sixth time doing it in Arizona, so thank you all for coming. And to kick off the meeting, none other than my very good friend, Dr. Corey Lappin. He is, you guys, a lot of you guys knew him from when he was here in Arizona. He really doesn't need an introduction, but for those online, of course, I'll read a small bio from him. Dr. Corey Lappin received his Doctor of Optometry degree from The Ohio State University College of Optometry. He also concurrently earned his Master of Science degree in Vision Science, and he was the class president. He then continued his training by completing a residency in ocular disease at the renowned Cincinnati Eye Institute in Cincinnati, Ohio. He has an amazing practice, and by the way, it just opened, so congratulations to Dr. Lappin. He just opened the Dry Eye Center of Ohio.
Yep.
Amazing. We're so proud of him. Yay! And of course, he writes a million articles. He lectures on this topic. He is a true expert on dry eye, and we're so lucky to hear from him today. Welcome, Dr. Corey Lappin.
All right, well, thank you, Stephanie. Thank you so much for that. And it's great to see everyone here. Obviously, this is like a homecoming for me, which is great. I love that I have my home away from home now. I kind of get to come back to this. So I'm super excited to kick things off here. I mean, dry eye in the desert could not be a more perfect dry eye setting for this. So we're going to get started here talking about practical dry eye pathways here. And this is such a cool lecture because we really get to dive into what was something that transformed how we manage dry eye, and that's actually looking at prescription dry eye medications with different mechanisms of action. That's the really cool thing here, and we're really going to dive into how dry eye is multifactorial and complex, and how we can target that with our different prescription options here. So first off, just disclosures here. I'm a speaker who's speaking on behalf of Bausch & Lomb. They created this speaker deck. There's not going to be any CE or CME credit given, but hopefully we do learn something along the way. And everything I'm going to be presenting is consistent with FDA guidelines. All right, so one of my favorite things right here, the first slide that we have stats on, you don't even see them yet. This is normally where you put the dry eye statistics slide, which is how many patients have dry eye. And guess what? Some people would say 5%, some would say 50, some would say 50 million. If you want to know how many people have dry eye, the answer is a lot. That's the stat you just need to know. Here out in Phoenix, the answer is basically everyone. Everyone has a degree of it. But these stats I like because I think they highlight more of the need and the current disconnect we have with managing dry eye. So the first one right here. On average, patients wait, about 2/3 of patients wait at least 6 months before they go see an eye care provider for their dry eye. Now I'm going to tell you something. I really wish my patients would come to see me because they think I have a sterling personality, they love my jokes, and they find me charming. That's not why they come and see me. That's what I wish would happen. The reason they come and see me is because they have tried everything they could do on their own to fix their dry eye, and it's not cutting it. And they now need me to give them something they can't get on their own. And trust me, why does it take them 6 months? Because they've tried everything that Dr. Google told them to do. And guess what? Dr. Google, he's on the way out. He's not cool anymore. It's Dr. ChatGPT now, by the way. That's who they like to listen to. But they've still done everything that ChatGPT has told them to do. They've walked down what I call the aisle of misery. So they've looked at every artificial tear. Make sure next time you're in the grocery store, you walk down that aisle and see that. They've tried every single one. So now they're sitting in your chair. They have tried everything. They're like, I need something more. And that brings us to the next point. 80% of patients who finally do get that diagnosis wish they had been diagnosed earlier. Makes sense, right? If you're suffering with something, you really wish you knew what was going on. I mean, we've heard it, right? A patient says, oh, my eyes are dry. It must be allergies. Like every allergies get blamed for everything. So this is where they need that diagnosis to really let them know what they're dealing with. This right here, though, this is the one I want to talk about, the disconnect right now. We have a lot of great artificial tears out there which are good for the comfort of the eye, but they don't necessarily treat the underlying condition. This is the disconnect. 88% of patients who are put on a prescription dry eye medication wish they had started treatment sooner. And that leads exactly to this next point. 90% of over-the-counter drop users would be open to a prescription if their doctor recommended it. I think this is where a bit of a disconnect happens. I think sometimes we think, man, I don't know if a patient wants to start this medication. They're going to be on it chronically. Would it not be easier just to put them on an artificial tear that they can pick up at the store? And what we see here is really, they're fine with this. They would want a prescription. 90%, if we would recommend it, would be open to it. So again, I like these stats because they really show us that need and the gap we currently have. Now, we also know kind of the whole paradigm of dry eye traditionally has been aqueous deficiency versus evaporative dry eye. And now I think we kind of know it's a mix, right? For the most part, they have some element of both. We do know that evaporative is much more common now. And you can kind of see with this diagram here. But really, what I always like to say is MGD is the biggest driver of modern dry eye, quite frankly. And the reason for that is screens. I mean, we all have our phone. We carry a screen with us all the time. We work on screens. Screen time has fundamentally changed the way we blink. So you guys know when we stare at screens, we're like, oh yeah, that's not great for your eyes. It can cause dry eye, right? But do you ever think exactly from a mechanistic standpoint why it causes dry eye? The one that most people would say that they can think of is, oh, well, you know, when you stare at a screen, you're not blinking as much, so your eyes are going to dry out. There's an element of truth to that. But if you actually look at studies, changes in blink rate aren't necessarily strongly correlated with dry eye. What is correlated with dry eye is blinking completeness. So when we look off into the distance, we're going to blink about 15 to 20 times per minute. When we look up close, that's going to drop to about 4 to 6 times. That's not a big deal if you're doing that for a couple minutes, right? Do you guys know what the average amount of screen time is right now? 11 hours per day. So imagine you're dropping your blink rate to that 11 hours per day. Here's the thing. Your body knows, I'm like, I need to blink, but at the same time, it's going to be hard to do work if you're constantly blinking, so you don't want to obstruct your vision. So our body strikes a compromise. And what that compromise is, incomplete blinking. A little bit. Kind of close them a little bit, but not all the way. The big issue with that actually is when we blink and the lids come together and touch, we get full contraction of the orbicularis oculi muscle. And back to anatomy. I know it's early, but yes, we are going to anatomy. The orbicularis oculi muscle, when you blink, it contracts, and right behind that is the tarsal plate. And embedded in the tarsal plate are the meibomian glands. So as you blink and it fully contracts, it actually compresses that and helps pump out the meibum. So when we flutter blink, the meibum builds up, it doesn't get expressed, and that's how we can get MGD. That's the reason this is our biggest driver right now. And we know if we don't get that good lipid layer onto the surface, we'll have that large evaporative element. So that right there is the big underlying reason we have that. I like to bring that up so we can kind of fully understand the impact of screen time on our patients. All right, so we know that evaporative dry eye is super common. How can we target this? How can we specifically address this issue? And this is where we get to talk about MIBO. How many in here have tried MIBO before? Okay, yeah, most people. I would ask the audience at home, and I'm going to assume your hands were up in the same ratio for this. So most of you have got to try MIBO at this point. So a little bit about MIBO here. So indication, it is perfluorohexyloctane, and it is indicated for the treatment of signs and symptoms of dry eye. So we got both here. It's not just one, we've got the symptoms and the signs. Now, it's contraindicated in a patient who has a hypersensitivity to that, so basically someone who would be allergic to MIBO. Now, I don't know about you. I don't know how many people have had previous exposure to perfluorohexyloctane. That was not MIBO. So I don't know if you do. Please tell me where they're getting in contact with it ahead of time, because I personally don't know. So as far as contact lenses, you should make sure the lenses are out when you use it, and you want to wait 30 minutes before you put the lenses back in after using a drop of MIBO. Its dosing is 4 times a day, 1 drop in each eye. It hasn't been studied in the pediatric population below the ages of 18, and overall, it's actually very well tolerated. We saw that the most common adverse reaction was blurred vision, and 1 to 3% of patients had some blurred vision and redness. All right, I love this slide right here. So when I describe MIBO to a patient, I tell them this is a water-free liquid that can stay on the surface for up to 8 hours. Do you know why I say that? Because that's very different than what they're used to. First of all, if you tell a patient it's a liquid and it's not water, that's not something they're normally used to, right? Most people are like, oh, I thought most liquids would be water. And then you hear it can stay on the surface of the eye for up to 8 hours. They're very intrigued because they're used to an artificial tear, what, maybe lasting 20 minutes if they're lucky. Most, it's probably more about 5. So the thing that's so interesting about it is its structure. So perfluorohexyloctane is this long chain of carbon atoms, and about half of them have hydrogen attached and half have fluorine attached. That hydrogen half is really attracted to lipids. the fluorine side is highly attracted to oxygen. So what happens is if you take a drop of this, you put it on the ocular surface, that hydrogen side is going to embed in the lipid layer of the tear film. The other one's going to go up into the air. And you can see up there, basically what you've done is you've added an extra anti-evaporative layer on top of your meibum, which is an anti-evaporative layer. So now you've basically got two anti-evaporative layers. So that's the fundamental idea behind MIBO, is that we are going to reduce evaporation. Makes sense, right? All right. That's great in theory. That's a theoretical thing. Do we know that it actually does that? How do we know it actually has this ability to reduce evaporation? I love this experiment for this. What they did is they took a container that was roughly the same volume as the ocular surface, they put some saline in it, and they put it on a scale, and they watched over time as its weight went down, right? Because the saline would evaporate, therefore you'd have less weight in the scale. That's how we got our baseline evaporation rate for saline. Fantastic. All right, so let's repeat the experiment. Let's take a drop of meibum from a healthy person. Let's do the same thing. Let's put it over top of the saline, and let's watch the evaporation rate. And what they saw was there was an 8% reduction in evaporation. Makes sense. That's what meibum's supposed to do. Okay, let's try again. This time, saline and 1 drop of MIBO. This was unexpected to me. 28% reduction. The reason why this is so unexpected to me is that MIBO actually did better than human meibum at reducing evaporation. That is incredibly rare that we see a synthetic substance outperform what our own body makes at its given task. So when I saw that, I'm like, wow, this is really, really cool. And then, of course, the last thing they did, let's see if we put it all together. You add some human meibum, let's put in MIBO, and they saw there was a 34% reduction in evaporation. So overmore, MIBO was 4 times more effective than human alone. So for me, I thought this was just a really elegant experiment to really kind of show, yes, this is reducing evaporation. So clinical studies. Remember, the whole goal of this is to make sure that a medication is safe and it works. So MIBO was looking, again, signs and symptoms. So they looked at corneal staining and they looked at patient-reported symptoms. The nice thing about this is now, too, we have a phase 4 study. So this lets us look at times that are longer and times that are shorter than what we would typically see. So you have your 2 weeks and your 8 weeks in the original Gobi and Mojave study, but we now even see how MIBO works at 5 minutes. So first off, from the pivotal studies, this is what we found. We're looking at total corneal fluorescein staining, and we wanted to see how MIBO did at day 57, primary endpoint, and day 15. So about 2 weeks and 8 weeks here. What they found was at about 8 weeks, there was a 2 times greater improvement in total corneal staining compared to the vehicle. Wait a minute, there is no vehicle. What do we compare this to, right? Because MIBO is 100% perfluorohexyloctane. What they actually used as the comparator for this was hypotonic saline. The reason I like to bring that up is hypotonic saline itself can actually help with dryness. So this wasn't like a neutral comparator. It had to outperform something that itself can be helpful for the dry eye. And what they found, again, there was a statistically significant difference at day 57. And even at day 15, week 2, we already had a statistically significant difference in total corneal fluorescein staining. Okay, so that's the sign piece of the equation. What about the symptoms? So what they found here was there was a 1.5 times improvement in symptoms. And again, even at week 2, it was already a statistically significant difference in symptoms. So many of you have probably seen that data at this point. We've had that around for now. Now the fun new data. I always like new data. My mind it wanders. I like new things. It keeps me stimulated here. So what we now know is, okay, let's take a look at symptoms as early as 5 minutes after you put in the drop here. And what they found was that when you use a single drop of MIBO here, and you wait 5 minutes, there was almost a 47% reduction in symptoms. It's pretty impressive. Now, however, I would see that and I would say, okay, well, I bet if I put in an artificial tear, someone's symptoms would probably go down about half, right, after 5 minutes. This next number is the key. They remeasured this at 1 hour. No more drops were put in. 1 hour later, the reduction was now over 56%. So it kept getting better. When you normally use an artificial tear, wouldn't you expect maybe that symptoms to kind of start coming back after time? This kept going down. And then with the repeat dosing, it got to the day 7 primary endpoint, it was down 61%. So for me, that seeing at 5 minutes, it's at half, and in an hour, it's an even greater reduction in symptoms. This, to me, is what makes this so unique as a treatment. And then, of course, is it well tolerated? Patients don't like to use medications if they don't feel very good. Best thing is there is no serious ocular adverse events with MIEBO. The discontinuation rate, this is what I consider the proof in the pudding, is whatever they experience bad enough for them to stop, 0.2% of people discontinued use. So you know that is not much at all. Here's my favorite thing about that number. Do you know how many people that was in the study? 1. And do you know what that tells me? There's always that one person. I'm hoping someday I get to go up and talk about a study where they had no discontinuations. We've all had that patient, right? There's always that one person, no matter how comfortable something is, that's going to be like, I don't know. So there's always that one, but you see here incredibly low. Even 0.5% had some burning or stinging. And the most common adverse event, though, was some mild and transient blurred vision at about 2%. All right, so that was the evaporative element of things. So remember, dry eye is multifactorial. So yes, we have things that are causing evaporation, but what about our patients who have a strong inflammatory component? We know that inflammation is a large part of dry eye. And for these, I like that we start out here with inflammation and autoimmunity. I'm going to go with our classic patient, our Sjogren's disease patient, right? We all see these patients. We all know it's a classic dry patient. These are patients who inflammation is a driver of their dry eye. Their autoimmune disease is going to cause inflammation that leads to dryness, so we have to make sure we get this inflammation under control. Otherwise, we're just going to be chasing our tails on this one. So, Xiidra. How many of you have used Xiidra? Okay, yep. That's why it's a good one. We've had it for a while. Most of us have had experience with Xiidra at this point. So first off, the important information, Xiidra is lifitegrast ophthalmic solution, 5%, again indicated for the signs and symptoms of dry eye. And it's contraindicated in patients who would have an adverse, you might have that hypersensitivity to lifitegrast. Clinical trials, adverse events range between 5 and 25%. You had some irritation, you had dysgeusia, that's that funky taste that you can get, reduced visual acuity, and other things they saw between 1 and 5% were some blurred vision, some conjunctival redness, eye irritation, headaches, some more tearing and lacrimation, a little bit of discharge, eye discomfort, some itching and sinusitis. Now, I also love this too. This is eye drop 101. I love that the FDA includes this. Guess what? You don't want to hit yourself in the eye when you put a drop in. Imagine that. You also don't want to touch it to anything that can cause contamination. I like that they decided to let people know, hey, don't hurt yourself when you put in your eye drop. Contact lenses with this. Don't want to have them in when you put in Xiidra, and you just wait 15 minutes before you put them back in. Xiidra is dose BID, so it's very easy to use with contacts. Put the drop in before your lens. Beginning of the day, pop out your lens at the end of the day, and then use it. Pediatric population has not specifically been looked at, and those below the age of 17. All right, so let's kind of look into the science here. So we know immunomodulators are going to have an effect on basically how our body deals with inflammation, right? That's the whole thing, our immune system, what these are working with. So what is lifitegrast specifically? The thing about lifitegrast I like to bring up is it was specifically designed, this molecule was basically designed to help with dry eye. That was its intention from day one. And what it does is it actually binds to this LFA1 receptor on T cells. Now, the way T cells were taught to us in school was they're basically the quarterback of the immune system, right? They're the one that controls everything. So what happens is if this LFA1 receptor binds to this molecule called ICAM, think of ICAM as like an anchor or a docking station. ICAM has higher expression on the surface of patients with dry eye and ocular surface disease. So what happens is if that T cell and that LFA1 receptor comes in contact and binds to that ICAM, it's going to activate it, and then you're going to get cytokines and you're going to get the inflammatory cascade. We know that that is going into overdrive in our dry eye patients. So what Xiidra does is it actually binds to that LFA1, so when it comes in contact with ICAM, it can't bind and dock. And because of that, it's going to prevent activation of T cells, but Xiidra actually works on both active and inactive T cells. We want that, right, for our patients because we want to deal with the inflammation that's present, but we want to also avoid stimulating more inflammation down the road. So that's the way that we're going to be basically getting that reduction in inflammation with Xiidra. Now with Xiidra, the nice thing is because it's been around for a while, we have tons of clinical data on this. So again, remember, signs and symptoms. And what we found is by week 12 of use of Xiidra, there's a 50% reduction in symptoms from baseline, and we saw that in OPUS 2, OPUS 3, so those were clinical studies. And then when we hop on over to the signs, for this wasn't total corneal fluorescein staining, this was inferior staining, and there was a 33% reduction by week 12 with OPUS 3. And then as far as the adverse reactions for this, one thing I always like to bring up is we also know with most of our immunomodulators, burning and stinging can be an adverse event, right? We all kind of know that. The big thing is talking to your patients ahead of time about that. You want to let them know, hey, yeah, this is something you can expect. The thing about this is when they looked at the studies, discontinuation rate, again, that's where the rubber meets the road. How many people thought the side effects were bad enough to stop the medication? 1% or less of patients on Xiidra actually felt the need to discontinue because of irritation or pain. So that really shows you, in general, it was very well tolerated. The biggest thing is to let your patients know ahead of time, because you know what happens if you don't. They call in the next morning, they're like, oh, yep, I'm allergic to the drop. I don't know why everything is magically an allergy if they don't expect it, but if they let them know, they're like, yep, my doctor told me about it. I know what's going on here. And less than 2% of patients discontinue due to a sight reaction, reduced visual acuity, or dysgeusia. Overall, though, well tolerated. So this is kind of the crux of this at this point. Our dry eye patients have multiple different things causing their dry eye, right? I mean, here in Phoenix, the environment's a big one. Screen time's a big one. So we need to make sure that we're addressing all the elements of a patient's dry eye to fully manage them. This is where education is huge. I really do think patients oftentimes want to know more information than what we think. They want to know why they're doing something. So I think we need to take it upon ourselves to educate them and let them know about dry eye. Let them know this is a chronic condition. It's not going to go away, so we need to manage this long term. For instance, you see a patient who has Sjogren's. You can let them know, hey, you have this inflammation going on, so I'm going to use this medication called Xiidra because I have to make sure I'm keeping your inflammation under control long term. You could have a patient who's a software engineer. They're staring at screens all day, and you look and you're like, your tears are basically evaporating after 2 seconds. We want to see 10 seconds. They're not lasting long enough. I'm going to use MIBO so I can keep your tears on the surface of your eyes longer. So let them know. Give them that rationale. They want to know why you're doing what we're doing. And the other thing is follow up with these patients. This is not a one and done. Most of my patients, I'm seeing a minimum of twice a year, and most of them I see 3 or 4, sometimes more times per year, because you really got to make sure they're doing well. So if you want to take a targeted approach and really look at the things that are causing someone's underlying dry eye, we look at something like MIBO. It's an easy first grab. We know that most of our patients will have that evaporative element to some degree. So we can use a medication that specifically helps reduce evaporation. We know that it's fast acting and long lasting. Those are the big things we want, right? You want quick onset and you want it to be sustained. We also want something that patients can tolerate. And the side effect profile for MIBO is excellent. So this is a reason why patients have really loved this drop. They find it very soothing. It's very easy to use. And then we've got Xiidra. Xiidra is phenomenal with managing patients with inflammation long term. And we see for this that it's going to be the only one that's targeting that LFA1 ICAM complex that really is driving that whole kind of inflammatory cascade. We also know that the dryness improves over time and it continues to build. And again, an excellent safety profile from we see from this. Now, big thing here, everyone's like, that's great and all, but can I get it for my patients? Because we all love mind-numbing paperwork, right? We all love PAs. That's our favorite part of our day, right? Oh, let's get all the work in here. The key to getting these medications for your patients is to use the partner pharmacies. Have you guys used BlinkRx before? This is the best way to do it. It's just, we're in a very complex system now. Coverage is changing all the time. The easiest way to help get your patients these medications specifically is to send them to BlinkRx. The reason for this is they are going to help you with the process, and they are really incentivized to help get your patients these brand name medications. Personally, I always tell my patients if I'm prescribing them, I tell them this is where we're going to send it because they are going to give us the best help. They're going to try to help you get it for the best price you can get, and we're going to get the best support. And then when they mail it directly to you. So if you explain to a patient again why you're sending it there, they'll get it. And the other thing is utilize your reps. Your reps are an amazing resource. If you're having trouble with this, don't struggle, just feel like you have to struggle on your own. Reach out to them. They're always happy to help you through the process to make sure our patients can get what they need. So thank you guys so much. I was really excited to kick this off here. I hope you enjoyed your breakfast. I hope everyone at home is also getting some breakfast and coffee because we got a really exciting day. So I really thank you guys all again, and I'm excited to keep going.
Dr. Lappin, there's a couple questions that came in online.
Oh, nice. I love questions.
How many times per day are you using MyBo?
So for me, I always recommend it that 4 times a day. The reason for that is all the stuff we saw in the clinical studies, that's what we know it's dosed with. So I tell a patient, I'm like, let's start with that 4. Let's really go with the dosing that we know. So I do always start at 4 times a day.
This is a good question. Where do you see the biggest gap between published dry eye guidelines and real world implementation?
That one, do we have time for an extra lecture? Yeah. I could do that entire lecture right here. What I think sometimes is I love getting nitty gritty with dry eye, but sometimes I think we make it overly complex. Even in the lecture I'm going to give, I actually talk a whole slide about that. I think a lot of times we just need very practical approaches. I think we need to keep things simple, because the one thing that tends to happen with all of us who are really into dry eye is we get into the weeds, right? And then when you get into the weeds, people start to wonder, what do I even do? Where do I start to get confused? So my biggest thing I often say, one of my philosophies, is the only wrong answer for treatment is to do nothing. That's the clinical gap right now is, I think, really getting like prescription treatments, using those more advanced treatments. And I think the reason for that is because of analysis paralysis. We're not confident in what to choose. And the beauty of something working or not working is, guess what? If something doesn't work, you can try something else. And again, just let your patient know what you're thinking, give them the rationale, and say, hey, we're going to start with this. This is what I'm thinking. But if we find that this doesn't work well, we can pivot to another one. So really, I think that's the big gap right now, is all the weeds, the details, when really just starting and treating is probably what we should be doing.
Are Xiidra and MyBo safe for pregnant women?
The great question here for this one. So they have not been looked at in the pediatric population for this. I once, my fiance's an OBGYN, and I asked her things. She's like, why would I know? I don't know this stuff. This is eye stuff. You guys know that. But really, this one is a tougher one, because I can tell you medications that aren't specifically for pediatric populations, they just don't look. So realistically, it's not that they're unsafe, but we don't know if they are safe definitively. Really, we just don't know. That's the thing. So always have that conversation with your patient. That's what I do. But we just don't know, because it hasn't been looked at.
And then last question. How do you assess and manage tolerability challenges with cyclosporine therapies?
For this, most of the time, I just tell the patient, let's start using this, and let's use it consistently for a duration of time. One thing I've tended to notice, have you guys noticed sometimes, like if a patient has a side effect, it tends to taper off after a while? Like it might be a bit more rough in the first couple weeks. For me, for tolerability, I tell them I normally want to see about a month or so of consistent use. Because most of the time, at least in my experience, if something has some irritation, by week 2, it will start to go off a little bit. However, if I find that it's persistent, then we might make a change. But really, I want to see them using it consistently to see if it's more of just a front-end issue.
Awesome. Thank you. All right, let's give Dr. Lappin a round of applause. Thank you so much. Okay, so next we are going to migrate out the door. Katie is standing at one of the doors, and then outside, and Dr. Morrison is going to give us a presentation and demonstration on the Zen lens. So let's migrate out there, and then we'll be back here in about 30 minutes for Dr. Lappin's CE lecture.
contemplating in our conversation if we could start something new. Oh, I wanna get deep, babe. We got chemistry, and small talk's only wasting time. Oh, I need to get closer before it's all over. You can tell me what you like, but we should jump right into the personal facts. I wanna get to know you like that. So maybe we can leave this party or sneak out to the back. I wanna get to know you like that. So we should jump right into the personal facts. I wanna get to know you like that. So maybe we can leave this party or sneak out to the back. I wanna get to know you like that. You have just recovered from a broken love. I put it all on display. I've gotten over the other one before you, so nothing stands in the way. Oh, I wanna get deep, babe. We got chemistry, and small talk's only wasting time. Oh, I need to get closer before it's all over. You can tell me what you like, but we should jump right into the personal facts. I wanna get to know you like that. So maybe we can leave this party or sneak out to the back. I wanna get to know you like that. So we should jump right into the personal facts. I wanna get to know you like that. So maybe we can leave this party or sneak out to the back. I wanna get to know you like that. I wanna, I need to get closer before it's all over. You can tell me what you like. So we should jump right into the personal facts. I wanna get to know you like that. So maybe we can leave this party or sneak out to the back. I wanna get to know you like that. So we should jump right into the personal facts. I wanna get to know you like that. So maybe we can leave this party or sneak out to the back. I wanna get to know you like that. Oh yeah. I wanna get to know you like that. I wanna get to know you like that.
Well, you must be a girl with shoes like that. She said you know me well. I've seen you, little Stephen and Joanna around the back of my hotel. Oh yeah. Someone said you was asking after me, but I know you best as a blagger. I said, tell me your name, is it sweet? She said my boy is Dagger. Oh yeah. I was good, she was hot, stealing everything she got. I was bold, she was over the worst of it. Give me gear, thank you dear. Bring your sister over here, let her dance with me just for the hell of it. Well, you must be a boy with bones like that. She said you got me wrong. I would've sold him to you if I could. I just kept the last of my clothes on. Oh yeah. Call me up, take me down with you when you go. I could be your regular belle. And I'll see dance for little Stephen and Joanna around the back for the hell of it. I've been trying to call. I've been on my own for long enough. Maybe you can show me how to love. Maybe I'm going through a drought. You don't even have to do too much. You can turn me on with just a touch, baby. I look around, since city's cold and empty, no one's around to judge me. I can see clearly when you're gone. And I said, ooh, I'm blinded by the lights. No, I can't sleep until I feel your touch. I said, ooh, I'm drowning in the night. Oh, when I'm like this, you're the one I trust. Hey, hey, hey. I'm running out of time, 'cause I can see the sun light up the sky. So I hit the road in overdrive, baby. Oh, city cold and empty. No one's around to judge me. I can see clearly when you're gone. Ooh, I'm blinded by the lights. No, I can't sleep until I feel your touch. I said, ooh, I'm drowning in the night. Oh, when I'm like this, you're the one I trust. I'm just looking back to let you know I can never say it on the phone. They'll never let you go this time. I said, ooh, I'm blinded by the lights. No, I can't sleep until I feel your touch. Hey, hey, I said, ooh, I'm blinded by the lights. No, I can't sleep until I feel your touch. I gotta tell ya, sometimes she gets moving real slow. And if we have the afternoon, well, baby, there's no telling where we go. Yeah, couples out there loving, I see them on my phone, but I don't have a sweetheart to hold when I'm alone. So I just grab my keys and snag my favorite seat. Cruising mine, it's just me in the front seat. She's so sweet, my honey in the summer. never been quite the same. There's a haze on the horizon, babe. It's only been a couple of days and I miss you. Yeah, nothing really goes to plan. You stub your toe or break your can. I'll do everything I can to help you through. If you're feeling down, I just wanna make you happier, baby. With sorrows around, I just wanna make you happier, baby. We've been doing all this late night talking about anything you wanna till the morning. Now you're in my life. I can't get you off my mind. I've never been a fan of change, but I'd follow you to any place. If it's Hollywood or Bishopsgate, I'm coming too. If you're feeling down, I just wanna make you happier, baby. With sorrows around, I just wanna make you happier, baby. We've been doing all this late night talking about anything you wanna till the morning. Now you're in my life. I can't get you off my mind. 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 I won't even try. To get you off my mind. We've been doing all this late night talking about anything you wanna till the morning. Now you're in my life. I can't get you off my mind. Can't get you off my mind. Talking, can't get you off my mind. Talking, won't even try. Talking, can't get you off from all this late night talking.
Rose-colored boy, hear you making all that noise about the world you want to see. always take it there. Gonna lose it, don't you dare. I can't take me anywhere, no. Don't freak, you don't gotta cause a big scene. They don't wanna see you now. You just gotta do what they told me. Can't sleep 'cause all my brain does is overthink. Scared I'm gonna end up alone. They just gotta do what they told me. We don't gotta feel a thing, but we can fake it. Ask each other how we're doing, just a lie. And if I cut up on my hair, would I feel less like I wanna disappear? Just another day I'm trying to get by. Overthinking, God, I swear. Why I always take it there. Gonna lose it, don't you dare. I can't take me anywhere, no. Don't freak, you don't gotta cause a big scene. They don't wanna see you now. Dude, just gotta do what they told me. Can't sleep 'cause all my brain does is overthink. Scared I'm gonna end up alone. They just gotta do what they told me. Just gotta do what they told me. Just gotta do what they told me. Oh, na na na, na na na, baby. Just gotta do what they told me. Something else better for me. Just gotta do what they told me. Just gotta do what they told me. Just gotta do what they told me. Just gotta do what they
When I'm with you, it doesn't matter where we are or what we're doing. I'm with you, that's all that matters. Time passes much too quickly when we're together laughing. I wish I could sing it to you. Oh no, I wish I could sing it to you. Oh, 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 mostly I'm silent. Silent. La, 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 la. Never think of the right words to say. When I kiss you, I feel 1,000 different feelings. Color of chills all over my body. And when I feel them, I quickly try
All right, everyone, welcome back. Just a couple housekeeping slides before we get into our first CE event. Oh. Well, I'll just go through them. It's fine. So this is our first time in this venue. So people are always asking about the bathrooms when you're in person. They are right up at the front when you came in to the left. So when you need to go to the bathroom, just go right up to the front. If you need anything as far as have questions about anything regarding the venue or the CE or need anything while you're here, Katie and Hannah from the Woo U team are in the back, if you could just wave your hands. And I would also like to say that they are the ones that actually planned this entire meeting for the past year. So thank you to Katie and Hannah for being so amazing. And then there are going to be over 1,000 people online listening in, so just kind of limiting the amount of chatter and just being mindful of like silverware clanking around, stuff like that, just so we don't hear a lot of that online. And yes, we will welcome back Dr. Corey Lappin.
All righty. Thank you. All right, so time to get started with the CE portion of things. So everyone get comfortable. We got 2 hours of all dry eye here. So I like to say that this lecture is kind of my State of the Union address on dry eye. So we are going to cover a bunch of things. Make sure you have plenty of coffee, plenty of water. I have mine. I am both caffeinated and hydrated here. So before we even start in, fun fact, the relationship between hydration and caffeine and dry eye is actually incredibly complex. I don't know if you guys knew that. However, they always say, drink all your water, right? Here in Phoenix, we should. When you actually have higher water intake, there was a study, they found that patients who drink more water actually tended to have more dry eye symptoms. Not causation, correlation. They think that patients with dry eye tried to fix it by drinking more water. The reason for that is because water alone seems to not have the same effect as water with a certain blend of electrolytes and other things. So hydration is important, but make sure your patients are also getting the proper amount of electrolytes. I think in Phoenix, Arizona, we know that is a very important thing. So I always like to lead that. So sometimes hydration is a little bit of a complex thing. And also caffeine seems to be a dose-dependent thing. Some studies have showed that caffeine can help a bit with dry eye. Some say it could be more dry eye. That's a complete tangent before I even started. I haven't even got to the introductory slide, so there's your mini tangent. All right, so we're really going to be talking about all aspects of dry eye here. So we're going to be talking about diagnostic technology. We're going to be talking about over-the-counter treatments, and we're going to be talking about prescription therapies, in-office procedures. So let's get started here. So first off, here are my financial disclosures. I'm fortunate to work with a lot of great companies. All right, let's start at the beginning. Now, I'm sure all of you guys have much busier social lives than I do, because I've at this point probably read through about all of these 3, which says more really about my social life than anything. So it is a weighty tome, but this is kind of what we always look to, right, to give us our general guidance on dry eye. And we now have an updated definition of dry eye. So we're going to just walk through it here. So dry eye is a multifactorial condition, right? Nothing new there. We all know that, very aware. A symptomatic disease, we're going to talk about that in a moment, characterized by a loss of homeostasis. Yep, good. We always love to keep homeostasis. And of the tear film and or ocular surface, good. We like that here, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, all old things, and neurosensory abnormalities. This is a big one. This is one that's often overlooked, are etiological factors. Now, the reason I italicize symptomatic here is because this is an interesting inclusion here, and I think I know the intention, but I think we need to understand the nuance of this. Raise your hand here if you have seen an asymptomatic dry eye patient. I have too. So with this new definition, if you go by it by the strictest sense, it would say if a patient does not report symptoms to you, they do not have dry eye. I think we can be missing some patients if we go off of that. So really here, the whole intent of this is more so for you to make sure you're not missing other conditions that are related to dry eye, but may not be dry eye proper. So I'm going to dive into that more here too in a second. So diagnostics, this is just a brief overview of what I would say are some of the most common diagnostic tests that you can use when treating ocular surface disease. Now, I know this isn't exhaustive. There's a lot up here, and there's many more of them, but these are the ones that I've used, and I think they're going to give you a lot of high-yield information. So I have now simplified. I just worked on generating this diagram. This is DEWS 3's diagnostic criteria. It's actually an interesting fact. Did you know there has never been a consensus criteria for dry eye diagnosis? It was kind of always been like, what's dry eye? You're like, I know it when I see it. This is what DEWS 3 proposed. So I'm going to go through this, and I'm going to give you my thoughts on it. So first, because again, they think that dry eye has to be inherently symptomatic, they say start with the OSDI-6. So this is a questionnaire. The original OSDI, which you guys are probably familiar with, had 12 questions. This 6-question version is actually found to be just as reliable and actually is more repeatable. So they recommend using this because it's shorter. If you get a score of 4 or more, then yes, you are considered symptomatic. If you do not, it says you don't have dry eye. I added this. This is my own thing. If you want to use this framework, you consider that patient a dry eye suspect. Because let's say they have a 3. So what? They just magically that cut off, they don't have dry eye? This is a dry eye suspect. That's what I would say if you use this framework. All right, so let's say they do have that 4. Now the second thing is they now have symptoms. You now have to find a sign, and then you have your diagnosis. And there's 3 different pathways you can do this. The first one is tear film instability. So you can use a non-invasive tear breakup time, and we're going to talk about non-invasive testing. If your score is less than 10, that means you now have dry eye. If you use fluorescein and it's less than 5, it's dry eye. Why is the number different? It's because when you put fluorescein on the surface, you disrupt the natural tear film dynamics. So that's why they use different cutoffs. The other one is hyperosmolarity. Now, so how many of you guys use osmolarity testing in your clinic? It's a few. So this is something where I bring this one up. I'm glad they have different avenues because a lot of people don't have osmolarity testing. And we definitely don't want to have that be a requirement because a lot of people could not use this framework then. But if you have a value of greater than 308, or you have an inter-eye difference of 8 or more, of more than 8 between the 2 eyes, then it's considered a sign of dry eye. And then this next one here is probably our easiest one to use, staining. If you have corneal staining, 5 or more spots, conjunctival staining, more than 9 spots, or lid margin staining of greater than 2 millimeters or 25% of the width of the lid margin, you now have dry eye. I'm going to simplify this. Again, we had that question earlier. It's like, okay, I think this is a decent framework. It's not overly complex, but I think in the busy clinic, we can make this easier. Symptoms, does the patient say they have symptoms, yes or no? You're done right there. They'll tell you. Questionnaires are great, but you don't have to do one. Yes, I have symptoms. Then do a non-invasive tear breakup time or any amount of staining, you're done. I'm not counting spots because once you have staining, you now have surface damage. So to me, any level of staining is dry eye. So my simplified version of this is patient complaints of it, or I see staining, or they have a tear breakup time of less than 10. That's super easy for all of us to do in the clinic. So that is my version of how I would do diagnosis. All right, so questionnaires. How many of you guys use questionnaires? Okay, yeah. I think they're a good way. Their biggest strength, honestly, is to take subjective symptoms and quantify them. All of these are good. If you look at clinical studies, SPEED, OSDI, DEQ, the SANDY, all of these are ones that have commonly been used. So this one I have down here is actually a bit of a unique thing. It has these questionnaires, but it's called CSI Dry Eye Software. Has anyone heard of this? Okay, yeah, a few. So basically what this is this is a program where you take all your information you collect from your patient and you put it in, and it also puts things in like humidity, temperature, puts in all their medications, and based on the information you put in, it basically goes through the literature and it suggests, based on what you told me, this patient probably has this going on. So it really is just checking all of a patient's symptoms. What this does is this is a great data aggregator. It takes what you collect and puts it into a very digestible thing for both you and your patient. So just kind of a unique software. All right, now with diagnostics, let's start with the good old-fashioned meibography. This is probably this is like the granddaddy of them all, right? For testing when it comes to dry eye, when you have something dedicated here. The thing I like to talk about meibography, throughout this, I'm going to talk about glaucoma with comparison. When we are looking at someone with glaucoma suspect, we do the OCT to look at nerve structure, correct? That's what we're looking at. We want to see the thickness of the nerve fiber layer. We want to make sure that we have a good structural picture of the nerve. This is your structural aspect for the meibomian glands. Now, this is a great start, but I will often tell people who want to build a dry eye clinic and they're like, I want to get my biography, it is only the start. Because if we're treating glaucoma well, we theoretically should not see a change on the OCT, right? Like if it's well managed, it should stay stable. If we are treating dry eye well, we should not see a change on this. The reason I bring this up is because if this is, you're building this out and this is the only diagnostic test you brought in, you can be showing patients the same image like month after month because really we shouldn't see much change. Also, when it comes to regeneration on my biography, you can get some, but I always say for those who might be new to this, regeneration isn't going to be a gland that's gone. So you see down there in the lower left eye, you see how there's that completely kind of like grayed out area? Glands that are completely gone will not come back. You cannot create something that's completely gone. But look up at the upper one for the upper right. Do you see how there's those kind of hazy, grayish looking glands? We often call those ghost glands. Those are the ones you might be able to recover more structure for. So when we talk about recovery, don't expect glands to magically reappear or get super long. That's why I try to make a very reasonable expectation. When I show my patients my biography, I tell them, our goal for you is stability. That's our goal. If we get a little bit of improvement, fantastic, but the goal should be stability. All right, tear meniscus height. I love tear meniscus height because it's a non-invasive way for me to look at tear production. So tear meniscus, as you see here, it holds 70 to 90% of the total tear volume on the ocular surface. And again, I love non-invasive testing because I don't want to touch the eye. I want to see how it's functioning without me doing anything to it. So I really like this. Every one of these images I'm showing you so far, these are taken from an ocular surface analyzer. You by no means have to have one of these to treat dry eye, trust me. But if you're someone who's like, yeah, I really want to dive into this, these things are phenomenal because these are great for patient education tools. And then you can see here, they give you great values that you can show them. Tear meniscus height should be between about a 0.2 and a 0.5. If you're below that 0.2 millimeters, you're worried that you might be underproducing tears. If you're above a 5, it might sound great, right? Oh, good, plenty of tears. You actually might be getting into reflex tearing territory. So this is why you want that here, and that's why you see this meter. I like how this one's color-coded. You can see when it's down all the way, it's red, but you're even yellow when you go above because now we're like, I don't know, that might not actually be a good thing. All right, blink analysis. Kind of gave you a little bit of a prelude to this earlier when I was talking about how screen time is affecting us with dry eye. So remember, everyone thinks about blink rate. But why did I say that blink rate tends not to be very closely associated with dry eye? And that's because changes in blink rate are bidirectional. A change in blink rate, regardless of which direction it goes, can give you a clue that you might be dealing with dry eye. Because this tends to be what happens. When dry eye starts, you tend to have a reduced blink rate, right? You're not blinking as much. Then the eyes start to dry out more, and guess what you do now that your eyes are drying out more? You blink more to compensate. So both directions can indicate dry eye. That's why it's not as easy for you to say, oh yes, they have a higher blink rate, they have a lower blink rate, these mean dry eye. Either one that's abnormal can be a sign of dry eye. However, incomplete blinking is heavily associated for the reasons I mentioned. You need that complete contraction of the orbicularis. You need to compress the tarsal plate with the meibomian glands embedded in it. With the complete blink, the lids come together, pushes out the meibum. Versus partial blink, partial blink, partial blink, you build up the meibum, it becomes stagnant because it never gets released. You get obstructive MGD. Now in this particular case, I get a readout here, blink count. Okay, so right eye, 13 blinks. Left eye, 31. Okay, I think one of these eyes probably is having some irritation, right? 31. Okay, let's take a look at blink quality now. How complete are the blinks? All right, partial blinks, right eye, 4. Not too bad. Partial blinks in the left eye, 22. That eye is blinking more because it's irritated, but the bigger issue is it's a bunch of flutters. You guys have seen that, right, before? You see that patient where they're like constantly, it's almost like, I think like a hummingbird flapping its wings, like rapidly blinking, but the lids aren't coming together. You don't need an ocular surface analyzer to do blink analysis then too. Easiest way to do it when you're doing your patient history, look them in the eye and watch their blinking behavior. The easiest way also, I think, to look for complete blinks, because that's a little bit harder when you're at a distance, when you're behind the slit lamp, do not put the light directly in their eyes because obviously that will change their blinking. Kind of put it on the bridge of the nose so it's not in there. and just kind of see as they blink, see if they're getting that completeness. Those are very easy ways to check for this. Lipid layer interferometry. I love this. This is the functional piece to mybography. Mybography gave us our structure. Now we're looking at meibomian gland function. So the lipid layer interferometry is going to give us lipid layer thickness. So we typically want to see at least about 80 nanometers to 100. That's what we're going to consider normal for this. If it's below that, we might be worried the meibomian glands aren't producing enough oil, or the oil quality may be poor. So this does also give us structural information about the tear film structure, but I like to think about this function of the meibomian glands. This is that second piece. Lipid layer interferometry with mybography gives you a very robust picture of what's going on with the glands. So also, I know Dr. Zagelbaum's back there too. What do we like to look at this besides just that number? Quality. And the way we do that is, do you guys see that reflex right there, that kind of reflection? Can you appreciate how there's like kind of like an oil slick-like appearance? Like, well, I mean, out here when it rains twice a year, you know, you actually can kind of see the oil building up and you see that. That's what we want to see. We want to see that oil slick-like appearance. This patient has poor lipid layer. So this one here, the 100 plus we like to see, he's in the 60s. Do you see how flat matte that is? Do you guys see any of that oil slick-like appearance? No, you just see that flat white. So even just looking at the quality of that, you can tell he's not producing a lot of oil. Obviously, this is going to come to a shock when you look at that redness. He has severe ocular rosacea. So this is just to give you a difference between what you're seeing when you're looking at lipid layer thickness and quality. All right, tear breakup time. Oldie but a goodie. Easiest way for us to do this, throw some fluorescein in and you look for that first breakup area, like kind of black-like appearance, easy to do. Non-invasively, I like this because this map you see up here, this is a map of the cornea, and all the green areas are where it's making it to a normal breakup time at least. And then it gets darker red the less it goes. So I like about these ocular surface analyzers, you get both first and average time. First is what we look at, obviously, clinically. We know that's what we record. But in my experience, average breakup time tends to correlate more with patient symptoms. Again, that's not published. That's just what I've noticed. So I like being able to look at first and average breakup times. I just say, I like to stick with the old 10 for that. I like to keep things simple. 10 seconds, that's your low normal. Below that, you're worried about dryness. And then this is all you need, guys. Realistically, a fluorescein strip. This alone will allow you to do most of what we need to do for dry eye. And the thing about it is it gives us so much information. So obviously if we see staining, yeah, we know we have ocular surface damage, but where is the staining? The location, the pattern tells us things. So this one down here, inferior staining, is there any other specific things you guys see here that looks abnormal? Yeah, a little bit of the conj staining here. The big thing, and I'm going to talk about this too, look where that lower lid margin is. Way down low. And where's the staining? Quite frankly, more or less where that lower lid should be. This is a patient who has chronic exposure because they have excessive lower lid laxity. That is a huge issue. That is a big driver of dry eye. One, because the surface is going to be drying out. And remember what I talked about blinking? If this person has low lid laxity, they're not getting a good quality blink. So they're also getting all of those MGD issues I talked about as well, and this compounds. But here you see that immediately. You know that this patient has been dealing with this for a while, right? This is not mild staining. This is significant staining. Did you guys take photos? I love taking photos. I mean, I can write all day long, or I can literally show a picture. From a documentation standpoint, it's phenomenal. And an education point, I love it. And here's the thing. Yeah, I've got slit lamps that have a dedicated camera on that. I also love a good iPhone. You can get these cheap adapters, get yourself a refurbished iPhone online, put a password on it, make it HIPAA compliant, and that can be your camera. I just really think, I mean, all of us, how many in here have wide field retinal imaging of some sort? Yeah, everywhere I go, everyone, you know what? I'm sick of the retina being the star. Let's give some love to the anterior segment. Let's get some anterior segment photos out here. It's beautiful too. It deserves pictures. So I'm a big advocate for doing this too. Remember, you can also bill for these too. These are things just like you can bill for retinal photos. You can also bill for anterior segment photography. All right, another big thing. So now I'm going to move into what I would say my clinical exam would be just at a basis. So I like to look at the ocular surface from the outside in. So I'm going to start with the lids and the lashes. So first thing that I do, I have a patient tilt their chin up, and I say, gently close your eyes like you're going to sleep. I then take a transilluminator, go up underneath, and I look at that interpalpebral region. And what I'm looking for is that lower image. What do we see there? lag ophthalmos, right? You see that white showing through, the lids aren't closing all the way. Easy peasy, slam dunk. However, that's part one of the test. So the core Blackie light test is a really easy test that gives you a lot of great information. Just because the upper lid and the lower lid touch does not mean you're making a complete seal. This is separate from lag ophthalmos. Lag ophthalmos is the lids are not completely touching. A poor lid seal or an incomplete lid seal means the upper and the lower lids do come together and touch, but the upper lid kind of just gently drapes or sits. Sometimes it's like an overbite, and it will look like they're closing their eyes. But if you take that transilluminator, put it on the upper lid, and you see light rays emanating from between, that means you don't have an airtight seal, and they will have every single issue that a patient with lag ophthalmos will have. Why do we want to look for this? There's a paper that was published that found that 60% of patients with refractory dry eye, those who weren't responding to traditional dry eye treatments, had some level of incomplete lid closure or some lid closure issue. So we want to make sure we're not missing this as if this is a primary driver. Easy way to look for it is doing these tests. All right, other ways to look at lid laxity. These ones you can do behind the slit lamp, super easy. So the lower lid distraction test, if you take the lower lid and you pull down on it, now you don't have to yank on it, just find a natural stopping point. If it pulls down more than 6 millimeters, which you can use, your slit beam to measure, that's considered excessive lid laxity. Now, measurement takes time. The easier thing is, how about you just pull it down and you let it snap back? That's the snapback test. That lid, when you pull it down, should take at max a second to go back. But every one of you knows what I'm talking about, right? When you pull that one back and it kind of like just slowly retracts. If it takes more than a second, you have excessive lid laxity. And we obviously had talked about blinking behavior, blinking assessments already. All right, I'm talking a lot about lid position, and that all is related to, again, lid laxity or blinking. I've kind of mentioned our blinking dysfunction is a main driver of modern dry eye, I would say. Now, this is the easiest one. You're like, okay, well, yeah, but I'm busy. I see patients every 15 minutes. I don't know if I can take time to do a lot of these tests. This one requires you to do nothing different than look at the eye. And I am really big at looking at our base anatomy because it tells us so much. What every single one of us in this room, I guarantee you, is good at is looking at upper lid ptosis. We are phenomenal at that. We catch ptosis all the time. The upper lid margin should be about 1 to 2 millimeters below the superior limbus. What we are not good at doing is looking at the lower lid. So this is what we should see. That lower lid margin should be at or slightly above the lower limbus. So often we see this. See the sclera there? This is called inferior scleral show. We should not see sclera between the lower limbus and the lower lid margin. This means either the patient has lid laxity, there's lid anatomy changes, or they might have a proptotic eye. I would say this next week, I want all of you to look at every single one of your patients, look for this. You will be shocked at how common this is. So this is a big one. This is the easiest way to look for lid laxity or lid abnormality. Look for this inferior scleral show. I mean, even look at this patient. Look how red it is in that area. That is an area that should be protected. And the other thing about this also disrupts the tear lake. That tear lake should be right up here. Now it's pulled down. It's just tear film dynamics go out the window with this. All right, and then while they're looking down, look for everyone's favorite garbage on the lashes right now, good old-fashioned collarettes. This one is so easy. You see this, you're dealing with. What are we dealing with? Demodex. We say it all together here. I feel like I'm on Sesame Street for this. The word of the day is collarette. C is for collarette. We all got that now. This is the mite eggs, waste, and their garbage. We see this. We know we're dealing with Demodex. And what do you see on this lid margin down here? This other one. Telangiectatic vessels. Often consistent with ocular rosacea, one of the most overlooked but common conditions. You looked at this. So, I mean, at this point, if all our patients had this, we have now diagnosed about 6 different conditions. We haven't even looked at the eye proper yet. We're looking at the lids and lashes, and we're in deep already. So this is just showing you how much information you can get simply looking at these. All right. This is one I will honestly tell you I was guilty of. For a long time, I felt like I really overlooked the lacrimal drainage system. What really challenged me to rethink this is the fact that epiphora is one of the most challenging things we deal with. Epiphora itself can be multifactorial. So if a patient complains, my eyes went dry, they water all the time. We've all heard it, right? We know oftentimes that can be reflex tearing. Yeah, so you can get a reflex tear for dryness. But let's say you treat their dry eye and they still have epiphora. All right, so now we're thinking about the drainage system. Remember, this drainage system is not passive. It is not a giant manhole that the tears just passively run into. This is active. Every time we blink, there is capillary action. The tears are actually sucked off the surface. They don't just passively go down the drain. So if a patient has epiphora, the first thing I want you to do, Look at the punctum. Is it scarred over? That's an easy one to look at. Or look at this patient. Where is it facing? Are either of these actually adjacent to the ocular surface proper? No, this is punctal tropion. The puncta are actually bowing outward. These cannot suck the tears off the surface because they're not in contact with the tears. So of course this patient would have epiphora. All right, the other thing I like to do, punctal palpation, just gently push on that area. Look for regurgitation, look for excess mucus, look for any kind of junk coming out, because sometimes patients can be getting this low-grade kind of like infectious-looking thing, especially with a poor tear quality, and you just want to make sure you're not overlooking that as the source of inflammation. All right, so one of the big things we want to do is we want to make sure that this entire structure is clear. So now let's say a patient has epiphora, you're like, okay, I don't think this is reflex from dry eye. How do we evaluate that? Well, thankfully, we have the Jones 1 and Jones 2. Again, when I was a student, I thought this was super complex for some reason. And this diagram makes it simple. I love this diagram I found. So basically, Jones 1, this is called a physiologic test because all you're doing is putting fluorescein on the eye, waiting about 5 minutes, and have them blow their nose and see if they get fluorescein out. If the fluorescein comes out, the system is open. If you don't get fluorescein, okay, now something isn't open at some point, and you move to Jones 2. Jones 2 is non-physiologic because this is where you're doing a saline irrigation. So this is where you're forcing it through, and because that obviously does not naturally happen, this is not physiologic. And what happens is if you force the saline through and now they do get fluorescein on the tissue, what this typically means is there is stenosis of the nasolacrimal duct. Because what you're doing is you're able to force it open with that high pressure. Now, this doesn't mean it's functional. This just means that you can force it open. If you get nothing, now you have obstruction somewhere in the system that can't be forced open. That's really what it is. I can tell you my number one referrals in the dry eye clinic actually come from oculoplastics when we can't fix this. Because I'm like, okay, now this is beyond what we're able to do. Sometimes these patients need a DCR. But I bring this up because epiphora is a tough bear to tackle. So that's why I bring this up. And this is a really easy thing to do in your clinic. Also, technically, if we want to be pedantic, because that's fun sometimes, dilation and irrigation is technically different than a Jones test. Even though you're doing the exact same procedure, a Jones test is a diagnostic test. Dilation and irrigation is a therapeutic intervention. That's the difference. Exact same thing, but it's pedantic. It's fun to be pedantic sometimes. Corneal sensitivity testing. So this right now, a great tech up here who's taking one for the team to demonstrate corneal sensitivity testing. How many of you guys do corneal sensitivity testing? Okay, so since I have a dry eye clinic, I test every single patient. I know that's not practical for every single patient. What I would recommend for this is all of your dry eye patients at least consider testing it, or if there's a patient who you think might have any form of nerve damage, whether it was a herpetic infection, they've had LASIK, I really think we should test this. Remember when we went to the whole definition of the neurosensory abnormalities? This is this right here. Let's say, okay, you guys see the cord coming off the screen up here? Let's say I cut this. Would the TV work? No. Okay, so what if I decided, you know what, man, that cord's cut, I'm going to change the screen. Is that going to fix the problem? No. Let's think the eye, the same structure. The corneal nerves, the nerves in general, the trigeminal nerve, all the nerves, that is the wiring of the eye. Doesn't matter what I do to the cornea and conj, if the wiring is cut or the wiring is dysfunctional, I can mess around all day with the front surface of the eye. It will not improve. So this is why we want to make sure the nerves are functional for our ocular surface disease patients. That's the big thing. Think of it like a screen. You cut the wiring. Until you fix that wiring, nothing's going to work. So ways to test corneal sensitivity, you can do it quantitatively. You can use a good old Cochet-Bonnet anesthesiometer. We had one, but we never used it because, I mean, how many of you guys have a Cochet-Bonnet? Yeah, most people. Well, yeah, it's Andrew, you had ours. That's my Cochet still. That's mine still, I consider. So Cochet-Bonnet, you have that. Now, the other one is also the Brill Engines anesthesiometer. That's a new one. It's basically like a calibrated air puff, which is great because it's non-contact. Here's a fun piece of trivia. The first corneal anesthesiometer, horsehair. So if any of you ride horses and you're like, oh, well, I want a discount thing. No, don't do that. But that was the first one, was a horsehair. Easiest way to do this, though, a good old cotton swab. Just take it like you can see here, twist the end, and then just touch it to the surface. Some people like to use dental floss. For some reason, if you really dislike your patient, you can use capsaicin. So yeah, basically putting hot sauce in their eyes. You'll know if they have sensitivity, that's for sure. Would not recommend it. The thing I would say, though, is this. Again, I understand you have a busy clinic. If you have a patient who you are really suspicious for nerve dysfunction, a neurotrophic keratitis, a reduced or absent corneal sensitivity, always test centrally, and if that's normal, test every other quadrant. Ideally, you would do this for every single patient regardless, but if you want a good protocol for doing this in a busy clinic, start there and work your way around until you can prove everyone's there, because if you don't, you can miss focal reduction. I've had a patient who is normal in every quadrant but the inferior one, and that often can be missed. We have 7,000 nerve endings per square millimeter on the surface. It's the most densely innervated structure in the eye. So it would make sense that some would be functional and some could be reduced, right? So that's my kind of pearl for that. Okay, prepare cane challenge. This is the flip side. So our corneal nerves can either become desensitized, less sensitive, or they can become hypersensitized when they're damaged. These are patients who, if you and I would walk out today, there's that gentle breeze, we might feel it, but our eyes probably don't notice it. These patients, a gentle breeze will be painful. Stimuli that should not cause pain, and stimuli that normally cause pain out of proportion to what they should cause. So this can be central or peripheral. A peripheral neuropathic pain is where a patient has the corneal nerves are damaged and the pain is coming from those nerves. Centralized is a lot more difficult. That's where the pain has become chronic, or they've had an injury at the level of like the brain or brainstem, and the pain actually comes from the brain. The most difficult thing these patients deal with, spontaneous pain. What that means is they get pain that is generated from the brain or the nerves itself. There is no external cause of it. That is tough. These are the patients when they ask, they're like, so basically is this pain in my head? I say, yes, the pain's in your head, but that doesn't mean it's not real. That's normally when they start crying because they understand that their brain itself is causing pain. So one way you can know if you're dealing with peripheral or regular dry pain or maybe centralized pain is the Prepare Cane Challenge. Ask your patient beforehand, okay, what's your pain on a scale from 1 to 10? Let's say they say it's an 8. Okay, put in the drop of Prepare Cane, you ask them again, what's your pain level? 0, it's great. Okay, so I now know the pain's at the surface, right? Because we just cut off the nerve transmission there. So they might have some peripheral neuropathy there, but that's treated the same way as regular dry eye. You're trying to repair those nerves. Okay, let's say they say, well, okay, my pain's about a 4. Okay, it's mixed now. They have some peripheral external pain, but there's still a pain generator that's outside of the eye. Now let's say they say it doesn't improve at all. Now either they do have centralized pain or the pain is coming from another area. One nuance for this, some people will do the Prepare Cane Challenge and they think, oh yes, this is centralized pain because they have no improvement. Maybe. It can be centralized or they can get referred pain. Some patients with neck issues can actually get referred pain that affects the eyes, and that's technically not neuropathic. That just gives you an idea that, yes, I know the pain is not coming from the external environment. And centralized pain is something you would be considering at that point. All right, in vivo corneal confocal microscopy. Nothing you have to do. This is interesting. We still don't know 100% all we need to know for this. But you guys see those little kind of like comma-shaped white structures? Those are dendritic cells. Those are markers of inflammation. And you see how the nerve kind of has a banded or beaded appearance? That's called nerve beading, and that can be a sign of nerve damage. Again, we don't know the exact relationship, but we do know we tend to get more beading. We get more of these dendritic cells when there's nerve damage. And you can get a reduction in nerve density. Okay, osmolarity. I already mentioned this one earlier. I personally, I would not put osmolarity in the core definition of dry eye. This is somewhat controversial. Some people would say yes, some people would say no. The whole concept behind osmolarity, just think of it like a cup of water and salt. If I fill a cup of water up to the brim and I pour salt in it, and then I have a cup of water that's only half filled, and I pour the same amount of salt in it, there's a higher salt concentration in the cup with less water, right? That's the idea in dry eye, is if your tears are evaporating too quickly or not producing enough of the aqueous component of the tears, you will have a higher relative salt content. There was a period of time where they were trying to have this be considered diagnostic for dry eye. I don't consider it diagnostic. I consider it a great tool to measure this over time. If we would call this, looking at glaucoma, this is like your patient's IOP for a dry eye patient. You want to track change over time, to me, is way more important than an absolute value. However, they consider the diagnostic value that 308 or more, or that difference between the two eyes. But I think this is a better way to check changes over time. That's just personally how I like to see it. MMP9, have you guys ever used this? Inflamadry, anything like that? This is great. I think it's really good for studies. The poor man's version of this is put them on a steroid drop 3 times a day for a week and see if they get better. Guess what? If they do, there's some inflammation present. That's the easy way to do it too. Both ways work, but like I said, really good way to objectively look for this, especially if you're doing a study. Some people really like to do this. I think it's a great test. Schirmer's testing. Okay, Schirmer's testing. How many of you guys do Schirmer's testing routinely? Okay, we got a couple. In my dry eye clinic, I do not do Schirmer's testing. The only time I do Schirmer's testing is if it's for a study. And the reason is we have to put a piece of paper on the eye. What's that going to do? Reflex tearing. Now, yes, it will tell us some about basal tears, but we also get a reflex element here. So basically, you're kind of muddying the waters a little bit. I'm not saying it's a test that does not have value. This is why I talked about how much I like tear meniscus height. I like doing that instead because that's a non-invasive way to look at this. Again, gives some value here. But the thing that's funny, I actually did a literature review on Schirmer's testing. The first paper that was published that was questioning its value was published in 1979. So about a half century ago, doctors were saying, we don't think this is a good test. And 50 years later, guess what? We still got it there. So just know that you have to take everything into account when you're doing Schirmer's testing. Okay, so now we are moving into therapies. Starting with over-the-counter. I am a huge fan of supplementation. When it comes to dry eye, we want to take a personalized approach. However, I do think there are foundational treatments that every dry eye patient should start with, and one of those is supplementation. Personally, I am a huge fan of omega-3 supplements. The reason being is because there is a paper that was published in Cornea that shows omega-3s are helpful with dry eye. Now, you might say, well, what about the DREAM study? Well, the DREAM study was one of the worst designed studies I've ever seen. So the DREAM study, people thought that the takeaway was that omega-3s don't work for dry eye. That's not what happened. They compared omega-3s to olive oil. Olive oil also helps with dry eye. What they found in that study was both olive oil and omega-3s helped, but there wasn't a difference between omega-3s and that. That's not a neutral comparator. That's comparing two things that work, so you can't draw that conclusion. Also, as we're going to see, the specific formulation of omega-3s matter. And that formulation that was studied in that Cornea paper that I referenced was not the formulation that they used in the DREAM study. So I think the DREAM study is a widely misinterpreted study, and the reason I get a little bit cagey about that is I've had doctors who stay away from what can be a very good treatment because they think the DREAM study says that omega-3s don't work. The other thing is we now know that vitamin D is super helpful for dry eye, helps bring down inflammation. Things like lutein, zeaxanthin, and curcuminoids like turmeric, those are all really powerful antioxidants. We see those in AREDs, right? That's what you probably look like, well, isn't that in AREDs? It's similar because they are really good at bringing down inflammation. So when I talked about formulation matters, this is what you want. If you want to get an omega-3 supplement that actually does help your patient's dry eye, you want a high-quality, re-esterified triglyceride-based omega-3 with a 3-to-1 EPA to DHA ratio and at least 2 grams of combined EPA and DHA. Yes, that is a mouthful. I do tell that to every single patient. They then look at me dumbfounded. I'm like, don't worry, I'll tell you which one I recommend. The reason why this is important, and I do take 5 minutes to talk to a patient of this in a dry exam, because if I send them to Costco to get theirs, I guarantee you I know which one they're going to get. The cheapest one available. And when I talk about the re-esterification and the triglyceride-based nature of that, those are ones our bodies can digest. Super cheap versions are not re-esterified, and they tend to give you the poor digestion, the fish burps, because our body can't digest the ethyl ester form of that. This is why this is such a big deal. So that's why I dive into this so much, but I've had really good success with this. In that study I referenced in Cornea, it improved symptoms. There was a decrease in osmolarity. There was an increase in tear breakup time and a reduction in MP9, so a reduction in inflammation. Lutein, zeaxanthin, curcuminoids, and vitamin D, that's a newer formulation. We saw very similar results for this. I will use both of these. I've actually used these in conjunction with patients before. The only thing is you want to make sure if they both have vitamin D that you're not going over their recommended amount of vitamin D per day. Both are really good options. That secondary one I will use as a backup because some patients, some might be allergic to fish. They might not be able to take fish oil for one reason. I always like to have another option. But I am a big proponent of using that as part of your foundation. Warm compresses. Believe it or not, I actually use warm compresses less. I use cool compresses more nowadays. I think a big thing for this is our rosacea patients. Rosacea patients can actually get worse if they use a warm compress because they have those spidery vessels, right? And what does heat do to blood vessels? Dilates them. So you can actually be getting an uptick in pro-inflammatory factors with them. So next time you see a patient, ask them, have you done warm compresses? They're probably going to say yes. Ask them if they feel better or worse afterwards. If they've got that kind of reddish appearance, it might be worse. I tell them, use a cold compress. It's not going to congeal the meibum more. It's not going to clog more. Even then, the warm compresses, it's hard to get them to a amount that's so high that you're truly going to be like deeply getting the meibum. So for me, this is just a piece of the puzzle. The reason we hold on to these so hard is because this for a long time is what we had. And before this, we actually had the good old rice sock. And I remember once when I was a student, the patient asked me, does it have to be a clean sock? And that was when I'm like, oh boy, we definitely need some better treatments. And if you're wondering if your sock has to be clean. Artificial tears. Artificial tears also have a place. Oftentimes people are tempted to go to extremes. I know some doctors who will refuse to use an artificial tear because they're like, it's not treating dry eye, it's not getting the underlying cause, it's just re-wetting the surface. And then the other extreme, there's doctors who only use artificial tears and they're ignoring some really good treatments. Their use is in the middle. I explained to a patient that your artificial tear is there for your quick hit of comfort when you need it. That's what it's there. I mean, our prescription drops, they're not as needed drops typically. They need something that they can reach for in the moment that makes their eyes feel better. And I often say they're good for priming the eye. I still think it's good to use an artificial tear once in the morning, once before bed. It just helps get a little more moisture on the surface. Again, this is creating the foundational scaffolding we build things on top of. There's gels, ointments for regular tears. I really like gels. They're a little bit thicker. Now, all the rage here, hyaluronic acid, it is the buzzword. I'm sure it's all over TikTok. I hear it all the time. I don't not even have TikTok, and somehow I know everyone talks about hyaluronic acid on TikTok. I don't know how that happened. I'm somehow, I thought I'd be impervious, but no, I know all the kids on TikTok, they're all about the hyaluronic acid. There's a reason for it, though. Hyaluronic acid is a really good lubricating agent. Now, within the hyaluronic acid family, there is low molecular weight and there's high molecular weight. Low molecular weight hyaluronic acid actually can be a bit more associated with inflammation, whereas high molecular weight hyaluronic acid is anti-inflammatory. But now we even have a third category. We have something that is called ultra high molecular weight. When you get to a weight that's actually at a certain level where it's ultra high molecular weight, you start to get some interesting properties to drops. There is a new drop that was actually just released. It's the first one that you can get over the counter that's ultra high molecular weight. And what's so interesting about this is that when they did a study where they looked at patients who had corneal cross-linking, they actually had enhanced nerve recovery when they used this hyaluronic acid compared to a different version. So this might have the ability to promote healing. On top of that, these patients who use this drop reported a 27% reduction in drop use in a dry eye study. And the reason for this, they think, is that molecular weight of hyaluronic acid and its ability to bind to mucins on the ocular surface are directly related. So the higher molecular weight you have, the better binding affinity it has. And they think the idea behind that is they used drops less because the drops were staying on the surface longer because they could bind to mucins better. So it's just, all I can say right now is we are getting some really, really good technology, even in artificial tears. So yes, they do have a place. Don't overly rely on them, but they can be beneficial still. Lid hygiene. I am a massive proponent of lid hygiene across the board. Even if you don't see a single dry eye patient, we should probably be using lid hygiene. The reason why? Our lids and lashes are like the air filter of our ocular surface. And you know how we're supposed to all change our air filter, we forget about it, and then we pull it out, it's all like black and gross. That's kind of how I see our lashes. If we're not routinely cleaning them, they're going to be picking up debris, they're going to get, bacteria, things on them, because that's their job. Their job is to keep this from going onto the surface of the eye. There are a ton of great options for lid hygiene. Hypochlorous acid, I really, really like. Tea tree oil, it can be helpful. Manuka honey is another one that we're starting to see more and more of. And okra. Okra is really good for patients who have sensitive skin. And there's wipes, there's sprays, there's foams, all can be helpful. But now some of us might be wondering, what about baby shampoo? Go into any urgent care anywhere in America, find their medical reference manual from 1982 that they somehow all have, and they would look for blepharitis. So it'd be like, use baby shampoo. You know how the tagline for baby shampoo is no tears? They actually left out the word, it's no good tears. Do not use baby shampoo. Here's the reason why. It is a surfactant. We use shampoo in our hair to remove grease. We kind of want the grease that's on our tear film, which we call the meibum layer, to be there. If this gets in the eye, this will strip that lipid layer. Our skin is supposed to have a fine layer of lipid on it. It's supposed to have a little bit of oil to protect the skin from dehydrating. and it's protective. I had a patient who came in who I basically said, the condition I came up for her is she had baby shampoo blepharitis. Her lids were raw, they were flaky. I'm like, oh, this is looking bad. And I'm like, okay, so what have you been doing? And she's like, for lid hygiene, I use baby shampoo at least twice a day. And I'm like, you said at least. How often do you use it? She's like, well, some days if my eyes get irritated, I use it more. I've used it up to 5 times a day. Every time her eyes got irritated, she'd use it more, and they get more irritated because she was perpetually stripping that oil, and it was basically just eating away at the surface of her lids. So for her, I'm like, we're done with the baby shampoo. We're gonna move on to these other ones. They're gentler, they work much more. So that's why I bring this up. This is a relic of an old time. This is what we had at something, but now we have much better hygiene options. Okay, now we're moving into the prescription treatments. All right, so let's start with the old-fashioned anti-inflammatories. So right now, if we're technically looking at dry eye, any steroid's gonna bring down inflammation, but Isuvis actually is our only FDA-approved steroid that has an indication for dry eye. Isuvis is low prednisol. The big thing about it is it has a low percentage. It's 0.25%. So your side effect profile tends to be lower. This is used on label, at least, for short-term acute flare management up to 4 times a day for 2 weeks. The way I love to use this, off-label, mind you, is as a rescue drop. So you know just how someone who has asthma, they need a rescue inhaler in emergencies? What I will do is I will prescribe a bottle of Isuvis, and I will typically for a patient say, this is your bottle for the year, this is your rescue drop. No matter how well you are managed today, you're going to have a flare. If it's on one of those days where you have a bad flare-up, you can go ahead and use 1 or 2 drops. You can do that for 2 or 3 days, but if you have to use this for more than 3 days, you call me right away because something more is going on and I need to take a look. The key to doing this is document, document, document. In your chart, make sure that you have told them if they use this longer than they're supposed to, they are risking cataracts. They are risking premature cataracts. They are risking elevated IOP and possible glaucomatous changes. You have discussed the risks. They acknowledge that using this more than what you have prescribed increases the chance of them having this. Again, it's more of just a medico-legal thing, so then at least in your chart, if a patient says, I'm gonna go nuts, I'm gonna use this entire bottle and not stop, if any of those things would happen, which is still a pretty low chance, you have at least documented in your chart, you had these discussions, you told them to use this. But I'll tell you, I've had patients who love the rescue drop who have never put it in their eye once. Because psychologically, they're at such a level of comfort knowing they have this drop on hand. Because most patients worry, they're like, well, let's say I'm going to a wedding. Let's say I'm going to this and my eyes are all flared up. Now I'm panicking. I have to call my doctor. They have this on hand. They know they have something that can get things soothed. But you always have to remember, if it makes it worse or it doesn't get better after a few days, call me. So there is responsible use, and also use your clinical judgment to know who would be a good patient for this. Now we're going to move on to something that's a little bit more unique. Are you guys familiar with corticotropin gel? So this would be like Acthar or Cortropin. Okay, I'm seeing some heads nod. So this is a gel and this is an infusion. So you're using this systemically. This is a really cool molecule. So this is corticotropin hormone. This is actually naturally produced, and it stimulates the pituitary gland to then also signal the adrenal cortex to produce cortisol naturally. It also works through something called the melanocortin receptor system. Melanocortin receptors are throughout our body, and they are a non-steroidal anti-inflammatory pathway. So the majority of ACTH use in our body is actually non-steroidal pathway. Fun fact, this is actually what we first used before we had synthetic steroids. This comes from pigs. The reason why we switched over from this in the 50s was because synthetic steroids were cheaper to source and make. If you look at the label for this, it's basically, its indication, inflammation. Anywhere in the body, because this was like the first one for this. So basically the thing that's interesting about this is instead of suppressing the immune system, what this does is it regulates the immune system. So this is something to consider for a patient who has really bad systemic inflammation, they're non-responsive to things. Now, the biggest thing for this is going to depend on state scope, whether you can do this on your own, because it is an injection. If you can't, what I recommend is a lot of times find an ophthalmologist who you have a good relationship with. I know that's what I did when I was here in Arizona. I had a good relationship with one, and I would call her up and I'd say, hey, this is a patient I want to start on this. This would be the dosing. Would you like to take a look and see if they would agree? And oftentimes she'd, yep, we'll get them started, because she had a background in uveitis, was very familiar with these. So Just know this isn't going to be probably something that you're grabbing every single day, but just keep this in your back pocket if you have those really tough inflammatory cases. Immunomodulators. I'm going to spend some time talking about these here because we have several of them, but sometimes I think we don't really look at the specific differences of why we have so many. So we're going to start with cyclosporin because this was one of the first one. This is really our first one we had. Okay, Restasis. This is cyclosporin. It's an emulsion. It's 0.05%. The big thing for Restasis was this was our first one. That's really the thing that it did best. But what I want to bring up about this is it's really not the best one. And quite frankly, because it was our first one, right? The first one, generation of one of anything, you know, it's kind of finding the path, but it has its struggles. And the big struggle we have with cyclosporin is it is incredibly hydrophobic. It does not get through liquid well. To have the effects of cyclosporin, it needs to get to the cornea, the ocular surface of the conj. Well, guess what's in the way? That nice aqueous component of the tear film. So we have a very difficult time getting cyclosporin through that. So that's why Restasis probably back in the day, it kind of works, but it could take up to 6 months. It was just kind of a struggle to get it to where we needed it. Our second generation was Cequa. Have you guys used Cequa? So Cequa's, its answer to this delivery question was it used nanomicelles. Basically, a nanomicelle is a little kind of ball. It's a sphere. The outside is really hydrophilic, and the inside is hydrophobic. So it would basically take the cyclosporin, put it inside the ball. The outside of the ball is like, yep, I can pass through liquid really easy, through water easy. And then when it would get to the surface, it was better delivery. Also, you saw we increased the percentage, right? Now we're at 0.09. So a higher concentration got to the surface better because of the better nanomicelles. And we actually have some data that shows it would start working within about 2 weeks. Okay, that's great. Then we have VEVI. So VEVI is the newest one. How many of you use VEVI? Okay, so what's unique about VEVI is, first of all, we upped the percentage again. Now we're at double. We're at the highest percentage. And it's also using a unique vehicle. So it's a semi-fluorinated alkane, so you can actually dissolve the cyclosporin. So this vehicle, it's literally just completely dissolving it. So it's in there, it's completely there. And because you have this semi-fluorinated alkane vehicle, it can stay on the eye for up to 8 hours. And because it dissolves and it's so good at delivering it, they actually find that you can get 22 times more cyclosporin to the surface with this. So the vehicles for these really matter. And what they've actually seen at week 2, patients showed a grade improvement in staining of 3 grades or more. That's huge improvement, right? 3 grades of staining within 2 weeks. So really this shows you that the vehicle can make all the difference in getting cyclosporin to where it needs to go. Okay, now lifitegrast, Xiidra. I talked about this earlier here. So where cyclosporins work on calcineurin in the inflammatory cascade, these work on T cells. They block that LFA1 so it can't bind to that ICAM and create the inflammatory cascade. Again, it works on both inactive and active T cells. And we saw there's about a 50% reduction in symptoms at week 12 and about a 33% reduction in staining. This new contact lens study, I don't know, have you guys seen this contact lens study with Xiidra? It was really interesting. What they did is they looked at contact lens end-of-day dryness and discomfort. And they had these patients use Xiidra, and what they found was it reduced end-of-day dryness by 68%. That's great. This next finding was the big one, though. Patients reported 2.5 hours more of comfortable contact lens wearing time. I don't know about you guys, but in a dry eye population, 2.5 more hours of comfortable wear time is huge. A lot of our dry eye contact lens patients, they're not looking from 6 a.m. to 10 p.m. They're like, I want to be able to go to the gym. I want to go dancing wearing my lenses. If we can increase that by 2.5 hours, that's a big difference. So really cool study that they found that Xiidra is able to do that for these patients. Tacrolimus, we have no commercial preparation of this. However, this is an incredibly potent anti-inflammatory, and this works through that same calcineurin pathway. I just want you to be aware of that because you might see this in the literature. I would not be surprised if someday someone does make a commercial availability version of tacrolimus. Okay, the good old MMP9 inhibitors, things like doxycycline. Some people really, they're like, man, why are you using an oral antibiotic for this? Again, they have a place. This one brings down MMP9. The key here, though, is dosing. At or below 40 milligrams of doxycycline, you actually aren't getting antimicrobial effects. You're only getting anti-inflammatory effects at this point. Unfortunately, in generics, what does it come in? 50. Darn. So you can get 20, though, and you can do that. You can double it with 20. The big thing with this, though, too, is that you're going to have to figure out how you want to dose it. A lot of patients, what I like to do is have them do it for about a month, go off and see how they're sustained. But at the same time, the next one here, Oracea, this is a branded version of that. It's 40 milligrams, so it's the right dose. But the thing about it is it's 30 milligrams of immediate release and 10 extended release. I had one patient who had really bad ocular rosacea. This was it for her. Once she got in her Oracea, she was fine. Like, she was good. Like, everything else, she's like, this did it for me. Insurance can be a hurdle here. So just remember, it does have a place. That's what I like to bring up here. Now, oral azithromycin, this is kind of becoming a thing in vogue. There was a study that actually showed that if you did 1 gram of azithromycin once a week for 3 weeks, it was equivalent to the effects of doxycycline for MGD with a lower side effect profile, which is good, but there's one concern I have here. You're still using an antimicrobial dose, and if you do this frequently, I am a bit concerned about antibiotic resistance. Now, doing this one-off, not bad. If you do this every now and then, okay, that's fine, but I wouldn't want a patient doing this every single month. That's not, I just feel like that's a bad recipe for antibiotic resistance. And then azocyte. Have you guys ever used azocyte? It's topical azithromycin. It has one major issue. It's really hard to get. This thing has a cult following, I can tell you for sure. So the way you actually use this is again off-label. You actually take a little bit of it, wash your hands, put it on your finger, and you rub it into the lid margin. And you do a loading dose, basically. What you're going to do is you're going to use it every single night for 2 weeks, and then about twice a week for maintenance. When I was in my residency, the doctor who was my attending, he was the top prescriber of azocyte for like 3 years in a row in the entire country. He loved doing this. It was easier to get at that time. So just know that sometimes if you want an alternative to orals, this can work really, really well. Tear film stabilizers. So now we're going back to perfluorohexyloctane. This is MIBO, like I talked about earlier. What we saw here is that MIBO actually did a better job of reducing evaporation than human mibum did. When they put that little container of saline on the scale and they saw its evaporation rate, then they put a drop of human mibum in there and they saw they had an 8% reduction. But then when they put that saline, no human mibum, and just MIBO, there was a 28% reduction. So perfluorohexyloctane is actually better at inhibiting evaporation than our own human mibum was. And when you put it all together, mibum, MIBO, you actually got a 34% reduction in evaporation. And we know that this is very well tolerated. Patients find it very comfortable. And they found that at 5 minutes, there's a 47% reduction in symptoms. Also, I mentioned that it was all the way up over 56 at 1 hour. So the effect doesn't only start quickly, but it's sustained. And this is going to stay on the surface of the eye for a long time. It's found up for 8 hours. And that's really because it has this unique structure. It's got those hydrogen atoms that are attracted to lipids, the fluorine atoms on the one side that are attracted to oxygen. So it's basically creating an extra anti-evaporative layer on top of the mibum. So you basically now have 2 anti-evaporative layers. Now we're moving into the neuromodulator side of things. So I love how we're getting more emphasis on corneal nerves. So Acoltramon. How many of you guys have used Triptyr so far? Okay, it's a new kid on the block. I'm a millennial. Its name is Acoltramon. It sounds like Pokemon, so I loved it immediately. I'm like, this is great. So Acoltramon is a very unique drop. So what it does is it's going to stimulate the nerves, but it does it through a specific pathway. Have you ever wondered how we produce basal tears without thinking about it, right? Like all of us right now, we're all tearing. We're producing our natural tears, and we're not thinking about it. The way that this works is all predicated on evaporative cooling. So let's say, now we're getting close to swim season here. I would swim out here in this weather, so I would do it, especially now. I've been back in Ohio. My blood is thickened. I'm hardy. I could swim in this weather again. If I would get out of the pool and that water would start to evaporate, I would get really, really cold. When I lived out here, it could be 110, and I would get out of the pool, and I would actually feel chilly. And that's because as that water evaporated, it was pulling heat away from my body. When your tears naturally evaporate, it pulls heat from the corneal surface, and it causes a slight temperature reduction. We have this group of cell receptors called TRPM8, and they sense temperature reductions of about 2 degrees. And what happens is when you have that evaporative cooling, you get that slight reduction in temperature, it stimulates that TRPM8 receptor. It sends a signal back along the corneal nerves to the brain, and then it sends signals to the goblet cells, the meibomian glands, the lacrimal gland, main and accessory, Wolfring and Krauss, the redheaded stepchildren of the lacrimal functional unit, they're in there too. And it stimulates all part of our tear production. As I've been talking about this, you guys have probably done this about a dozen times already. So what Acoltramon, what Triptyr does is it actually is an agonist. It stimulates that TRPM8 receptor. So it is working on that same basal tear production pathway that we naturally use. to stimulate our natural tear production. That's a pretty elegant solution, right? Like, I mean, that's nice. We get more tears based on our natural production pathway. And what they found was at day 14, patients in this study, they did Schirmer's testing initially. They were about a 6. We want 10 millimeters of wetting on the Schirmer strip is considered normal. They found that the proportion of patients 4 times greater got 10 more millimeters of wetting. So that means these patients were getting to about 16 versus that. 4 times greater got to that versus the control. 75% of patients got to normal. So how many of the patients got to at least 10? 75%. The way to think about this means 75% of patients after using TripTear would no longer even qualify for the study because they were back to normal. All right, you're like, well, I thought at the beginning you said you didn't like Schirmer's testing, and now here you're talking about it. Well, how do you rectify that? I completely agree with you. And so did they when they were developing Cultramon. They had to use Schirmer's testing because it's the standard in clinical studies, but they always knew, they're like, well, what if someone's going to say this is just a reflex tear? What they did then is they did a phase 3B study. They did a separate study. And they took their patient. And on the right eye, they took a tear sample. And in the left eye, they measured tear meniscus height with an OCT non-invasively. They put in a drop of a Cultramon. They waited 3 minutes, and they took a measurement. And what they found was tear meniscus height increased 147%. So non-invasively, they looked, and there was a 147% increase in tear meniscus height. Good, okay, I'm seeing more tear production non-invasively. And the reason they took that tear sample is, if you get a reflex tears don't nourish. They're supposed to flush. Reflex tears are primarily composed of aqueous, not as much lipid. So you would expect if there was more aqueous component, you'd have a lower relative concentration of lipid, right? More water, less oil. What they found was there is a 72% increase in lipid concentration. So what that shows us is we are also getting an uptick in lipids. So this is not just a reflex. We are getting all parts of that tear. So I thought this was a great way. I love this. This is what I would show. The other thing about this is they saw these effects as early as day 1. And when I say day 1, the measurement was taken at minute 3. So this onset of action is incredibly rapid, and there was no drop off at day 90. So this is rapid and sustained. So I love this because now what you're seeing is we are really building out multiple ways to attack dry eye at this point. And then before this, we had varenicline. We had Tyrvaya, the nasal spray. How many of you guys have used this one? Okay, so it's a similar idea. I say this is just kind of taking a scenic route for this. So instead of doing that TRPM8 receptor, it's looking at these nicotinic receptors on the anterior ethmoidal nerve and the nasal mucosa. That's why for this, you always have to tell a patient, do not spray it into the nasal passageway. You will pepper spray yourself. You will tear, but it will be all reflex. You want it to coat the inside of the nose. I actually would say to patients to pinch your nose after using it because you want to coat the nasal mucosa. That's how it would do this. And they saw there's about a 50% increase of that 10 millimeters or more of wetting at week 4. So this is good for your patients who can't tolerate drops. That's where this has a lot of utility. In my experience, what I noticed with this is it tended to be a group of super responders. What I mean by that is I've had some patients use it and they're like, yeah, it was okay. I don't really know. Or what they told me is, this is the best the best treatment I've ever used. I feel great. So I don't know why, but there tends to be, when you have the group of patients who respond to this, they tend to respond really, really well. Okay, the iTear 100. How many of you guys have ever heard of this guy? Oh, yes. This is a handheld device. It vibrates, and what it does is it stimulates the external nerve right at the kind of the bony prominence of the nose. You're supposed to hold it there, and it's going to vibrate for 60 seconds. Andrew, did you ever play the game? What we did in our clinic is we saw who could hold it there longest. Remember, they said a minute. I think I made it 35 seconds. You could hear me screaming from there, like yelling, trying to hold it more and more. My eyes were dripping. Quite frankly, I couldn't tell you if it was a basal or a reflex tear. The yelling probably said it might have been a bit of the latter. But this is a handheld device, so just another way to do this. Just you might come across this, but that's what the iTear was doing. It was just a mechanical stimulation of the nerve. Okay, now into biologics. This is a very unique area. So autologous serum tears. How many here have used autologous serum tears? Okay, yeah, a smattering of patients have gotten these, I know, from many doctors. You know, you spin your own blood down, you make the tears. Realistically, you like to keep this between, I would say, about 30% 50. The problem when you're above a 50% autologous serum tier, they actually can become irritating because you're starting to keep components of the blood you'd actually probably not want in there. And these can work okay, but I'll tell you, if you've ever used PRP, platelet-rich plasma, the results are way better for this personally. And the reason for that is it's keeping the same general things, but you also keep in the platelets. So if I would cut my arm and I form a scab, the platelets are helping to form the scab, right? That's part of the healing side of this. When you keep those platelets in, when they combine, they're actually going to be stimulating the production of a lot of growth factors that promote healing. There is one struggle with PRP. It is hard to get. I have told many companies already, the first one who makes PRP commercially available will be the winner, because I've just had really, really good success with that. But like I said, hard to get. Amniotic membranes, they come in two primary flavors, the dehydrated, the cryopreserved. So when you look at cryopreservation, the big thing with this, it's literally still a wet membrane. So there's this thing called HCHAPTX3. That's heavy chain hyaluronic acid and pentraxin 3. That is a signaling complex that's involved in scarring, inflammation. And they really think that that's why sometimes the cryopreserved membranes have a bit more of an oomph to them, if you will. They work a little bit better, is because they have these factors that really kind of work on those pathways. Now, I'll say this too, though. A dehydrated can definitely help. It's giving you some extra bang for your buck. But I've always found my big thing is people say, when do you use which? If someone has really, their surface is like almost confluent SPK, or they have a major defect, they have an ulcer, something like that, I'm going with a cryopreserved. If you're cleaning up a little bit of stuff, a cryopreserved will definitely give you a lot of bang for your buck, but you will get some extra help from a dehydrated. So just know, it's controversial, guys. If you look in the literature, some will say that, only cryopreserved, some will say dehydrated is there. I will say the cryopreserved work really, really, really well. Dehydrated I've had success with as well. Also, there's new versions. So Procara is our big one there. You have the ring, though. That can be a bit of a struggle. Has anyone used the CAM 360? Okay, yeah. So what that is, basically, it's the same idea. It's a cryopreserved membrane, but there is no ring with it. But you actually put that in a collagen shield, which is from a porcine from a pig source with that. Takes a little bit of time getting used to, right? But most doctors I talk to who like it, they typically switch over to using that if they really like that. Okay, biologics. So why was I harping on so much earlier about testing corneal sensitivity? Why did I talk about cutting the wire on the TV? This is a first-line treatment for a patient. I say this, and it sometimes raises eyebrows because most people would say, man, I'm not going to go to oxybate until I've tried every single thing else and it's failed, and now I'm going to go to this. I'm the exact opposite. The reason being what I mentioned earlier. If the nerves are dysfunctional, it does not matter what I'm doing on the rest of the eye. It will not work until I restore the nerves. The nerves are needed to produce tears. We talked about that with trip tear. The nerves sense. They protect the eye. The nerves are needed for routine epithelial cell turnover and wound healing. So our corneal epithelium is turned over about once a week. If you have dysfunctional nerves, we don't get that. That's why you get non-healing epithelial defects and neurotrophic keratitis, because we can't stimulate healing. So if a patient has reduced or absent sensitivity, that's pathognomonic for NK, I immediately know I need to fix this problem. So what is oxervate? It's sernedrimin. Sernedrimin is a recombinant form of human nerve growth factor. Nerve growth factor is naturally produced by the epithelial cells and the lacrimal gland because it promotes nerve proliferation, maturation, healing, and maintenance. Basically, it's making sure the nerves can survive. Remember, the cornea is avascular, but it still needs nutrition, right? So it actually gets its nutrients from the nerves. So they have this symbiotic relationship. You cut off that nerve supply, the epithelium now is going to start to struggle. So the goal of oxervate here is providing NGF exogenously to help repair the nerves and heal the surface. Now, the recombinant side of things, this is where I really like this here. What this means is they took the human genome, they sequenced it, and they found the part that encodes NGF, that what we use to actually make NGF. They spliced it out, they put it in a plasmid. A plasmid is what we use to take DNA from one creature and put it into another creature. What I mean by that is they took our DNA and put it into E. coli bacteria. They then put it into their own DNA, and they produce human NGF. This is all done in Italy, and I like to believe they are little E. coli farms. Instead of milking the cows, you were milking the E. coli, and they were giving us NGF, and it's batch produced. And that's why, if you've ever heard that Oxervate is really expensive, that's why. Now, also, just as a minor side thing for this is a very expensive medication. Your patients will never pay that. Just if you have, if you know your Oxervate rep is, talk to them about this, because this is a really, really great medication. Don't be scared off by the price tag. There's just specific ways you have to go about basically prescribing this. I also will use this as a little side tangent on this with prescribing. I gave this lecture once. I was in Colorado, and the couple came up to me afterwards, and they gave me the best compliment I can get. They started by saying, "We hate dry eye." I'm like, okay, good start here. I like this. You actually made that kind of okay to listen to. I'm like, good, I'll take it. You hate dry eye, and you kind of like that. But they looked at me, and then they said, "These treatments sound great, but can patients actually get them?" And in my mind, I'm like, oh my gosh, I didn't even think about this. Most of these medications nowadays, guys, have a specific place you need to send them. They have partner pharmacies. Talk to your local rep, because quite frankly, if you want your patient to get them, you need to go through the partner pharmacies. They are incentivized to actually fulfill the brand name you prescribe. I'll just be honest, most pharmacies nowadays, like just out in the wild, they're incentivized to fill generics because there's a greater margin on them. That's just the reality of the situation. So if you really want to get these for your patients, find the best place to send them. I have now included that in this lecture every single time, because I always think about that without even I do it without thinking about that. So if you want to get these for your patients, that's the way to go for this. All right, back to our regularly scheduled program. So Oxervate. What they did is, when you look at NK, there's 3 stages. Stage 1 looks identical to dry eye. It's SPK, and they'll have reduced tear production. There is only one way to know the difference between stage 1 neurotrophic keratitis and dry eye. Check corneal sensitivity. Because these patients can still complain of dryness, but if you test sensitivity, it's often reduced or maybe even absent somewhere. So that's stage 1. Stage 2, there's a non-healing epithelial defect. Stage 3, this is where you have an ulcer that involves the stroma. These patients are on the verge of perforation. So the first study they did for Oxervate, it was called the Reparo study, and they looked at stage 2 and 3. So these were big defects. And what they found is, after an 8-week course of Oxervate, it's 6 times a day for 8 weeks, 72% of patients had complete healing, which means they had no staining. That's a high bar, no staining at all. And then they found that about a year, about 48-week follow-up, about a year, 80% of those patients had sustained healing. Okay, that's pretty good. What about stage 1, that mild stage? Same dosing. They found that almost 85% of patients had complete healing, and over 91% had improvement in corneal sensitivity. And then a year out, we saw it was about 95% that still had that sustained healing, 82% with the sustained sensitivity improvement. This is, again, why I start at the beginning with these patients. If I see nerve dysfunction, I don't mess around. I go straight to using this to treat it, and this is the reason why. I had a patient who came in who had dry eye, had seen several other doctors, and they said they had failed on everything. Their most recent failure, they said, I tried Xiidra, nada. Didn't do anything. I tested her corneal sensitivity, and guess what? She had probably, I would say, she was at a stage 1, heading towards a stage 2 NK. Treated her with Oxervate. 8 weeks later, she was doing a lot better, still had some dryness because dryness was a contributing factor. I then put her back on that Xiidra that had not worked, and guess what? It worked. The problem was, until I fixed the nerves, it didn't matter what dry treatment I used, it was not going to work. So that is why, for me, this is actually a first-line treatment. A lot of times people ask, what about amniotic membranes for this? What I would like to do is I stack it. This can take a few weeks to get, so normally I'll put a patient on an amniotic membrane, I put the prescription in for this, then I have them use Oxervate, and then afterwards, I like to put them on autologous serum tears or PRP, depending on what I can get, as their maintenance afterwards, because both of those also have growth factors. So that's like my 3-pronged approach to dealing with NK. Now, antiparasitics, bugs, mites, all the fun stuff right here. The one time I get to use my undergraduate degree to zoology to some function whatsoever is talking about these. So we're going to talk about Demodex. So these are an ectoparasitic mite. We all have them. It has 8 legs. What else do we know has 8 legs? Spiders, ticks. So if a patient, I tell them they have an ectoparasitic mite on their lashes and they don't kind of cringe, I'm not satisfied. I like shock and awe. I tell them they're related to spiders. And if they still don't do anything, I'm like, go check their blood pressure again. Something's wrong. So we have our first FDA-approved treatment for this. This is lotilaner ophthalmic solution, 0.25%. This is Xdemvy. So things like tea tree oil, microblepharoid exfoliation, all good treatments to help get rid of collarettes, things like that, which is great because collarettes themselves are also pro-inflammatory, but they don't really do a great job of getting rid of the mites themselves. So you wonder, why is it then, okay, then what's so magic about Xdemvy? Why does this work where nothing else really works? Well, first we have to look at the mite's anatomy. They actually have a chitinous exoskeleton. What that means is they basically have this mini suit of armor that's the same material as crab shells. Because of that, 75% alcohol will not kill them. 10% povidone iodine will not kill them. And that's what they use before surgery. That like kills everything. Again, they laugh. They're like, I have a little suit of armor. You can't do a thing to touch me. Well, this is how Xdemvy works and what's so unique about it. First of all, the question I had was, why is this a drop and not an ointment? Because Demodex mites live in the lash follicles, that's Demodex follicularum, and the other species we have is called Demodex brevis. They're smaller, and they live in the meibomian glands, the sebaceous glands. Well, shouldn't we slather an ointment on there to get to them? That's what I would have thought. But Xdemvy is highly lipophilic, so it actually can get into the follicles and the glands without having to be an ointment. Yay, that's good, right? Because patients really don't like ointments. Okay, so it gets to where the mites live. Then what does it do? It actually binds to this GABA-gated chloride channel, and it paralyzes the mites. When you are paralyzed, you cannot eat and you cannot mate. So what's the point of living? And you go on and you die. That's what happens to the mites. So it gets to where they live, it kills them, but here's the last piece of the puzzle. That GABA-gated chloride channel is only found on the mites. So it doesn't affect our cells, so it's incredibly well tolerated. So it gets to where they live, it kills them off, and on top of that, it does nothing to our cells. So that's a really good mite-killing agent. You use it twice a day for 6 weeks. You guys know why we use it for 6 weeks? Life cycle, I heard it. So the mites start as an egg, then they become a larva. It's the teenage years, you know, this is who I am, mom, it's not a phase. And then they become an adult. They die, and the circle of life continues. Now, you need to go through 2 life cycles of the mites. And the reason for this is because of Godzilla. Why did I say Godzilla? Well, if you recall, in 1998, there was a movie about Godzilla that came out. I was 7 years old. I was prime demographic. At the end of this movie, they finally had killed Big Mama Godzilla. And the last shot of the movie is this giant empty warehouse. And in the center of the warehouse is an egg. The egg hatches, and wouldn't you know it, it's a baby Godzilla, setting up the sequel that we never got. It's one of the great tragedies of mankind. However, if a patient comes in and says, well, yeah, I felt better after 3 weeks, I say, let me tell you about Godzilla. You have killed off Mama. You've killed off all the living ones, but that egg is still there. It's going to hatch. It's going to set up Demodex blepharitis to the sequel, and we're going to be all over the place. So next time a patient only goes halfway through, you talk to them about Godzilla. They'll understand. So what did we see in clinical studies with Xdemvy? So we saw that 60% of patients reached mite eradication. That meant when they started the study, they plucked a lash and they saw 3 mites per lash. 60% had 0 mites per lash. Collarettes, the sign of this, on average in the study, these patients started with 100 collarettes on the upper lid. That's a lot, right? 50% got to 2 or less collarettes, and then 85% got to 10 or less. Why do we care about 10? Even a single collarette can mean Demodex blepharitis, but 10 is where patients tend to start having more of the symptoms in the literature. So that's the clinically meaningful reduction. And 25% got erythema cure. That's crazy, right? The word cure, you don't see that in studies. That means it's completely gone. That means patients who had redness before, a quarter of them after using Xdemvy had no redness. Redness is tough to treat, isn't it? Especially for a patient like our dry patients. So if a patient comes in complaining about redness, I am praying they actually have collarettes because that 25% who got resolution. This next one is the big finding. Demodex blepharitis and MGD are incredibly intertwined. Have you guys ever seen a patient who has significant Demodex blepharitis with no MGD? No. There's a study that showed that patients who have moderate to severe Demodex blepharitis, up to 96 to 99% of them have MGD. They did a study of patients who had Demodex and MGD, and what they found is after treatment, there was a 54% increase in the number of meibomian glands that were now secreting a liquid versus that toothpaste-like secretion, right? We want liquid, right? We want liquid oil. We don't want toothpaste. What this tells me is a major thing here. Xdemvy does nothing at all to meibom. It doesn't liquefy, it doesn't do anything. All it does is kill mites. So for a mite-killing agent to improve MGD, this means that the mites were contributing to the MGD. The reason why I'm belaboring this point is very similar to the oxyrvate point. This is a first-line treatment. The reason being is if a patient comes in and they have MGD and they have collarettes, if I start treating their MGD and ignore the collarettes, I could be missing the root cause of this. I could treat them with IPL, I could do a bunch of amazing MGD treatments, but guess what will happen? They'll improve, but they'll probably regress if the mites are a contributing factor. So what I'll normally tell a patient is, I see these collarettes, you also have some MGD, and I've explained what those are to the patient. What we are going to do is this. I am going to start out by treating you with this drop called Xtembi. You're going to use it twice a day for 6 weeks, and one of two things is going to happen. We're either going to improve the mites and your MGD, or we will get rid of the mites, and if you still have MGD, I can now confidently start treating the MGD on its own, knowing that I'm not missing the underlying cause. So that's why I tell them this is a no-lose situation. If Xtembi was a chronic medication, I couldn't do that. But in 6 weeks, I have an answer. So that's why now this has moved to like a frontline treatment for me. The other thing I like to point out about this is IPL. How many have IPL in here? Also, just so you guys know, going back to like Ohio here, Arizona, really good with IPL. We got a lot of IPL here, thanks to all the dryness here. IPL is a workhorse in many of our dry clinics. IPL can kill Demodex, but there's one major caveat with this. When you are doing IPL on the lids, we all know we put in corneal protection, right? We also know we need to stay about 2 millimeters from the lash line because IPL can cause hair removal. The problem is, where do the mites live? Right at that lash line area in the follicles in the meibomian glands, the area where we really shouldn't be treating with IPL. So we have a hard time getting directly to them. However, Demodex mites also are found in the whole periocular area. So what you can tell a patient is, okay, this is what I'll do. We're going to use the Xtembi for your ocular mites, and then we're going to hit you with IPL, and I'm going to get all the mites around that, and you get a great compound effect. So yes, it can kill mites, but that is the challenge of it. But if you use that synergistically, it's great. The same thing with like microblepharoexfoliation. I like to use new lids. We'll talk a bit about that. How many do people use Zest? That's another really big one. Those are really good at getting rid of collarettes, but we're not really sure how good they are at killing the mites themselves. What I often say is they're good at removing the garbage, but we still have to deal with the garbage generator. So what I would do if a patient comes in and they have really heavy collarettes, I would tell them, hey, if we want to get started on this early, I can clean those off today. I'll prescribe the Xtembi to get rid of the, the mites at the root cause here. And then if we want to do IPL to compound it, we can. These are all synergistic. That's the thing. Remember, it's not that if you do one, you can't do the other. You get really good compounding effects with these.
Question.
Yes?
After 6 weeks, they're gone. What's the chance of recurrence?
Great question. We actually now know that. There was a study, and what they found is at a year, there is a lower than 50% recurrence. So what I typically tell a patient is it's about a coin flip if you need to use it again. Oftentimes, I tell a patient at most you'll have to use it once a year. So it's under 50% that have the recurrence. All right, so the other things you might see, things like ivermectin. So ivermectin works on a different channel. It is somewhat similar to lotilaner, but here's the thing. There are risks of neurological toxicity with ivermectin. They are very low. This is actually used to treat river blindness, if you guys remember onchocerciasis, because we're all treating that routinely. This is something that it's used for this. My biggest thing I say for this is some people are like, well, yeah, we can just use ivermectin. Quite frankly, at this point, Xtembi is very easy to get, and it's FDA approved. This is a bit of a medical legal thing for you. The risk of using ivermectin is very, very low. However, I will tell you, if God forbid you ever did have a complication, the first thing any lawyer would say is, why did you use this when you could have used an FDA-approved treatment? Not a situation you want to be in because, quite frankly, you don't have a really good answer for that one. Again, I'm not saying this is high. That's not to scare you off or anything, but the FDA approval carries some weight to it. So yes, this can be used. Some people like to do that, but the dosing has never been specifically studied for this. It's actually a lot more legwork on your part in the end to actually use ivermectin. So that's something there. Metronidazole has also been used. They're not entirely sure of the mechanism for that. They actually think it might disrupt DNA synthesis, nucleic acid synthesis. All right, so now we're moving on here. So how many of you fit scleral lenses? God bless you. My rule was if it didn't flex in my fingers, I didn't fit it because I am not good at woodworking. If I cannot do something in centimeters, how am I supposed to be doing something in microns? Not my bag. But these are great. This is one thing I would say that when it comes to dry eye, remember that sclerals aren't necessarily a first-line treatment because they can improve this, but you still have to address the underlying dry eye. But at the same time, I will say sometimes as dry eye doctors, we forget about these, and we really shouldn't. When you have a patient, for instance, who has almost lost all of their meibomian glands, They do phenomenally well in these because they need something to protect that external environment. Remember, this is a combo. You still have to do all your dry treatments, but I'm telling you, scleral lenses can be a game changer for the patients who need them. Soft bandage lenses are the single most underused thing in dry eye. If you see a patient who comes in with like really bad SPK all over the surface, you could put them in a bandage lens, give them a prophylactic topical antibiotic, see them back in a day or two. You will be shocked at how much better the surface looks. Sometimes you just got to put a Band-Aid on it. That's literally, I mean, it's in the name. Sometimes I'm like, it's literally in the name. When you heal something, sometimes you just need a Band-Aid. Now, you need to fix the underlying problem, but I've had patients who come in, they are miserable, and I'm like, let's put this on, and here's the other thing. Patients feel immediately better when you put on a BCL. So remember, we got that in our pocket. Protective barriers. For these patients who are struggling at night, with nocturnal hypothalamus not closing their eyes. So the first thing you see there is an eye seal. This is a soft silicone sleep mask. It makes a seal around the eyes. You sweat underneath. It's almost like a terrarium. Patients love these if they can keep them on their eyes at night. The only problem I sometimes hear is in the next morning, they're like, yeah, I like them, but somehow they're always across the room when I wake up. And as you can see, they have tremendous sex appeal. So that's one of the other things with this. They're really helpful. Lid taping. Some patients can't wear these. Lid taping, there are specific tapes. The Sleep Right, Sleep Tight is actually made to be putting on the eyes so you're not pulling away the skin. Some patients get a little claustrophobic with that. Also, you can use these moisture chamber specs. I use these all the time when I was out here because, our environment's tough. It's dry, it's windy, you get a lot of dust kicked up. So that's actually a soft silicone gasket, and that's magnetic, so you can remove that. I had a ton of patients who love to haiku like those glasses. So sometimes you just need a good environmental barrier, and that works really well. Nighttime for patients, I will say, a lot of times I would combo this with either a gel or an ointment just to put an extra layer of protection on the surface of the eyes. All right, other treatments, aptly named, right? Other treatments. Allergies. Thankfully, at this point, allergies are, a true allergy is pretty easy. We've got great over-the-counter drops. So olopatadine, all you guys ever really need is Pataday once daily relief, extra strength. Why they needed a million Patadays, you tell them it's the green one. That's what it is right there. Get the green one, use it once in the morning. Alcaftidine is Lasticaft is also really good. If you look in the literature, those are the top dogs. Those are really, really good. They're once a day, really manage traditional allergies well. If you get bad inflammation, hit them with a steroid. You can do that. It can bring it down really quickly. Now, if you have patients who have VKC, those kids are really struggling with this chronically, Vercasia is actually a specific formulation that's used 4 times a day for kids with VKC. And then tacrolimus ointment. If I want to give you one of the biggest clinical pearls I can say that's very practical from my residency, if you have someone with atopic lid disease, the dry, flaky, chronically itchy lids, you'll look and sometimes they'll say use a hydrocortisone cream. I do not like using hydrocortisone. Why? It thins the skin. The eyelid skin is always already the thinnest skin in the body. It can cause depigmentation. If you get tacrolimus ointment, 0.003%, have them use that BID just a little bit on the lids. It works phenomenally well with avoiding all the side effects of a steroid. Typically, I say use it BID for a week, but you know what's interesting? Most patients actually self-taper. I don't know why, but it's been like universal. They kind of use it and they're like, oh, I don't really need it anymore. Then they've got a tube of it. Use GoodRx because this is super cheap when you use GoodRx. They get a tube. So works really well. Just let them know if they do get in the eyes, it is going to burn because it's not formulated for that. But works really well for atopic lid disease. Now, what if you have a breakthrough? What I mean by this is you guys have probably had this, an allergic patient who they kind of improve, but then they're like, yeah, like midday I start getting itchy. Sometimes I used to take an olopatadine and alcaftidine and I would mix them together. But now what I like to do is use different mechanisms. So there's this molecule called ectoin. Ectoin has been used in treatments of things like cystic fibrosis. It's been used in other products. It is this weird molecule. It's an osmolyte. It's actually produced by extremophilic bacteria. So these are bacteria that live in like sulfur springs. They live in deserts, salt flats. They live in harsh environments. And how do they do that, right? How are they surviving these brutal environments? They produce these molecules like ectoin. Think of a molecule of ectoin as like a magnet for water. What it does is if you put it into a water-rich environment, it's literally going to pull the water molecules in tight around it. And I kid you not, this is what they call it in the literature. It creates a water shield. I know it doesn't sound scientific, but that's what they do. So if you look at this diagram here, do you see those little kind of gray dots? Those are water molecules that are spread out. The darker black dots are a molecule of ectoin. And when you put it in there, do you guys see how the water molecules are pulled in tight? This is what happens if you put a drop of Ectoin onto the tear film, is it's going to pull in those water molecules tight, and now allergens, environmental irritants can't penetrate through to the surface. So this is like a mechanical blocker of allergens. So what I'll often do for a patient is I'll say, use your mast cell stabilizer antihistamine combo drop once in the morning, and then use this as the combo for it. So you're both working on the system that's active and then also actively trying to block any of the allergens from getting to the surface. And that drop is called Allegro that has this. Vasoconstrictors. All of us know this really well. Lumify good, Visine Clear Eyes bad, right? That's just that's the mantra we could say for this. If you ever wondered the reason why, it's because of the target. So Lumify is highly targeting your alpha-2 receptor, whereas your Visine, your Clear Eyes, are targeting the alpha-1. The alpha-1 is often found on the arterial side. Alpha-2 is often on the venous return side. The reason why you get the rebound redness with Visine and Clear Eyes is because you're basically cutting off the blood supply hose, and then when it releases, it dilates. It's basically compensating for the fact, hey, you were choking off my nutrient supply. I'm going big now to make up for it and get more redness. Because bromonidine works on the venous side, it doesn't have that rebound. It's more of a loose hose, if you remember. It's just trying to return this. So that's why you get less of that effect. So that's the reason why. Also, I'm so happy Lumify is now preservative-free. Hooray, what we've all wanted. So that's a great thing. It's really good at helping with redness, but I still tell patients we got to figure out why you're getting redness why you're getting redness in general. But from the cosmetic perspective, it works incredibly well. Then we have Upneek. Upneek kind of lifts the lids for those who need that. Gives a good little lid lift. That's oxymetazoline. That works on Mueller's muscle. That's the one that, man, I said this again. I actually gave this lecture, a similar one. I need to hold something that I can throw across the room. The reason for that is because I'd throw something across the room and all your eyes would get really wide and be like, you all just use Mueller's muscle. That's the one that opens our eyes more when we're shocked, and that's what oxymetazoline works on to lift any kind of that mild ptosis. Lash serums. Man, Latisse is the #1 eye drop that's not prescribed by us. Really, ask next time your patient gets Latisse, and it's probably from a dermatologist or it's from their GP. And the problem there is that we know the things you have to watch for, the hollowing, the periorbital darkening. We know about these. I can tell you there's a disconnect. A lot of times they're not aware of those side effects, so make sure you're talking to your patients about them if they're using Latisse. All right, punctal plugs. I would say this is a somewhat controversial topic, and this is why. Punctal plugs, obviously, it's a pretty straightforward mechanism, right? The idea is, hey, we want more tears on the surface. Let's plug up the drain. Makes sense. However, we do know that inflammatory factors are elevated in the tear film of dry eye and ocular surface disease patients. So are we risking just keeping an inflammatory soup, dirty bathtub water on the eye longer? That's what could be thought. Okay. However, there is a paper that showed that patients who got punctal plugs actually had a decrease in inflammation. So which is it? I'd say the answer is both. I think it's dependent on the patient. I've seen both. I have removed more silicone plugs than I've ever put in, and I've actually seen a lot of improvement when I remove those plugs. However, I will be diplomatic about it and say there are a time for plugs. However, when I say there are a time for plugs, I will not use silicone plugs because you're putting a foreign body in there, you're risking getting a granuloma, mechanical irritation. I will also, if I would use the temporary collagen ones, but again, I'm not a big fan. One thing I will personally, the hill I will die on, no punctal cautery. The worst ocular surfaces I have ever seen are those who have had the puncta cauterized. Let's think about homeostasis here. Would we really have 4 tear drains if we didn't need them? Tears need to drain, so the idea of literally permanently cauterizing them is just absolute insanity to me. However, I do think you can have some therapeutic effect. So while I said, I'm like, okay, well, what do I like? Personally, I think there's a better option. So have you guys heard of Lacrophil? This is newer, and what this is more of a lacrimal system occluder. This isn't necessarily punctal occlusion. It is a gel of cross-linked hyaluronic acid, and you actually just direct it directly down in there. So there's no plug, there's no sizing, there's no irritation issues. If you need to remove it, you just irrigate it out with saline. Personally, I actually don't think the major benefits you see from this are from the occlusion. I think it's because we are putting a depot of hyaluronic acid gel, and every time we blink, we get a little regurgitation of it onto the surface. For those of you who have used this, have you found it's worked better than traditional plugs? Okay. I always ask because I've had a lot of people who have found that they've really, really liked this. The one thing is I will say it'll take a bit of nuance getting used to this, but for me, this is what I would use. I just have found that this works better. All right, in-office procedures here. So Microblepharal exfoliation. This is your cleaning procedures. First one we had was BlephX. So how many of you use BlephX? Okay, yeah, BlephX was the first one that kind of started here. What I like to say about BlephX is it's a rotary motion. It spins in one direction. Newlids Pro, this is personally what I use, it has an oscillatory motion. The reason why I like oscillation, first of all, there's a picture up there. Does that not look like an electric toothbrush? Guess what? It does, and it's actually a great idea. Do you guys know the motion our electric toothbrushes use? Oscillation. The reason it uses that is because that's the most efficient motion for cleaning. There's a reason it specifically goes back and forth and not in one direction. So this uses a rotary motion. Now this next one here, there is nothing yet published on this. This is just a theoretical thing, so take this with a grain of salt here. If you do this, you can use Newlids Pro over the eyelid. That oscillatory motion, right, back and forth, you have that. The meibomian glands have meibum in them, right? Meibum is a non-Newtonian fluid. What does that mean? Ketchup is a non-Newtonian fluid. If I put a bottle of ketchup here and you tried to pour it, it's kind of thick at first, right? If it's just been sitting there, it's kind of thick. But when you shake the bottle, it actually becomes more fluid, right? You didn't heat it up, did you? No. Butter, you heat up and then becomes more liquid. Ketchup, you shake the bottle. The actual shear stress of shaking has liquefied it. Meibum is also a non-Newtonian fluid. So the idea here is possibly, this is again just what's been hypothesized, is that motion from this might be moving the meibum back and forth and making it more fluid. Again, like I said, grain of salt, theoretical, but it's an interesting thought. So you might get a little bit of that in addition to any of the cleaning effect. Then Zest, this is a good manual cleaning one. You can really kind of scrub that. You can see success with all of these, but I like to always kind of talk about the little nuances so you can kind of know what is going with each one. Okay, ocular surface lavage, rinsada. I love this. Have you guys got to play around with this yet? When I was first introduced to this, I will be honest, they're like, okay, here's this device. What this is just a high pressure saline irrigation rinse. And I was kind of skeptical. I'm like, okay, so you're telling me I have IPL, I have radio frequency, I have all these high level devices, and you're telling me a saline rinse will be helpful. I'm like, what is a saline rinse going to do that all my fancy equipment won't do? But I always make a rule, I'm going to keep an open mind, I'll try it. And it was a good reminder to me that sometimes things that are very simple work incredibly well. So what this is it's an irrigating lid retractor. So it's got that J-hook design and it's got 5 ports bored into it. It attaches onto a syringe and you press it down really fast and it's a high pressure saline rinse. You're hooking it under the fornix, right? Under the lid into the fornix. So you're actually rinsing out this area that's often not touched. This was actually created by a retinal specialist in the Pittsburgh area. His inspiration was he would always do a betadine rinse, before he would do injections. And he found that the technique of rinsing, certain patients liked when someone rinsed their way versus another one, and it's because they were trying to get into the fornix. Kind of lifted the lid and kind of irrigated under. So he's like, well, what if I made something that got there? So what really got me interested, though, is that he did a study where they looked at MMP9, right? They looked at the inflammadry, and it decreased after use. And for part of those patients, it was actually sustained past a month even. And I'm like, okay, I would not suspect that, right? That it stayed sustained. And then it finally made sense to me here, because you even see that all the way, 33% actually remained MMP9 negative at 12 weeks after the rinse. What I really think is happening is every time we blink, we renew the tear film, right? But we have the mucins and the glycocalyx. They're trying to keep the tears on the surface. I don't think we're completely renewing the entire thing. I think we're getting a little bit of residual kind of held on to the surface with each blink. This is like a pressure washer for the surface. What I think this is doing is that high irrigation is actually stripping it completely, and we are truly renewing the tear film. So I think we're kind of getting a reset of the tear film. That's why I think something so simple works well. When I do this on patients afterwards too, they feel immediately better. It has a bit of a cooling effect. So for me, I'm like, this one is great. I actually like to pair this with like new lids or any like cleaning procedure because I'm cleaning the lids inside and out. This works really well. This is also, it showed that these were just case studies, but there was an increase in non-invasive breakup time. There's an increase in lipid layer thickness. It's helped with SLK and lid wiper epitheliopathy. And then toxic conjunctivitis, they're, patient with glaucoma, chronic therapy. It helped kind of rinse away a lot of the preservatives. Easy thing in your office. The other thing is, this is great if someone gets like sawdust in their eye. Those things that get up into the fornix that are really hard to get out, those foreign bodies. You can rinse them out. A contact lens stuck up in there. They're like, I feel something in there. You don't see anything. You can flush that. Great for allergies. Remember, mucin comes from the goblet cells. They're in the fornix. This is just a very utilitarian thing. So like I said, this was a good humbling for me to remember that things can be simple and really, really helpful. All right, LipiFlow, iLux Tear Care. I've played with them all. These are the good old standbys. These are our classic, let's heat up the meibum and let's get it out one way. LipiFlow, entirely automated, right? You put the things on there, it's going to melt, it's going to pump on its own. iLux, you have a heating unit and you're manually going to do that all in one unit. Tear Care, this is where it's got a separate unit and you're manually doing it. So it's basically just what's your flavor of expression. Do you like heating on its own? Do you like it all automated? Really going to come down to what you prefer there. IPL. I have entire lectures on all of these, but I like to distill this down. IPL is great because it addresses several of the underlying factors that drive dry eye and a single treatment modality. MGD, it's been shown to improve meibomian gland structure and function. It actually is going to help decrease those pro-inflammatory vessels that we get with ocular rosacea, and it's reducing inflammatory factors, and it's going to decrease the microbial burden, kind of we talked around in the periocular area. Now, the way that this works is through photobiomodulation. I'm not going to force you to go through all of biophys again here, but basically, IPL is light energy. That light energy is absorbed by pigment. There is an enzyme called cytochrome C oxidase in the electron transport chain in the cells of the mitochondria, the powerhouse of the cell. We all remember that. We're good. What that does is it increases ATP production. ATP is cellular energy. With increased ATP, we have increased free intracellular calcium. Calcium is a key intracellular signaling molecule, so that's going to enhance fibroblast activity. It's going to modulate T cells, so you have increase in collagen production, you have a decrease in inflammation. It's going to increase macrophage activity, so those are the garbage trucks, they're cleaning up all the debris, and it actually decreases inflammatory factors. So it's really all based on light. That's what it is. That light's just a form of energy, and it's stimulating these cellular processes. What they saw in patients in the studies for this, so we do have one FDA-approved one, so that's what I'll say. So Luminous, the Optilight, their technology is the only FDA-approved currently that we have for IPL, and in the studies they saw there's a 53% improvement in symptoms. There is a 7 times increase in the number of meibomian glands that are expressible afterwards, a 3 times improvement in meibum quality, 1.5 time improvement in T-butt, and a 2.5 time improvement in the inflammatory factors. So there's lots of studies on this, so this was kind of just the summary there. Low-level light therapy. I'll be honest, I needed more data on this for a long time. Because for me, part of me is like, I can get a piece of cardboard, I can go down to Lowe's, I can get red LEDs and poke them through and tell you to hold it. Because this is that's what this is. This is a red LED array. However, I have found now, when you look at more literature, it seems like it can be helpful. It works through similar principles to IPL, but different. This is all just going to be red light, and it's going to be constantly shining at you. You're normally under this for 15 minutes, where IPL is quick bursts. And IPL is multiple wavelengths, so it's going to have red light, but it's also going to have green, orange, and yellow, so you get different effects. These two work really, really well together. So we're starting to find that these can be really helpful. So red light therapy, you guys have probably saw they're using it for AMD right now, too. So part of this is, again, photobiomodulation, mitochondria. The retina is the most energy intensive structure in the body, lots of mitochondria. So similar philosophy for its use there. Radio frequency, this is just a really refined heating technique. Now, this is really good for aesthetics because it really hits collagen well. But what you can do is you can actually specifically target the plane where you want energy, specifically heat energy delivered. If you have a lower frequency, it's going to go more deeply. If you have a higher frequency, it's going to be more superficial. So what you can do here is, if you do the protocol that's recommended for this device, you start where you're going at 1 megahertz, and that's going to get the energy level to about the plane of the meibomian glands. It's going to get that meibum melted. Then the second half, it's at 4 megahertz, so it's more of the surface of the eye. So it's kind of helping more collagen to kind of tighten the lids itself. So it's kind of got a 1-2 punch. When you use this with IPL, they found a 150% increase in the number of expressible glands, 70% increase in meibum clarity, and a 60% reduction in symptoms. So a really elegant way to heat the patient's any clogged meibum. This is the new kid on the block, DMST. Have you guys heard of this? So what this does is it's a small current, and it causes contraction of the orbicularis muscle. I've talked about that so much today. This is literally going to be like physical therapy for your lids. We are causing ourselves to blink incompletely. I actually think, again, this is one thing, I think we're actually weakening the orbicularis muscle, right? If we're partially blinking, that muscle's not working as hard, and I think it gets weaker at this. We also start to lose muscle mass every decade, about 3 to 5% at age 30 of all skeletal muscle, orbicularis muscle, skeletal muscle. So we lose muscle mass with aging. We lose tonicity of the lids. This is a way to basically restore that tone by contracting the muscle and strengthening it. It's the same reason why they've actually shown blinking exercises can be helpful, but the reason why they don't really work much is because patients just don't do them. It's just hard to do it practically. This takes the patient compliance thing out of the equation. So that's what you're doing. You're stimulating the contraction of the muscle. But here's the other thing. You're also pumping out meibum, because every time you get that contraction, you're squeezing and squeezing. So this is also a way that you can get meibum pumped out. And we see that in the results. So there was a 75% increase in lid tone, basically, so the lids aren't as loose because you've tightened that muscle. Blink quality, so the completeness, right? 70% increase. And here's the one. This is how that meibum secretion piece I talked about, 286% increase in non-invasive tear breakup time. How would we possibly be getting a better tear breakup time unless we were getting more lipid onto the surface to keep the tears on there longer? So this is something I brought in my clinic. I'm very excited about this because we know that blinking abnormalities are a huge part of dry, like I said. So this is one of our few things where we can actually address that lid laxity in our clinic with this treatment. So really an exciting thing. Okay, just some things about that we've got in the pipeline. So AZR-MD-001, selenium sulfide ophthalmic ointment. This is a keratolytic. The idea is this is going to be an ointment we'll put on the lids. So if the meibomian glands kind of have keratin over it, and even like kind of that obstruction, this can clear it out. Also, it's potentially shown that it might actually get into the meibomian glands and liquefy the meibum. So that's a good adjunct, right, to have something that can kind of clear that off the surface. The other one I want to mention is PL9643. This is a topical form of a melanocortin receptor agonist. Remember when I talked about the cortrophin gel and the Acthar gel? This is working on that same system, but in a drop form. So I'm very excited about that because this could be an anti-inflammatory drop using a non-steroidal pathway. Urcursimod. This is our first medication that is being looked at by the FDA for neuropathic pain. In my opinion, this is our biggest area of need. Our patients right now who need treatment for neuropathic pain don't have great options. This one is really, really exciting. It's potentially going to help decrease inflammation and might help nerve health. I'm really looking forward to that. And then ETX4143. It sounds like a name of a droid in Star Wars. But what this is this is actually a device that you put over the eye and you put this solution that creates an intense cooling and it actually targets the cooling on the long ciliary nerves at the lateral aspects of the eye. It actually disrupts the myelin sheath. Now, at first, my concern was, and it helps with chronic ocular surface pain. My thing is like, but are we just inducing a neurotrophic keratitis to make the pain feel better? But they've actually found a increased sensitivity after treatment. What I think is going on here is I think basically it's resetting the myelin sheath. It's basically like kind of the classic unplug, plug it back in. It's like, let's kind of reset the nerves. So early, but I'm very excited about that. That's an in-office procedure. So the fact that we have two things that might be specifically looking at pain, very exciting for me. And then all of these essentially, these are different forms of growth factors for the most parts. So these are all things that might be in the biologic realm. We have some peptides. These are all going to be targeted at trying to facilitate healing. All right, so that was a ton of information. I know that was like, I mean, and the sad thing is I go on there and there's still other things I think I'm like, well, I could have talked about losartan. I could have talked about all these other things, like so many other things we have. So the ones I would also say, losartan, don't have a slide on that. That's actually being compounded topically to help with corneal scarring, which is really cool. Also, don't forget about natamycin. Do you guys even remember natamycin? I had to be reminded of it. It is actually approved for fungal blepharitis. And the reason why I bring that up is there was a study that actually showed that 79% of patients who had chronic blepharitis, more or less the ones that weren't responding, had fungal cultures. So that's a problem solver sometimes. So that's commercially available, so that's natamycin. It's also used in making cheese. So if you like cheese, you should like natamycin. So so this is the problem is every single time I'm like things to add for next time. So those are little pearls at the end. So thank you guys again. I truly appreciate it. And then we'll be answering some questions. Yeah. We already got one here. That's something.
Yeah, I'd just like to know, do you believe that RK and LASIK is a big person to pain?
Okay, yeah, so the question is, RK and LASIK, are they a big precursor to NK? Absolutely, I think they can be. The reason being is because you're cutting a flap in LASIK, you're cutting through the nerves, so I do see that a lot. So the answer to that is definitely yes. I watch those patients like a hawk. Absolutely. Okay, yeah. Okay, like, which is it the heating devices or ones with light? Oh, the infrared. Okay, yeah. Okay, yeah. So the question was, what about the infrared devices, which are similar to the same idea to the red light, things that are ESP based, that, like, again, TikTok, they're all over the place, and I know that still. How do I know that? I just do. I think they can be helpful. From what I can tell, they're not quite as robust as our in-office treatments, but I think they might be helpful. It's that same idea of photobiomodulation. So these are like the red light devices, the masks that people can buy. They might be helpful with rosacea. I've seen that because they can be anti-inflammatory. So yeah, that's a great question too.
Awesome. Well, we have a million questions online that we couldn't get to, but Dr. Lappin was nice enough to put his information for all the virtual people. Sorry we didn't get to your questions. Okay, so virtual people, we'll take a break on your end. I see that the QR code is up for you guys for the CE. And then we'll return back here at 11:15 to hear from Dr. Mark Blumenstein. And then in-person people, we're going to take a break. And then the lunch buffet is set up. So please, use the restroom, get some fresh air, collect your lunch. And then at 11:15, Dr. Blumenstein will be giving his presentation. And then about the QR code, of course, everyone wants to know. We will have that at the end of the day outside. So as you leave, you could just scan it, and that will have all 4 hours for today. But if you guys are leaving after this and you're not going to be a part of the afternoon, just go see Hannah and Katie outside. They will have that for you. All right, see you back at 11:15.
Singing for someone, suddenly knew I had changed. I just got lost in your smile. I think you already know. I was pulled in by your dancing. You were the star of the show. First conversation, it was a warm summer night. It was the start of our story, and we both knew it was right. Oh, my heart has been taken, feels like I've awakened. No matter what you do, I'll always be loving you.
stuck in a daydream in paradise. That summer feeling. Oh, don't need no reason, just living life. No time for sleeping. So we broke some laws and we danced on cars all night long. Went to every bar underneath the stars, one by one. They told me to grow up, but I just can't help myself. Maybe I'm messed up, and maybe I need some help. Yeah, I woke up with a headache and my memory's all gone. And I spend all of my money on martinis and rum. Now I only got $1 till the end of the month. Should be sorry, but not sorry. At least I had fun. Oh, at least I had fun. At least I had fun. At least I had fun. Had good intentions, guess it went wrong, but I ain't tripping, no. So we broke some laws and we danced on cars all night long. Went to every bar underneath the stars, one by one. They told me to grow up, but I just can't help myself. Maybe I'm messed up, and maybe I need some help. Yeah, I woke up with a headache and my memory's all gone. And I spend all of my money on martinis and rum. Now I only got $1 till the end of the month. Should be sorry, but not sorry. At least I had fun. Oh, at least I had fun. At least I had fun. At least I had fun. I woke up with a headache and my memory's all gone. And I spend all of my money on martinis and rum. Now I only got $1 till the end of the month. Should be sorry, but not sorry. At least I had fun. At least I had fun. At least I had fun. At least I had fun.
You and me got a lot of tension, not even to mention. Oh, that night, just 2 weeks ago, it was 10:30. Thinking about leaving, suddenly when you walked in, you took my breath away. Should I talk to her? Should I introduce myself? What if I mess it up? I just can't believe my eyes. There's my girl that I know for sure. Never thought I'd meet somebody else like you, that can make me feel so good. All these years waiting for the one, never settle for nobody else. Now you're here, life has never felt so good. You got me thinking back on my life, wishing I could take back all that time with those other girls. I was so naive, thought I had it made, yeah, thought they were the best for me. But then you changed everything, yeah. Should I talk to her? Should I introduce myself? What if I mess it up? I just can't believe my eyes. There's my girl that I know for sure. Never thought I'd meet somebody else like you, that can make me feel so good. All these years waiting for the one, never settle for nobody else. Now you're here, life has never felt so good. Life has never felt so good. Life has never felt so good, yeah. So good, so good. Felt so good.
dream that can't be sold. We were right till we weren't. Built a home and watched it burn. I didn't wanna leave you, I didn't wanna lie. Started to cry, but then remembered I can buy myself flowers, write my name in the sand, talk to myself for hours, see things you don't understand. I can take myself dancing, and I can hold my own head. Yeah, I can love me better than you can. Can love me better, I can love me better, baby. Can love me better, I can love me better. Paint my nails cherry red, match the roses that you laid. No remorse, no regret. I forgive every word you say. Ooh, I didn't wanna leave, baby. I didn't wanna fight. Started to cry, but then remembered I can buy myself flowers, write my name in the sand, talk to myself for hours, yeah, say things you don't understand. I can take myself dancing, yeah, I can hold my own head, yeah, I can love me better than you can. Can love me better, I can love me better, baby. Can love me better, I can love me better, baby. Can love me better, I can love me better, baby. Can love me better, I didn't wanna leave you, I didn't wanna fight. Started to cry, but then remembered I can buy myself flowers, write my name in the sand, talk to myself for hours, say things you don't understand. I can take myself dancing, yeah, I can hold my own hand, yeah, I can love me better than, yeah, I can love me better than you can.
Breaking down and that's alright. I got a little bit of money to make me fight, and I'm fine. Trust me, I'm fine. I don't know where I'm going or what to do. I got a little fascination with IOUs, and I'm fine. Trust me, I'm fine. Breaking down and wasting time, but everything's alright when I'm spending my money with you. Let's just ignore the news. I know you know that California sure would be nice if we knew what to do. My money with you. Let's just ignore the news. I know you know that California sure would be nice if we knew what to do. Making out and that's alright. I feel a beat, beat, beating my chest gets tight, and I'm fine. Trust me this time. If you just believe me, you'll see I got to deceive me. It's playing tricks on me. Believe me, I can't breathe now. I can't breathe now. Breaking down and wasting time, but everything's alright when I'm spending with you. Let's just ignore the news. I know you know that California sure would be nice if we didn't want to spend my money with you. Let's just ignore the news. I know you know that California sure would be nice if we didn't want to do. Spending my money with you. Let's just ignore the news. I know you know that California sure would be nice if we didn't want to spend my money with you. Let's just ignore the news. I know you know that California sure would be nice if we didn't want to do.
You fuel a fire deep in me. This is where I wanna be. You're taking me higher. Ride the wave, taking flight. This journey, it sets me free. You're taking me higher, and I don't wanna leave. It's only you that I need. You set me free. Your voices, it calls out to me, even though you do not need to speak. 'Cause your eyes say, tell me how you feel for me. Without you close, feels hard to breathe. You brought to life a side of me. I thought I lost to misery. Into a love you hold for me. You're taking me higher. Ride the wave, taking flight. This journey, it sets me free. You're taking me higher, and I don't wanna leave. It's only you that I need. You set me free. Oh no, oh no, 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 oh no, no, no. Yeah. Oh, 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 oh. You set me free. Ride the wave, taking flight. This journey, it sets me free. And I don't wanna leave. It's only you that I need. You set me free.
Call my name. Come running a love so vain. It's black and white. See my ties undone, and I want you a hired gun. On moonlit nights, you look amazing. Every time we touch, and you say my name, it's something amazing. I'm feeling you so much. What a wicked game. Someone call the band and say, stop the rhythm. 'Cause I Every time we touch, then I feel your skin. It's something amazing. I'm just a midnight crush, but I'm sinking in. I'm gonna call back. 'Cause I feel like dancing. Don't stop the rhythm. 'Cause I feel like moving, and I don't gotta make you mine for life, baby. If you want me, that's alright. Just don't stop the rhythm. 'Cause I feel like dancing. Amazing. Every time we touch, when you move like that and push back, I'm a pull baby. Stop the rhythm. 'Cause I feel like dancing. Stop the rhythm. No. 'Cause I feel like moving, and I don't wanna go down for life, baby. If you wanna leave, that's alright with me. Just don't stop the rhythm. 'Cause I feel like dancing tonight. Baby, don't stop the rhythm. Don't stop the rhythm.
And I don't ever wear a suit and tie. Wondering if I can sneak out the back. Nobody's even looking me in my eyes. When you take my hand, finish my drink, say, shall we dance? Hell yeah. You know I love you, did I ever tell you? You make it better like that. Don't think I fit in at this party. Everyone's got so much to say. Yeah, I always feel like I'm nobody. Who wants to fit in anyway? 'Cause I don't care when I'm with my baby, yeah. All the bad things disappear. You're making me feel that maybe I am somebody. I can deal with the bad nights when I'm with my baby, yeah. 'Cause I don't care as long as you just hold me near. You can take me anywhere. You're making me feel like I'm loved by somebody. I can deal with the bad nights when I'm with my baby, yeah. We at a party we don't wanna be at. Trying to talk but we can't hear ourselves. Pictureless, I'd rather kiss them right back. With all these people all around, I'm crippled with anxiety. But I'm told it's where I'm supposed to be. You know what? It's kinda crazy 'cause I really don't mind when you make it better like that. Don't think we fit in at this party. Everyone's got so much to say. Oh yeah, yeah. When we walked in, I said I'm sorry. But now I think that we should stay. 'Cause I don't care when I'm with my baby, yeah. All the bad things disappear. You're making me feel like maybe I am somebody. I can deal with the bad nights when I'm with my baby, yeah. Oh yeah, yeah, yeah. 'Cause I don't care.
All right, everyone, welcome back to our in-person and virtual attendees. We have about 1,000 people listening in online right now. So first, I would just want to say thank you to Harrow. Harrow is the diamond sponsor of Dry in the Desert this year. It's their first time being with us at this event, and this event would not be possible without the generous support of all of our sponsors, including Harrow. I'm going to turn it over to Bill, and he is going to introduce our amazing speaker, who you guys all know very, very well, but thank you very much.
Thank you, Dr. Wu. Really appreciate it. Well, welcome, everybody. I'm so glad to see everybody here. My name is Bill Brunke. I'm a business engagement manager for Harrow. And Harrow is probably the largest eye care company you've never heard of course. We have 4 different divisions. We have an ocular surgery division, a retina division, a rare and specialty division, and of course we have the division that Dr. Blumenstein is going to talk about today. But we represent products across the portfolio like Vercasia, Natison, Vigamox, Maxitrol, lots of things that you probably are really familiar with, and we'll be out here during the break if you guys have any questions about what you hear today or any of the other products too. But I want to introduce Dr. Mark Blumenstein. I think you all know Dr. Blumenstein. He's a local guy here. We're really honored to have him. He speaks across the entire country. You have a great asset right here in your hometown in Phoenix. But I want to just welcome you all to the presentation, and Dr. Blumenstein, I'll hand it over to you.
Thank you. How's everybody doing? How's the food here? Culinary Dropout. How's the food out for the people at home? Their food's probably better. The chicken's great. Yeah, I'm actually, here's a fun fact, if anybody cares. I am actually allergic to all poultry. My throat closes in, I can't breathe. So literally, if there's chicken broth, if there's duck, if there's quail, little baby quail, if turkey, I have not eaten that in almost 50 years. So yeah, enjoy the, thanks for that, for the chicken. So I get the honor of coming into a meeting that's called Dry Eye in the Desert to talk to you about a specific product that you can use where it's not just in the desert. And I think all of us that live here, and for those of you that are online, you have to understand something. This meeting should be called Dry Eye Where You Live, because it is effing everywhere, if I can say that and not be so kind. Moreover, for the people at home, you can't see, but there are a few people that chose to put their backs to me. Haters. I'm just pointing at you two right here, okay? This is the reason why you come to these meetings live, so you can just go, you know what? I don't give a crap. I'm gonna sit with my back to the dude, and I don't even care. So we're gonna talk about putting your patients on the fast track. You've had some great speakers, and more importantly, I know especially for the people who are virtual, in the next hour, they're gonna hear from Dr. Kramer out in Florida about opportunities for us to manage a disease state that, quite frankly, every single optometrist should be looking at and asking themselves, why am I not doing something more? If you go into your practices tomorrow and your first thought is, you know what, they can just go buy some of those generic drops that they read about in the news last week. I don't care. I know they're recalled. Let them live their best lives. If you think that's a treatment, then you have to ask yourself, why are you walking into an exam room? Because to me, this disease state affects every single aspect of our patient's lifestyle, but more importantly, it's what drives them into our practice. They don't think they're seeing as well. And to me, the ocular surface is the place that we have to start managing. We live in a time now where you guys have so many great options. You have so many opportunities to manage these patients, and it's not just pigeon-toed. 25 years ago, you had one choice, to do something or not do it. Right now, in 2026, you have opportunities to write prescriptions that are going to basically manage your patient's conditions, but also fit into their specific lifestyles. And that's what we're gonna talk about today. This is a product that, and Phil's 100% right, their company and this product is probably the most unheard of and yet largest opportunity for us in optometry. It's bizarre. You say Harrow, people go, hair what? Hair, huh? You say Vivi, some people go, okay. I'm gonna tell you what makes this drop unique and why you should consider this as a treatment for your patients. Yes, I'm being paid by Harrow. Once again, never enough. So if we can talk to the people that be, never enough. They offered me chicken. Let's see how that's gonna go. Everything that I'm gonna talk about today is in their, you can read about this in their product insert. Everything that I'm gonna talk about today has also been evidence-based. But the other thing that I always like to comment on is that some of you are sitting here thinking, okay, this is promotional. Mark's pimping hard for Harrow. Okay, he's already said he got paid. But more importantly, I'm not getting C out of this. Do I really care? Should I sit with my back to him or should I arch it uncomfortably? I like that. This is continuing education. You guys come to these meetings and you hear from speakers, like Corey, or you hear from Elise, Melissa, and they're telling you things that they're seeing in their practices and how we can manage better. But then you walk out and speak to the exhibitors, and you speak to the companies, And they tell you what makes their products unique and what makes them different and how they can help. And if you don't take that into your lane tomorrow and say, what can I do different today that I was not doing yesterday or 10 years ago or 20 years ago, then the only people that are suffering are your patients. So I hope you take some of this and you say, okay, how can I integrate this into my practice? This is me. More importantly, yes, I work in town here. I've been here for 32 years, 32 long, hard years. Hard. I had a lot more hair when I first started this, but I don't anymore. We can talk about the fact that, this disease state affects every single one of our patients. If you tell me I only see glaucoma patients, boom, you're seeing a ton of ocular surface disease, specifically dry eye. If you say that, you work in a cataract and refractive surgery center like I have my whole career, I will tell you my career is based on patients coming in saying things don't look as sharp. And my first response is, are you doing something about your ocular surface? And they're like, yeah, went to Costco, picked up some Refresh, living my best life. And I'm like, no, you're not. You're not living your best life and you're not doing anything to help yourself. Refractive surgeries, but more importantly, what about you contact lens people? I saw Dr. Egger walked out of here. I was gonna point at him because he's been doing contacts since I think the beginning of time, 1902. And if you don't believe me, just ask him, he'll tell you. Contact lenses, this is a thin piece of plastic sitting on top of the most vital organ in the human body. I venture to say that if you went to the FDA right now and said, hey, we've got this amazing ideas. What if we took plastic? What if we curved it kind of around the cornea? What if we stuck it on patients' eyes? We gave them the ability to wear it and never take it off because they are called dailies and they wear it every day and they maybe never take it off. It's going to deplete the oxygen by 80%. And more importantly, you know what? There's no mandate that they come back. Do you think the FDA would say, oh, hell yeah, that's a great idea. We should do that? I don't think that soft contact lenses would get approved in this market. I think it would be much, much harder. To me, I look at soft contact lenses as a privilege, but I feel like we have to manage those differently because when you look at how many of these patients have significant amount of inflammation or what we call dry eye. The other scourge right now is the fact that there is too much to do on our phones, our tablets. Okay, I said pluribus to somebody the other day and they went, what's that? I go, oh, girl, you're not watching Apple TV? Oh, hell no. Okay, oh no, we're busy watching Downton Abbey or watching, what's the other one? Bridgerton, ooh, season 5, hell yeah, oh my God. Heated Rivalry, this table over here, Heated Rivalry, yes, I knew it. My point being is that every single one of us, just like our patients, and some of you, I'm sure the ones that are at home right now who are looking at their monitors, which is probably a split screen, or they have their phone on their lap, yeah, I see you. Your camera's on, we see you. We're spending so much time doing things that are inducing this evaporative state that we're not thinking about the opportunities that we have to help manage those. I always feel that my responsibility as an optometrist is to tell my patients something they don't know. So if I walk into a lane sometimes, I'll go, by the way, those glasses are hideous, just want you to know that, or whoever cut your hair was blind, just little things like that. But I also think it's important for us to say, look, I want to do something to help you so that you can keep watching Breaking Bad and watch it over again. Season 3, starting it over again. And has anybody seen Breaking Bad? How many people here have seen The Pit? Okay, do you know that in The Pit, Bryan Cranston's daughter is the one who's kind of like super kind of like, she's like on the spectrum, the doctor that's on the spectrum there. If you go back and watch season 3 of of Breaking Bad, she's on the show. It's so bizarre because she was like one of the high school students and she raises her hand to basically say, yeah, that plane crash was really horrific. So if you guys know, you know, you know. It doesn't matter, my point being, I spend way too much time online and our patients are too. To me, when you talk about what are the symptoms that drive us to this disease state, 25 years ago, when we started defining dry eye, it was so ambiguous because we used a term called keratoconjunctivitis sicca. And everybody's like, well, what's KCS? And if you asked one person, they would tell you something. You asked another person, they would tell you something completely different. We were looking for staining. No staining, they don't have KCS. You know, patients would come in and say they have no problems, they don't have KCS. If you notice, the FDA has changed the language. And the language now says dry eye disease. And to me, dry eye disease affects your patients in so many different ways, but the number one way that I tell you that it affects it the most is by creating a change to the quality of their vision. We can sit here and talk about, challenging wearing contacts, and I know that if those of you that fit contacts will tell me, Mark, it's the fit of the contact, it's the fit of the jib, or it's the solution they're using, and I'm gonna tell you no, that it's absolutely the ocular surface. We can look at patients' work productivity. When a patient says to me they're having trouble driving at night, then my first thought is their cornea getting a little swollen? Is there a little bit of edema? Is there dry eye in those patients? But when a patient says, I feel like my vision's not as sharp as I think it should be, then I'm instantaneously thinking about the ocular surface for these patients. All of these symptoms are never going to drive a patient in to say, I have dry eye. They're gonna come into your practice and say, I thought it was time for an exam, or I kind of feel like I need to update my prescription. And I always look at those patients, and I think I'm glad you came in here today because we're gonna do something different. I look at every single patient and think to myself, your eyes are dry, or you have ocular surface disease until you prove otherwise. Now, with all that being said, this is a slide that every single slide deck has. They love to show this progression, but you know what, people? This is reality, is that something starts small, right? One day I was it's about 25 years ago, I was in a mirrored elevator at the Venetian, and I saw some flickering behind me, and I kept looking to see what the flickering light was, and the dude goes, it's your bald spot, okay? You're going bald, bro, okay? At that moment, I should have thought to myself, how can I slow down the progression of this? And I didn't. And so now people think I look like Stanley Tucci. It's okay, though. It's okay. These people last night at a restaurant were staring at me, and they said, is that Stanley Tucci? And I'm like, so. With that also being said, is that by disrupting the tear film, however you disrupt it, put on a contact, have LASIK, put drops in your eyes, okay? Spend too much time on a tablet, you're going to change the quality of the tears. The tears in turn basically increase, or it increases osmolarity, decreasing your evaporative effect, which in turn causes inflammation. How many of your patients are using things that are helping getting the red out? I went to my dry cleaners on Thursday. The kid pulled out some Rotov redness relief. And I go, stay off the weed, bro. And he goes, what? I go, your redness reliever. He goes, no, my eyes are irritated. I go, then why are you using that? Well, they're red too. And I'm like I said, okay? But I'm like, I go, there's better drops that you could use. I go, do you have an eye doctor? He goes, no. And I go, well, good luck finding one. I didn't want to be his, so. We know that when we disrupt this, it changes everything. It fluctuates. It's different for each person. So your management of this has to be managed differently for each person as well. You know, the common denominator that we still know is that you start off with that evaporative effect. You start off by changing the quality of the tears. Our patients aren't doing things to change that, okay? There is a lot of fork dropping going on here. I feel like they're trying to throw them at me and you miss, okay? Is that we see aqueous deficient, we see evaporative, which we know is about 87% of our patients have a combo of that. And more importantly, what does that do? It triggers inflammation. How many of you guys are in your mind thinking, I need to put somebody who has chronic dry eye? And what I mean by chronic dry eye, the patients that don't want to get out of their contacts. The patients that you see that have a ton of meibomian gland dysfunction that are not doing anything to manage that. Those patients that are using lubricating drops 4 to 6 times a day. The patients that come and tell you that they're putting redness relief drops in their eyes. I look at those patients and I think you're on this wheel already. More importantly, we start thinking about the options that we have. I get it, people. I walk into a lane sometimes and just question all of my life's choices at that moment too. When patients say, how are you? I pause for about 10 seconds before and then I go, I'm good. I'm good. I'm good. How are you? Good. Okay. I sometimes will tell them I don't have diarrhea today. I was on a big thing with diarrhea and that scared people. But when we think about doing something, I get it. It's easier just to sit there and say, hey, you know what? Keep your eyes lubricated. Hook yourself up, go over to the Costco or Walmart, you know, but watch out. No, I don't really care about you. Yeah, get those. Is that patients have opportunities, and you do too. You know, the one thing that's beautiful about our profession is that let's say you're not going to bring a device into your practice to help your patients. There are plenty of ODs in your neighborhood that basically have dedicated their life to managing the patients you don't want to manage. I love intra-optometric referrals. I can't do a scleral lens to save my life. I cannot do an RGP to save my life. I'm not good with soft contact lenses. I'm not really sure what I'm good at, but more importantly, we don't have all the cool stuff in our practice. So I will find somebody who's in town here and I'll say, you know what? I know the doctor up in Surprise who has that device. She's a little cray-cray, but you know what? I'll get you scheduled with her. Or I know somebody who has a dry eye dedicated practice who has those devices. To me, this is not an option to sit there and say, yeah, you're good, just keep using your drops. It should be, look, the next stage is to do something to help open up those glands or decrease the inflammation. We know that lubricating drops are important. Do you guys notice that I refuse to say artificial tears? Because there's nothing tear-like about these. The lubricating drops are important, but to me, they're just as important as putting a mint in your mouth after you ate curry. Okay? They're gonna last for a few minutes until Boo goes, woo, or your cat or whoever you're going home to is gonna be scared by that. They're nice to know that they're there for that moment, but they need something more to manage it. Nutraceuticals is also a good kind of like thing in the background. Again, I'm a little more practical. You know, when I tell a patient, you know what, you need to eat more or you need to have more, and they're like, I'm doing it, and I'm like, okay. You know, I'm not gonna browbeat them, but we have great options now. We have over-the-counter products that are once a day. More importantly, we have nutraceuticals you can sell in your practice. But still, the cornerstone of what we do is prescription medications, is where can those come in and break this chain? Where can we stop the progression? Where can we be like Susan Powter and stop the insanity with these? If you're old enough to remember Susan Powter, thank you. If you're not, don't worry about it. We know that 25 years ago, we took, you know, UGA, you know, the University of Georgia Bulldog. I think UGA was like UGA 3 or something. And you ever notice that bulldogs always have that big, thick, black kind of like stuff between their eyes? That's mucin. These bulldogs have a tremendous amount of aqueous deficient dry eye. So at the University of Georgia, they said, you know what if we took this immunomodulating anti-inflammatory medication called cyclosporin, and we figured out a way to lubricate it or to put it into a topical formulation for dogs. And you know what? UGA was the first one, and they found UGA wasn't complaining. I mean, I don't know how they got the symptoms from UGA, but they saw the signs were tremendously better. And that has been around for 23 years. This is treating the inflammation by basically going to these factor kappa, and basically going to these neurotrophic kappa or factor kappa, which inhibits the activation of these pro-inflammatory cytokines. And I get it. It's funny, as I was looking at this slide earlier, my wife walked up to me and she goes, do you guys know what all those things mean? I go, hell no. I go, but we do know that inflammatory mediators are what drives this process. And if you can slow down the inflammatory mediators, if you can slow down the process that is affecting your patients so they can stay in their contacts longer, so they can wear those amazing glasses that you sold them from your optical, so that when you tell them that blue blocking computer glasses are hideous, they're contraception glasses and nobody should wear them, but you have a better option for them, which is to basically manage their ocular disease, then they're gonna help. So when you start thinking about what this does by suppressing T-cell apoptosis and decreases T-cell activation, the cytokines are what drives that inflammation inside the eye. More importantly, when we think about putting a patient on a medication, the challenge that we have, and I get it, and you know what? I can't not stand up here without in good conscience and say that access is one of the hardest things that we have to do, and I get that. But the second thing that I think is the hardest thing is that if you put a patient on a prescription that has a lot of side effects, or takes a long time to work, or you have to sit there and have a 10-minute conversation with them, your patients, they're not gonna listen and they're gonna stop. Which is why we see that, you know what? How many patients? 70% of patients discontinue using these drops, and 29% remain on the therapy after 1 year. But I also have another theory to that. And my theory is that with this disease state, What is the end game? You know, like with glaucoma, you can go, your pressure was here, now it's here. You know, with hair growth, you can go, your hair was here, now it's here. With anything we do, your vision was 2100, now you're 2020. What is the end game of this disease state? And I think that's the hardest thing for us to do. To me, what I like to do is give my patients realistic expectations. We're managing this, people. You know what? We're not curing anything. And to me, by managing it means is I don't want you to have to use your lubricating drops more than you're using them. I want you to be able to stay on your computer as long. I want to see if we can't decrease the change to your vision. So to me, what I try to tell patients is, look, the metric we're going to use is the fact that I believe you need to be on this as your eye doctor, and I'm going to look for the signs, but the symptoms may not always correlate. And so I always try to let patients know, look, there's no reason to stop any treatment we do unless I tell you. Then take us back to access. Then the access part comes in. And that's when I usually have to have my conversation about why the product that I prescribe for them is important for them to get. And what are the characteristics, what are the qualities that make it different? So what's important is to know when you're prescribing something, what makes this different? I love oversharing a little bit with patients, and part of the reason why is because I think sometimes they question whether or not I'm actually a real doctor because of the way I come in and tell them I have diarrhea, or the staff is coming in and out and I'm just like, what up, girl? You know, or I had Skittles in my pocket once and a patient came in 2015 post LASIK and I go, you want one? And she calls the office and says that I was unprofessional and she didn't appreciate me offering her pocket candy sweet tarts. And I'm like, whoa, they were freaking Skittles, okay? But, so I oftentimes feel like I want to give my patients what's in it for them, the WIFM. And when I prescribe something, I will tell them, look, there's a lot of opportunities, a lot of other options. Let's start with this drop. And you know what? Hopefully, my staff and you can work together and we'll be able to get this in your hands. And this is why. And so when we start talking about products, it's important to know what makes them different. We mentioned before that cyclosporin's been around for, what, 23 years. 0.05% cyclosporin. To me, I love to tell a patient, look, you've been on this drop for a hell of a long time. That's great, but we now have a new and improved version. Twice the concentration, but more importantly, it comes in a different vehicle. Before I mention any, ooh, is that gonna black out the people at home too? Ooh, cool. Does it? Does it black them out too? Sweet. Okay, I'm still talking, people at home, okay? I'm being dramatic. Is that one of the most important things you can do when you write a prescription is the active ingredient is as important, but as important is the vehicle. Is, you know what gets you there? It's an analogy that I've given patients before is that, you know what, we could both fly to Europe. You could be on Spirit Airlines, and I'm taking Air France, mofo, you know? Or we could drive to California. I go, you're on the back of a donkey, and I'm flying in a Learjet. I go, how we get it there is just as important as where we're going or what we're trying to accomplish. When we think about VEVI, this is cyclosporin solution 0.1%. All the standard things here, this is indicated for the treatment of the signs and symptoms, and do you remember what I told you a few seconds ago? Dry eye disease. You don't have to sit there and try to conjure up what KCS means in your mind. You don't have to find 100 different tests to validate it. Dry eye disease is pretty simple. H04.123. Okay? That is the code that I would tell you to use. You use cyclosporin for other things, you might have to go with the H16.223. And for those of you that haven't memorized your ICD-10, shame. Shame. Okay? Because I get that driven into me all day long. When we start thinking about the potential for eye injury and contamination, I ignore this part because, again, I'm still hardcore on managing patients that get abrasions. It pays for some of the things in my house. So let them abrade their corneas. Let's get some amniotic membranes on there. Viva, let them contaminate it. Contact lenses, there's still not an FDA trial that has ever been done where patients can wear their contacts. So you know you just got to let them know, take out their contacts, wait 15 minutes before they put their contacts in. And then we'd start looking at what are the adverse reactions. There was a little bit of installation site reaction, there's about 8%, and a temporary decrease in vision of 3%. The beautiful thing about this drug is that when you prescribe it for a patient, the part where you say what to expect, there isn't anything to say. And that's as good and sometimes a little more challenging, because this drop doesn't burn. This drop doesn't cause their eyes to turn red. They don't start tearing. They don't have issues when they come back being on this medication. In fact, they'll say, is there really drop getting in my eye? And the only way that I've ever really been able to tell patients is close your eyes, blink a few times, and you might see a little bit of some blurred vision, as we see here about, what, 8%. Okay. More importantly, what I will share with you is that this is the first and only water-free cyclosporin. This is dissolved in a semi-fluorinated alkane, and this is for the signs and symptoms of dry eye disease. The water-free is important because if you ever wonder why your bottles are always so big, or if you have suspensions and you have to shake it 20 or 30 times, why that big plop gets in there and patients let it drip down their face, is because it's diluted in some form of water. When you don't have that water aspect, the drop does not need to be the same size. It could be like 1/20th of the size that your patients are getting. Being first and only in a cyclosporin that's approved for both the signs and symptoms of this dry eye disease that we just talked about. More importantly, that water-free cyclosporin, and it's also the only one that is in a semi-fluorinated alkane, and that is what the vehicle is. This is VEVYE. The other thing about this is there's no pH, okay? There's no water, there's no preservatives. In fact, there's no osmolarity, and they get that tiny little 10 microliter drop size. You have those fussy patients, we all do. The ones that go, I'm allergic to everything. I'm like, VEVYE. Those ones that say, oh, the last drop you had me on burned like a mofo. VEVYE. The ones where they sit there and say to me, you know what? I have other reactions. Like I kept getting hemorrhaging on my toes. Like they were black and blue from that last drop you put me on. I go, seriously? And she's like, yeah. And then this is an honest to God true story. So I stopped using it. I go, that's really strange. I go, well, let's try something different. She comes back, she goes, I'm still getting the black and blue marks. I go, really, why? I go, that is so bizarre. I go, we got to write you up. Call the FDA, do something. So then the next time my sergeant came in, and I said, oh, how is your feet? She goes, how'd you know about my feet? And I go, you told me that it was the drop. She goes, no. She goes, I realized that I was sleepwalking in the middle of the night, and I kept banging into stuff. And I'm like, you need to see a different doctor in this practice. Okay, bye. Yeah. This is the perfect drop for those patients that use the excuses to say why they're not filling their prescriptions. You all get them, right? I'm going to fill this out. No, I'm allergic to that. You don't even know what I said. I'm sure I'm allergic to it. I'm allergic to everything. Okay. In fact, I'm allergic to you, and I want to leave. No preservatives, no osmolarity, no water, no pH, no nothing except the molecule and the semi-fluorinated alkane that we want to have in there. If you don't know what semi-fluorinated alkanes are, you're just not listening, okay? These are colorless, amphiphilic, non-aqueous liquids that spread rapidly across the cornea. And that rapid spreading is what enables these to basically improve the bioavailability of any product that is dissolved in it, hence cyclosporin. Because do you remember, cyclosporin needs to go from the outside of the cornea to inside the anterior chamber to get to the lacrimal gland. Okay, there's water and there's also lipids. Cyclosporin does not like to be in water. So you have to cajole it. You got to kind of put it in there and kind of shove it in and get it where it needs to go. So kind of putting it in a Trojan horse or like some form of some liquid that's going to kind of like push it in there is what we need. So this liquid that dissolves in both hydrophilic and hydrophobic is really nice. More importantly, it provides a low tension, low surface tension, as we can see right here. Look at the spreading on the left-hand side there. You see how nice and beautiful that spreads, and this is perfluorobutyl pentane. And this is the vehicle, the specific vehicle that is in VEVYE. When we start thinking about peripheral butylpentane versus cyclosporine delivery, so you could take 0.05%, have it in a different delivery device, or you can take 0.05% and put it in peripheral butylpentane. And what do you see here? 22 times more cyclosporine gets into the cornea than Restasis, okay? Branded Restasis. Now, if I can also, my friends, take an editorial moment here, okay? I was all in. I was hardcore. I probably have more patients that are still on Restasis or Restasis or Restasis, whatever they call it, okay? That drug. And part of the reason why is because I truly believe and I bought into the fact that inflammation is the root cause. And we have to nullify that, manage it. But ever since this became generic, I have lost sight of what my patients are really using. Do you remember what I told you a few minutes ago? Is that the vehicle, right, is just as important as the molecule that it sits in, okay? So we don't know what the vehicles are on these generics. We know that your patients are coming in saying, oh, you know what, I get Restasis, but it's not Restasis, it's cyclosporine 0.05%. Those are the patients that I'm immediately taking off of that drop because you don't have control over what they're putting in there. And to me, you need to know what they're using. And when you look at a slide like this, where it's a head-to-head comparison, and now you see that there's 22 times or 22% more of that molecule reaching the tissue that it needs to, my question to you is, why do you still have them on an inferior product when you see something that's advanced and become more superior? In this phase 2 study where they looked at efficacy, safety, and tolerability, you see how VEVI performed against perfluorobutylpentane, the vehicle, and it's always gratifying when you see that a vehicle can actually have some clinical efficacy, that it's not just the molecule of the action of the molecule, that the vehicle actually is carrying a little bit of action with it, just by covering the cornea, creating that surface tension that we talked about before. When we start looking here, this is a change in baseline of total corneal fluorescein staining. To me, when I think of staining and I see corneal staining, I think inflammation. To me, S means put them on an anti-inflammatory. Okay, having an immunomodulator that's humming in the background, but more importantly, has the opportunity to do what this does, this is impressive. So here's the clinical trials. I know everybody gets super excited. You're like, dude, shut up, just get to the clinical trials. I hear you, people. I hear you, okay? The clinical trials on how this drug got to market and why it got to market. And so what Harrow did is they had the Essence 1, which was a 12-week study, and we look at what was the primary endpoint. It was to look at the change from baseline in total corneal fluorescein staining. I love when we use fluorescein staining for an immunomodulating anti-inflammatory versus tear volume. Tear volume or Schirmer scores demonstrates, yeah, they're making more tears, but is it doing anything? By changing the superficial punctate keratopathy, by changing the affect of that apoptosis, by changing that downstream effect of everything that's happening upstream, then you know this drug has efficacy. So that was our primary endpoint in Essence 1. Essence 2 is only a 4-week study. And a lot of times patients look at things like this and think, well, why is it less? And the FDA basically looks at the efficacy as these are going along and determines how long studies need to be or how many patients need to be enrolled. Primary endpoint, again, was the change from baseline in total corneal fluorescein staining at day 29, and then also change from baseline in dryness score at day 29. It was OSDI in Essence 1, and it was dry eye score in the Essence 2. And then there was the safety study. And this was a 52-week study that basically was kind of used Essence 2 patients, extended it out, looking for safety standpoints like visual acuity, as well as change from baseline of some of the other endpoints, dryness, Schirmer scores, and other of those exciting things. So let's just get to the data here, okay? First and foremost, when you do a clinical study, you basically separate the cornea into 5 different regions. Each region has 0 to 3, so you could have a total score of 15. A 15 is never a patient you want to have in your study because those are hardcore, hella dry eye patients. But if you can take a 15 and make those patients look a lot better, then you know what? You know you've got a good drug here, okay? So this is how you do the scoring here. And what we see here in both Essence 1 and 2 they were measuring the change from baseline of total choroidal fluorescein staining. You see that there is a clinically significant improvement from baseline, day 0, day 15, and day 29 when you're using VEVI. Compared against the vehicle, and again, knowing that the vehicle kicks some butte, then you know you're using a drop that has that efficacy. When we start looking here at the meaningful improvement by day 15, 3 or more grades of improvement. So basically, as somebody who was a 12 now is down to a 9, or somebody staining was a 5 is down to a 2, you basically see 56% improvement, or 57%, okay, in day 15, and it keeps getting better. The longer these patients stay on this drop twice a day, the better they get, and you can see there's a 65 or 67% improvement, give or take, right there. When we start looking at total corneal fluorescein staining improvement through week 56, again, the longer you can encourage your patients to stay on this, having this immunomodulating anti-inflammatory drop that's waterless, colorless, pH-less, no osmolarity, barely does anything except work. It's a workhorse. You see there's a 52% reduction in these patients' total corneal fluorescein staining. We see Schirmer's improvement, 98% increase in their Schirmer's, which implies to you that you're helping that lacrimal functioning gland. You're helping them secrete better quality of tears. And we also look at the safety profile. To me, why is the safety profile important? Because you have choices, people. You need to pick your warrior. You need to pick the drop that you're going to fight for your patients to get. And again, I'm going to go back to access. I get it. Don't come at me. I hear you. Because I know when I'm done, somebody's going to say, but, and I'm going to say, no, okay? No buts. Is that you got to look and see how you're managing and helping your patients. When you look at Essence 1, Essence 2, and the OLE study, you go across the board here and you think site installation discomfort, okay? I do a lot of clinical studies. And the number one thing that patients, when you ask them, do you have any, adverse events, is there anything, they always feel they want to say something. I think they feel like disingenuous if they don't say something. So they'll say, oh, well, it burns a little bit. The minute you say it burns a little bit, then you have to say, well, how long? And when does the burning start? So every study you'll see 10%, 15%, 20%, and I take those with a grain of salt because it's medicine. But when you see numbers that are basically 4%, 2%, okay, you start seeing patients that basically, when you start thinking about mild discomfort, these are ridiculously low numbers that validate that having cyclosporin in a semi-fluorinated alkane is an opportunity for your patients to stay on this drop, aside from the efficacy that we just saw a few seconds ago. Okay? 0 severe installation site pain over 3 studies, over hundreds of patients. So I always love when I tell a patient, look, this is like no other drop I'm going to prescribe for you. In fact, you may not even know you got it in your eye, but trust me, you will. And more importantly, trust me that this is going to work. 99.8% of patients experience no or mild installation site pain. And you remember how, like, when these drugs always came out and everybody, all the competitors would like to go, oh, but there's burns, and oh, but this one burns even more. How'd you like to be this one where you come in and go, yeah, whatever, let them fight over there because we got nothing, okay? Patients do not complain about site installation discomfort with our drug. We start looking at, discontinuation rates. That's another thing if you ever look at clinical studies. How many people go, yo, I'm out. I'm doing a study right now where I have to draw blood. And we have to get 25 microliters of blood. It's a tiny little amount. And so you have to squeeze. The subject that I have, her finger got bruised. And she goes, yeah, I can't do this anymore. And I go, excuse me? She goes, I think I'm going to drop out of the study. And I'm like, what the fuck? Are you kidding? And I looked at her, I go, and she's my wife. And I go, why? I go, no. I go, you're nuts. She goes, look at my finger. I go, oh. So my point is that it takes a lot for people to drop out of studies because we beg them to stay in because it's hard for us to keep patients in studies. But when they want out, you got to let them out. So you look at the discontinuation rate here, this is practically nothing. For long studies, short studies, patients will stay in them when they perceive it's doing something or they don't have a lot of ancillary side effects. And we look at the visual analog score improvement, 38% reduction by day 56. Week 56, 22% improvement in self-reported discomfort. That is a key factor there. I don't listen to patients. Their symptoms mean nothing to me. What I do is I look and I tell them what's going to be in their best interest. And with that being said, when you're in a study and you say to a patient, do you notice improvement? And they self-describe it, as opposed to me saying, like, do you have glare? Do you have, fluctuating vision? It's really critical when a patient advocates for something. So I love these numbers, but I'm going to tell you, do not solely just go off symptoms. Go off of what you know is best for your patient, going back to those slides we saw 50 minutes ago, before you had food coma from all the chicken you guys are still eating. And I do want to say there is more chicken, and there is more Sammys. So get a to-go box, make Woo You worth it for you tonight, tomorrow night, the next night. And if you're on GLP-1, this is going to last you a month, okay? You'll eat an eighth of it tomorrow and go, so full, okay? So we start thinking about improvements that were in the study, 3 or more grades of improvement with statistically significant improvement across the reading speeds, looking at screens, fluctuating vision, all the things that are critical to your patients that I told you at the very beginning. Super important, super critical. But let's cut the BS. I like this. Some people may not, but the BS stands for burning and stinging. I like it for what it really means. Let's cut the BS, people, okay? When you write a prescription, you want to be able to tell a patient, look, I'm here for you. I'm going to advocate for you. If you're not writing prescriptions and sending them to a specialty pharmacy that your pharmaceutical company has aligned with, then you're not helping your patients. Okay? So these patients can get this drug as little as 0. I love when a patient comes in and goes, hell yeah, mine was 0. And I'm like, yay. And I also get the patients to come and go, I'm not covered, it's cray-cray, and my staff has to work with it. But when you start realizing that there are ways that they can back out their insurances, patients can pay as little as $59 with commercial or $165 for a 90-day supply, there's no reason for you to not advocate for your patient. A drop that you think is important and you think is going to benefit these patients. I'm not going to do the case studies. I'm going to skip through the case studies. I think you guys all know these people. 56-year-old, right? Comes in, it's a train wreck. She's got all kinds of issues. She's been on other therapies. Why would you not say we have something new? Look at that inferior staining, okay? I think this is that same doctor from Surprise. This was her patient, okay? Came in, saw me, and I'm like, girl, we need to change you, put you on something else. Why didn't that other doctor tell you about it? That is my absolute favorite thing is, why didn't my other doctor tell me? And I would say something, because they hate you. Because they just don't care about you like I do. What was your name again? Yeah, like you. Before VEVI, after VEVI, okay? Here's another one, chronic open-angle glaucoma. I lied, I said I wasn't gonna do these, but I can't help myself, okay? They're on glaucoma meds. These people have ocular surface disease. It's just the nature of the beast, people. Unless you're going to do some form of interventional glaucoma, and I don't know, a lot of us are doing MIGs and stuff by ourselves. We're not doing, sustained release on our patients. You see here, persistent SPK. Look at that. Okay, that's Ben Gaddy's eyes, and Ben got glaucoma. Okay, although he just found out that he doesn't. He's just a suspect. Beautiful thing for Ben. Okay, but his eyes look hideous. So if you see Ben, go, damn, Ben, your eyes look hideous. But you know what? Before VEVI, after VEVI for 1 month. These are results that you can actually see. They're tangible. I don't care about this case because it's Ben again. I will be here to answer any questions. Okay, I cannot necessarily say that I will give you good answers, but I will yield those questions. So we know we have choices, people. Okay, and we know that it isn't always just going to be the first medication you want, but you got to try. So when you start thinking about difference and uniques and better qualities, don't forget about 0.1% cyclosporin that comes in a semi-fluorinated alkane, otherwise known as VEVI. Thank you guys for listening to me. I oftentimes do this in front of a mirror. It's not the same, but I will take some questions. Yeah?
How do you prescribe it?
How do I prescribe it? It's 1 drop twice a day. And it comes in a bottle, okay, which is forever? Oh, hell yeah. I think of this disease, the question was, do I do it forever? And my answer is yes. Is that I told you before that I feel our job is to manage our patients. You're managing their pressure with glaucoma. You're managing their ocular surface disease. We want to be on phones and tablets. We want to live in, arid environments or live in the East where it's super, super cold. We want to do what we want to do. We want to get in an airplane. All those things affect the ocular surface. For patients that have more inflammation, then they need to be on something like this. Any other questions, comments? Anybody's BS meter flying off the hook? Do you see what I just did there? Burning and stinging. Yeah. This is a no clap zone. The people at home are not clapping. Nobody here needs to clap. I'm a colleague. I'm hated by some of you. I see you guys. And more importantly, I appreciate you guys all. Viva la optometry. Thanks, Stephanie Wu and Wu Yu.
Thank you.
And thank you, Haro.
Thank you so much.
Thank you for not clapping.
Okay, so for the virtual people online, please stay online for your bonus CE that is starting right now. And for our in-person people, our exhibit hour is about to start. I just wanted to go over your little passport that you have on your table.
Good evening, everybody. Welcome to tonight's Wu University event, Top Tips for Successful Dry Eye Diagnosis with Dr. Elise Kramer. I'm your host, Dr. Jennifer Stewart, and thank you to Bausch & Lomb for exhibiting at tonight's event. And thank you to Alcon for providing an unrestricted medical education grant for this event. Some just reminders, CE certificates, for CE certificates, please fill out the survey. The link will be emailed to you after the event. Attendees must be online for a minimum of 50 minutes per hour of credit. CE certificates will be delivered via email and sent to ARBO with your OE tracker number. Please allow up to 4 weeks for certificates to be emailed. A QR code will be displayed at the end of the event that you can scan with your OE tracker app. So this platform is new for us. If you haven't seen it yet, welcome to the new platform. It looks a little bit different, but you still have Q&A and handouts, which are found on the right-hand side of the page. To minimize, use the down arrow, and to open, use the chat button. So as a reminder, put all of your questions in the chat in the Q&A. We will have time at the end for some questions with Dr. Kramer. So I think this is probably my 5th time introducing Dr. Kramer at least. So it is my great pleasure to welcome Dr. Kramer once again to Wu U. She's a residency trained optometrist in Miami, Florida, who specializes in ocular surface disease and specialty contact lens design and fitting. Her doctorate degree was awarded in optometry from the University of Montreal in 2012. During her 4th year, she completed her internship in ocular disease at the Eye Centers of South Florida and went on to complete her residency at the Miami VA Medical Center. Her time there included training at Bascom Palmer, the nation's top eye hospital. After her residency, Dr. Kramer became a fellow of the Scleral Lens Education Society and now serves as the president for the SLS. She's also the president of Women in Eye Care, a member of the American Optometric Association, the International Association of Contact Lens Educators, a fellow of the American Academy of Optometry, and of the British Contact Lens Association. She's published several important articles and reviews and participates in clinical research trials. She enjoys lecturing around the world in several different languages about ocular surface disease and specialty lenses. She's also an amazing Wu U moderator as well. So this time she's on the other side of the screen, but welcome again, Dr. Kramer. I'm going to turn it over to you.
Great. Do you hear me? Just making sure I'm...
Yeah. Yes, we hear you.
Great. Thank you so much for having me. I love Wu U, and I love, being able to share my knowledge and experience. So thank you to all of us joining this evening. And you can see my presentation up there, correct?
Yes. I can see it. Yeah.
Amazing. So tonight's topic is top tips for successful dry eye diagnosis. And dry eye is such a hot topic today. And it is something that I kind of fell into, as Dr. Stewart mentioned. I have a contact lens practice, but I don't believe that you can be successful in contact lenses without also treating ocular surface disease. And a lot of what we're treating with some contact lenses, like scleral lenses and others, are ocular surface diseases. And so it's very much intertwined. And a contact lens, and this is not a contact lens course, but all I'm going to say about contact lenses is that when we introduce a foreign body like that to the ocular surface, it is going to exacerbate whatever inflammation is already there. And so I've learned, that it's so important to mitigate this inflammation in order to be successful with contact lenses. But even if you're not fitting lenses, even if you're working primarily with glasses, or you want to focus only on dry eye, it is so important, because whatever these patients are going to do, whether it is driving, reading, working, or getting surgery on their eyes at some point, it is so important to optimize the ocular surface. And so the main reference for a lot of this presentation is going to be the DEWS 3, and that's out. It's super exciting. And this group of amazing experts get together every few years and put together new protocols for diagnosis and treatment management of ocular surface disease. And I know it's a very lengthy report. And so I love this opportunity to be able to put it here for you in a presentation. And obviously this doesn't cover everything. We're going to really focus on diagnosis, but I'm really thankful for this opportunity, because not only am I saving you a lot of time by reading the entire report, which I still encourage you to do, but I think this is going to be able to take a lot of what's said in that report and make it practical for you, and something that you can really just bring to your offices tomorrow. For those who are working tomorrow, I sure am. And I always learn a lot when I give presentations. So I'm excited as well for the interaction toward the end. So please, as Dr. Stewart mentioned, if you have questions, don't hesitate to put them there. Comments too. I love to hear what you do as well. But again, a lot of this is going to be evidence-based and based on the DEWS 3 report. So why is dry eye so often missed? The thing is that dry eye is going to be different in everyone, and everyone has different symptoms. Everyone has different signs. It's not like it always looks exactly the same. Now, when we learn about dry eye, we think, oh, it's going to be burning, and it's going to be patients that are in pain, but we don't have like a specific dry eye gold standard test. Like, for example, if we're looking for, keratoconus, we can just do a topography or tomography and we can just super easily find it. If we're looking for Demodex, we can ask patients to look down and we see the collarette. So a lot of what we diagnose in eye care, some of it is trickier than others, but dry eye is such a big group of conditions or signs and symptoms that it makes it hard. And on top of that, the symptoms that patients have are not always going to align with the signs. And it's going to be chronic, and it's also progressive. So patients might think that this came out of nowhere, when really they've been dealing with this for a long, long time. And a lot of the time I've found it's not about asking patients if they have dry eye. I mean, this week I had a patient come in and I asked her if her eyes were dry, and she said no. And then I like to probe, because there's always a little bit of dry eye. And I always like to say, and I think I heard this from Dr. Ketting once, and she was like, everyone has dry eye unless proven otherwise. And I completely agree with that statement. And so, I think it's also about asking the right questions. And so I went ahead and asked her, okay, your eyes don't feel dry, but do you ever have like any watering or any itching? And she's like, well, you know what? Sometimes when I'm reading, my eyes water a lot. And so I had a student with me, and we were just discussing how if I had just stopped right there and said, do you have dry eyes? And she said no, then I would have just moved on with the rest of my exam. But it turned into a whole, it prompted me to do other testing and then to eventually treat that patient for what was dry eye. So what is the TFOS DEWS 3 framework? So basically, when you're diagnosing dry eye, this is the hack. It's symptoms plus at least one tear film homeostasis marker. So again, you have to have a symptoms and one marker for tear film homeostasis, at least one. So you can find more than one. If you have a big dry eye clinic and you have multiple ways of testing, that's great. You can do it all. But really, to diagnose dry eye, you need a patient symptom and at least one tear film homeostasis marker. So what are these markers? So these are the 3 markers. So tear film instability. Okay, so that's going to be the non-invasive breakup time or the tear breakup time. Ideally, non-invasive is a little bit more accurate according to TFOS DUES 3. But this is a super easy test. We're all putting in fluorescein in our patients to check the ocular surface. All we have to do is look and wait a few seconds and see what happens to the tear film and how it breaks up and time that. So very easy test, something everyone can do. I know like a lot of people think they need to have a lot of fancy equipment in order to diagnose dry eye. But as you can see here, you really need just symptoms and again, at least one core homeostasis marker. The other thing would be tear osmolarity, which you can see on that left photo. And then ocular surface staining. I use lissamine green all the time, and it really just highlights everything so well on the ocular surface, especially on the conjunctiva, whether palpebral or bulbar, and it just makes it aligns a lot with the symptoms I find in traditional dry eye. So again, you don't have to have a positive result on all of these. You just need 1 plus symptoms in order to diagnose dry eye. So what are the symptoms? So how do we get patients to reveal their symptoms? Again, it's not just by asking, hey, are your eyes dry? Usually patients will say, no, I'm fine. You know, they think a lot of their symptoms that they are having that are representative of dry eye, consistent with dry eye, are a result of getting older, are a result of, you know, my eyes are watering, so they're not dry. And that's something that we need to clarify as practitioners. They're itching, so they're not dry. I just feel like there's something in my eye, but it's not dry, right? So people don't necessarily understand what dry eye is. And so comfort is an important question. Fluctuating vision actually is a huge hallmark of ocular surface disease. And triggers, right? So there are some triggers. For example, on the patient I mentioned earlier, she was saying she's fine, but when she reads, that's when her eyes water. So we have to also look for triggers. So everyone has a specific trigger for dry eye. And what happens when we're reading, when we're really focused on a screen? Well, we're just not blinking enough. And especially on a screen, but it can happen also with documents. It can happen with extensive paperwork. It can happen with iPads, phones. So we're just, especially when we're focused, we're just not blinking enough. It's the act of blinking that allows allows the meibum to be released, which prevents evaporation of the tears. So blinking helps create this uniform tear layer over the ocular surface. And by not blinking, patients may be getting excessive evaporation, and then they're getting that reflex tearing, which is really uncomfortable. But reviewing risk factors, right? So contact lens wear, as I mentioned before, is a risk factor. It will exacerbate whatever inflammation is already there. Medications, so practically all medications, right? Whether the anxiolytics, antidepressants, sleeping pills, hypertension medication, statins, everything can really dry out the ocular surface. There are some that dry it out more than others. Accutane is a big one. Any or other acne medication, but all medications, most medications, I won't say all, but most medications are going to reduce tear production to a certain extent. Systemic diseases, of course, especially if we're talking about autoimmune diseases, inflammatory diseases, but also other diseases like diabetes, where you lose a little bit of sensitivity. Menopause, of course, hormonal cycles. We talked about screen time and also environments. So arid environments. I don't know about you guys, but when I go out west, my eyes always get super dry, like if I'm skiing or if I'm in Vegas or whatever's going on. And you know, and now it's super cold, even in Miami, believe it or not, it's actually really cold. And, you know, we're all having our heaters indoors, which can dry out the air. And so there's a lot of factors. And so all of these need to be asked about. And again, you can identify mimickers or overlaps early. So allergy, infection, exposure to something toxic, right? It could be eyelash glue, it could be hairspray, and then neuropathic pain patterns. So neuropathic is when you're getting into those patients that really their signs are just so much worse than what you're seeing. And you're not really seeing one of those markers that we were talking about. But I do find that patients who have allergies often also have dry eye. So one does not exclude the other. And that's the tricky part too, is that a lot of patients will have both allergy and dry eye, and it's inflammation plus inflammation just gives more inflammation, which leads to more tear film instability, which leads to more symptoms. So, having an allergy does not necessarily, exclude dry eye. It can overlap, and those patients can actually be very symptomatic. So one of the screening tools, and this is actually the new and improved OSDI. This is the OSDI 6. I love the OSDI. It really, I think it does two things. One, it asks really great questions. So, and two, it allows patients to be able to express themselves better. And it has a great color scale. You can kind of see it there at the bottom. And you can show patients where they land, and so they can understand where they are on a scale, because a lot of patients want to know, is this really bad? Where am I in comparison with like the average or normal eye, right? And so this is a shortened version of the OSDI, the traditional OSDI that we've had. So that leads to better compliance. It's true. I found that the longer OSDI leads to patients leaving questions out, not really understanding certain questions. And it is a great tool that is going to be good for screening. So it's not necessarily grading the severity. It does, again, have that color scale, but it's more of a screening test. So this doesn't replace one of the core markers I was talking about, but it is going to add to your overall comprehensive overview of dry eye. So it's designed to identify symptomatic patients who need further testing. So a lot of patients will come in and say their eyes are dry. I'll give them an OSDI and then I'll see where they land. And this allows me to see like how bad are they compared to a normal patient, compared to an average patient, and how bad do they feel really? And so this allows me to identify risk factors, red flags. It works well also in a high volume practice. So I can sometimes see anywhere between 15 and 25 patients a day. And, this will allow, after they complete the intake form, allows them to do this while you're working with someone else, or it allows also the technician to do a little bit of workup before you come in, and that allows you to put your attention in other places. And the fact that it's shorter also like this avoids survey fatigue. So again, with the longer test, you'll see patients not necessarily finishing and just being frustrated with it, especially if they're having vision issues. So pick the right candidate for this type of questionnaire. But it is shorter than the traditional OSDI. And again, this is new and based on the TFOS-DUCE 3 report. So we were talking about tear film stability. We have the non-invasive breakup time, which is preferred. So for this, you really need a device that can allow you to see the tear breakup. So they use Placido disc, and you can see there in that video what it looks like when it starts to break up, and it will ultimately let you know how much time that was, and then it will map it out for you. So a lot of these devices are really great, but also a little pricey. So if you don't have the ability to get that, you can definitely just use a slit lamp, fluorescein, and just remember that less than 10 seconds is abnormal. So essentially what's happening in the tear breakup is that the lipid layer is breaking down and is causing the rest of the tears, or the rest of the layers of the tears, to be exposed, and it causes literally a breakup of the tears. And, obviously the shorter it is, so the faster they break up, the more tear film instability you have. And again, if you remember going back to the dry eye cycle, the more inflammation you have causes more tear film instability, which causes more inflammation, which causes more tear film instability. And it's a vicious cycle that continues, progresses until it's interrupted with treatment. So again, if you have that tear breakup, it is a hallmark sign of tear film instability. I was talking to you about ocular surface staining. This is one of my favorite tests. Again, so important to do. So I use lissamine green a lot. You can use fluorescein. Fluorescein is really wonderful for staining the cornea, but I do find that a lot of my dry eye patients come in, their corneas are intact, like perfect, pristine, no staining whatsoever. I mean, the tear film breakup time might be a little low or a little short, but there's no actual staining. So if it's not for lissamine green, you really wouldn't pick up on a lot of this. And these are really important signs. And as I mentioned earlier, I do find that the lissamine green correlates really, really well with patient symptoms. And even though the conjunctiva is less innervated, obviously much less innervated than the cornea, having staining on the conjunctiva is not benign, and patients are not asymptomatic. And it's not always because of the actual cells missing. It's because of what those cells missing represents. So in this situation, let's talk about the left photo for a second. You see that line on the eyelid. So you can really only see that with lissamine green, and that is called lid wiper epitheliopathy. And we really see this a lot in patients who have the more moderate to severe dry eye. The patients that are more symptomatic will have lid wiper epitheliopathy. And again, this is not a benign finding. This means that there is a lot of friction between that palpebral conjunctiva, or at least the lid margin, every time the patient is blinking, between that lid margin and the bulbar conjunctiva. And so what it literally means is that you're losing cells on the edge of your eyelid, or on the edge of the palpebral conjunctiva, because of an excessive amount of friction between the palpebral conjunctiva and the bulbar conjunctiva. And that is caused by a lack of moisture or a lack of hydration. And so by seeing this, you literally know that there is not enough tears. Now, whether there's not enough tears because the patient is not producing enough tears, or whether they're evaporating too quickly, we don't know that from this finding. But what we can confirm is that there is effectively a lack of moisture on the ocular surface, and that there's a lot of friction. And so in normal patients, blink is supposed to provide relief. In these patients, blinking is symptomatic, it's uncomfortable, and it gives that foreign body sensation. And every time they blink, there's an excessive amount of friction there. So that is very telling. And I can say the same thing for the bulbar conjunctiva. Again, dead and devitalized cells on the bulbar conjunctiva means that there's an excessive amount of loss due to tears evaporating too quickly or not producing enough tears, causing friction between the bulbar conjunctiva and the palpebral conjunctiva. And, the lids are quite strong. There's quite a few muscles there. A lot of people have tighter lids, and it can really cause a lot of symptoms. And so even if you're not finding corneal staining, again, look for conjunctival staining, whether on the palpebral conj, the bulbar conj, and use lissamine green. Now, the trick is a lot of us put in fluorescein and lissamine green and look right away. You're actually supposed to wait about 2 to 3 minutes for the excess amount of dye to go down the puncta or down the nose, or leave the ocular surface, and that will reveal all the staining, if any. And so just wait a little bit, have a quick chat with the patient, and then pull up your slit lamp and look. So don't look right away. There will just be an excessive amount of dye and you might miss a lot. And of course, if you want to educate your patients, showing them photos of this is very informative. And a lot of them like to take these photos home because it really allows them to understand what's actually going on the ocular surface and why they have the symptoms that they have. And then finally, we have the tear film osmolarity. So this is a test that is a point of contact test that you can quickly do in your office if it's greater. So if the osmolarity is greater than or equal to 308 milliosmoles per liter, or if there's an inter-eye difference, so a difference between both eyes of 8, then you know that there is inflammation there or tear film instability there. So what does osmolarity mean? It means that there is too much salt compared to a normal ocular surface. And so when there's too much salt, it means that there's not enough water or not enough aqueous, right? And so that could mean, again, that the patient is not producing enough, that it's evaporating too quickly. Again, we don't know what type of dry eye this is or what the underlying cause is, but we know that there is a case of dry eye here because a tear osmolarity is greater or equal to 308 milliosmoles per liter, or if there's a difference between each eye of 8 or more, or greater than 8. So that's something that you can easily do. And again, you don't have to do all 3 of those tests. You don't have to do the tear breakup time, the staining, and the osmolarity. You can. There's nothing wrong with that. But if you have a busy clinic, you have a lot of patients, you might not have time to do all of that. And again, you only need at least 1 marker plus symptoms in order to diagnose dry eye. So what kind of dry eye is this, right? And so this is the new kind of algorithm or chart or tree that we can find in the TFOS-DUES-3 report. So if they have symptoms and they have signs, then most likely they have dry eye, right? But if they don't have signs, but they do have symptoms, then you're talking about something a little bit neuropathic. So a patient who is experiencing pain that just really doesn't correlate with what we're seeing. So that's not real dry eye that would be managed the same way as the traditional dry eye. And sometimes you have symptoms, but you don't have, again, you don't have signs, or you don't have symptoms, but you do have signs. So that's your stain without pain patients. And that's when you're talking about your neurotrophic conditions. So those patients may have decreased sensitivity or a complete lack of sensitivity, and therefore they're not adequately providing epithelial cells to the ocular surface or to the cornea, the conjunctiva. And again, they might not be able to regenerate their cells properly. And that could be leading to the signs that we're seeing. But these patients really don't have the symptoms because we know that staining is so painful. If patients have staining, but they don't have the symptoms, then we know that they're probably more neurotrophic. So again, you do need signs and symptoms. Again, it can be poor tear stability, it could be hyperosmolarity, ocular surface staining, one of those. And then you exclude differential diagnoses. So again, we're looking for other things that may overlap or be a correct diagnosis, such as allergies, such as an infection, medicamentosa. But once we know that it's dry eye, we can start categorizing the dry eye. What type of dry eye is it? And the reason we want to do that is because it's really important to figure out what the underlying cause of the dry eye is. If we don't figure out the underlying cause, then it's going to be difficult to treat. Not all dry eye is treated the same. Some people, again, don't produce enough tears. Some people do, but they evaporate too quickly. A lot of the time it's mixed. So if we treat all these patients the same way, a lot of them will not respond the same way. They won't respond favorably. So once we do diagnose dry eye, it's really important to figure out why. And I think that is probably one of the most important aspects of dry eye is discovering the underlying cause. And I get a lot of reps that come in the office and talk to me about this drop and that drop. And we do have a lot of wonderful treatments in the market. And as I mentioned earlier, dry eye is a very hot topic right now. And there's always going to be, thankfully, new treatments that are going to be developed. But I would strongly oppose using all of these treatments equally in every single patient that has dry eye. And that's because there's different, underlying causes. So it could be lipid, aqueous, mucin. It could be from eyelid abnormalities, so blink or lid closure. For example, I see a ton of exposure post blepharoplasty, lid margin, anatomical misalignment, or you can have neural dysfunctions, ocular surface cell damage, primary inflammation or oxidative stress, and of course associated with systemic conditions. So if you have a patient that you feel like is primarily aqueous deficient, ask them about joint pain, back pain, dry mouth, other questions that may allow you to potentially identify a systemic condition or help identify a systemic condition. And then once you figure out the cause, you're on your way to the end, because the treatments we have, like I said, we are very fortunate right now to have a lot of wonderful treatments on the market. It's really about figuring out what works for different patients. And the only way to do that is to figure out why or what the underlying cause is of the dry eye itself. So let's start with lid margin. We have evaporative disease, and a lot of this is caused by meibomian gland dysfunction. Now, when you express glands, and I highly recommend doing that, especially in patients that you suspect of having evaporative dry eye, you'll see that the consistency of the oil that's coming out is not going to be that nice olive oil consistency. And the reason is because the oil or meibum inside the meibomian gland is supposed to be liquid at room temperature. But what happens when there's inflammation is that it raises the melting point of the meibum and it causes it to become solid. And when so inflammation itself is causing a change in consistency of, or changing the way, the structure of this secretion. And so you can see how a gland that produces this type of oil would not be properly preparing that protective coating that we have over the tear film, which is the lipid layer. And that lipid layer is really key in preventing evaporation of the tears. And so this is what we call the toothpaste sign. That's why you see this little toothpaste guy jumping. And again, this is something that you can take pictures and videos of and show your patients. They really do appreciate the education. So there's two ways to do in-office gland expression. You don't have to do both, but they are very different. So the one on the left is called a meibomian gland evaluator. What you're doing with that test is actually not qualitative. So you're not necessarily looking at the consistency of the oil, but in this case, you're actually seeing how many gland openings are patent, are open, right? Are allowing that oil to come out. So it's more quantitative. So if you want to see, for example, let's say you have a patient and you see that only 2 or 3 of their glands are functioning properly, then you can do a treatment and then remeasure this. And so we'll allow you to see quantitatively how your treatment is working, but it also allows you to give patient information. The second one on the right is more qualitative. So by expressing the glands and looking at the consistency of the oil, that's when you can really see that toothpaste sign. Again, this is not telling you how many glands are patent, how many glands are open, but it's really giving you information about the consistency of the oil, which does tell you, whether there's inflammation, underlying inflammation or not. So again, 2 very different kinds of expression, but both very useful for different reasons. And then, of course, my best friend, which is the meibographer. I try to do this on every single patient. We find meibomian gland dysfunction in kids now a lot, from maybe excessive screen use or underlying genetic predispositions. But we see this in teenagers, we see this, and of course in adults, we see this in people with systemic disease, without systemic disease. But the mybography is something that has actually existed for a long time, and you can see that Corb transillumination on the top, which kind of gives you some information. It's pretty cool that you can do that with a transilluminator. But we're also really spoiled now by having our infrared equipment and being able to visualize meibomian glands and then show them to our patients and show them where they have gland loss and shortening and dysfunction. And it's, I think, more than useful in telling me what's actually going on. It's so useful to show patients. And it's really analogous of those, like, when dentists show us our cavities or those shadows that we see on our dental imaging is very similar concept. And it really, like, patients really do, again, appreciate the education. I think I'm going to say that throughout this presentation. So it really just gives us so much information about the glands, and it really will unveil a lot of the underlying causes of evaporative dry eye. So a lot of this equipment is available now. Some of it is a little pricier than others. I know budget is always a consideration when we're building a clinic, but you can find some that are really inexpensive and easy to use. And if anything, you can just use a transilluminator. So definitely do mybography. But that's not the only thing that can happen on the eyelids, right? We also have the biofilm, which is accumulation of bacteria and other foreign deposits on the ocular surface, which can definitely contribute to evaporation of the tear film because it increases the osmolarity again. But you can also have just infection, but any type of bacterial infestation will cause, ocular surface damage, will cause toxicity to the ocular surface. And this is probably the easiest diagnosis to make in eye care. Just by asking our patients to look down, we can really see a lot in their eyelids. So you can see scurf, of course, but if you're seeing those cylindrical deposits in the base of the lashes, you'll be able to identify collarettes. And the collarettes are pathognomonic for Demodex, meaning they're characteristic of Demodex, also meaning that it cannot be anything except Demodex. So really not always obvious if the patient is looking straight ahead, but if you have them look down, you will find it. And I find it every single day of clinic, and we do have wonderful treatments now. I know they're not available everywhere all over the world, but in the US, we do have wonderful treatment now for Demodex blepharitis. But if anything, just make sure patients are cleaning and have good hygiene and are aware of this, because this condition does wreak a lot of havoc on the ocular surface. It will cause inflammation, not only on the surface, but also the eyelids, and it can cause lashes to fall. And it does also brings bacteria with it. So there's 3 ways that Demodex damages or causes damage and inflammation. The first is mechanical. So lash distension occurs as Demodex mites attach to follicles. So they have tiny little claws, and they can cause microabrasions in the gland and in the follicle as well. They do carry bacteria in their gut, or in their surface as well. And that could elicit, again, that immune response I was talking about earlier with the biofilm, and also chemicals. So Demodex mites, along with their debris and digestive enzymes, can contribute to inflammation by releasing inflammatory cytokines. So these are the 3 ways that we really see a lot of damage. And I find if you look for this and you find this, sometimes I'm so relieved because I know what's causing the problem for the patient. And could be the main cause of a lot of their discomfort. And so if you're treating this, you're giving them a huge jump start toward comfort and better vision, etc. So important and instrumental in your dry eye management to have them look down. But if you want to get fancy, there's other ways as well. We have the phenol red thread test that you see there on top, which is similar to the Schirmer test. Difference between the phenol red thread test and the Schirmer test is the size. So with the phenol red thread, you'll just see it's like a little tiny thread, so it might be a little bit less invasive to the ocular surface. The Schirmer test is a little bit thicker, but it is the standard one. It's the one that we use in a lot of studies. And of course, you can do it. You can use proparacaine as well to stop the reflex tearing. And the phenol red thread, if it's more than 15, it's or less than 15, sorry, it's abnormal. Whereas the Schirmer, if it's less than 10, it's abnormal. On the bottom left, you'll see there the show test. The show test is going to be a test that's done. It's a point of office, like you could do it in the office itself, and you can actually see if they test positive for the show, which might mean that they have Sjogren's syndrome. So something that you can do in your office. I don't do this, but you can definitely do it if you want to. And again, if you're suspecting Sjogren's syndrome, ask patients if they have dry mouth and then ask them to get tested for this. If you don't have the show test, you can ask them to do this with their rheumatologist. But a lot of the time, if you ask if they have dry mouth and they say yes, I would recommend testing that further. But that's not the only thing you can ask. You can also ask about any gastrointestinal symptoms. You can ask about any joint pain, back pain, and of course, dry mouth. And I'm going to just play this video again here at the top, which is going to be that tear meniscus. So the tear meniscus is something that you can measure with your slit beam. So you can make it a little bit shorter and just align it with the actual tear meniscus and measure the height of it. And toward the end of the video, I think it was the OCT. So if you have an anterior segment OCT, you can also use that to look at the tear meniscus. So great tests, all of them, if you want to see if you're suspecting the patient of having an aqueous deficient dry eye. So again, these are not going to be eyelid related. These are going to be aqueous related. So in these cases, again, the patient might have a normal lipid layer, but they're not producing enough tears. And so it's less common than evaporative dry eye, but still one of the main reasons patients do have dry eye. So if your meibography or your glands are, looking great and everything else looks really nice in terms of eyelids, but patients having symptoms and signs, then, a lot of the time it's aqueous. And so you can look into this as well. Now, patients do also have mixed dry eye. So it's not always going to be evaporative. They could have both. And so it's important to treat both. And again, they are not treated the same way. So make sure that you're also looking for aqueous deficient dry eye, even though in isolation it is less common. It's still present and again can be mixed with evaporative dry eye in a lot of our patients. Okay. So this is another test. So it's a test that is, again, point of contact in the office, identifies ocular surface inflammation. So by identifying whether a patient has elevated MMP9. So if a patient has greater than level 40, that means that they probably have inflammation. It's helpful when symptoms are greater than signs. So for example, if you're having a patient that's symptomatic, but you're looking at the slit lamp and you're really not seeing much there, then you can do a test like this to determine if they actually have ocular surface inflammation. Now, if it's normal, then you may consider that they have like a more neuropathic type of dry eye. But if it is elevated, then you're actually confirming that there is some inflammation there and therefore tear film instability, and that their symptoms do align with that. So it does guide anti-inflammatory therapy as well. It's not enough alone to make the diagnosis for dry eye, but it does give us a lot of information. So again, this test in isolation is not something I would recommend or is recommended for dry eye diagnosis, but it does assist. And again, especially in those patients where you're really not seeing much either in the eyelids or on the ocular surface. And so it will tell you if there is some inflammation. Again, super easy to do right in the office and have the results there. So this is something that if you want, again, something that you can add to your clinic, again, not necessary, but it is a software that allows you to organize your dry eye data. So it integrates the data, it's decision support in dry eye care. It basically collects symptoms, history, test results all in one place. And then it will give you like a full report for the patients. It does help sort through a lot of causes for dry eye. There is some AI in there. So it will help kind of extrapolate that information and arrive at certain conclusions that you can use in your decision making. It can also help track patients' progress over time. AI is not going to replace you. Obviously, you're the one making the diagnosis. So I wouldn't base all my decisions on this type of software, but it is available and it can be helpful. And a lot of the time, if you are doing a lot of dry eye and you want to provide your patients with some sort of data or a report, then that's something that you can give them, and again allows you to track progress over time. So it does help organize things, but again, it is not replacing us in that decision making. It is more decision support. And what's cool about it is that it really just brings everything into one place. So definitely something that you can look into if you want. But this was a lot of information, and I know it's like so much, and a lot of the time we're thinking, well, what do I actually do, right? Like, what do I do tomorrow? I'm a little overwhelmed by all these tests. I'm a little overwhelmed by all this information. And now I really don't know where to start. So I thought, yes, I'm going to obviously give you the evidence. That's what I'm here for. And I'm going to break down the TFOS DEWS 3 for you so that it's approachable. But I also want to let you know what I actually do in my office, because I think that that matters. And again, it's something, my goal really is to bring this to a practical level where you can do this tomorrow. So screening, right? So screening is super important. That's where you're going to get your symptoms. So don't just ask patient if they have dry eye. Look at your intake form. What are they there for? Okay, they're there for glasses and contacts, but always ask the questions, right? Probe the questions. Not, do they have dry eye? Do your eyes feel tired? Do you use a screen a lot? Do your eyes get red? Do your eyes water? Do your eyes itch? Do you ever feel like there's something in your eyes? If they say, a lot of patients will say, oh, I only wear my contacts on the weekend. Why? Because is it that you can't see well with them? Is it that you're not as comfortable with them? And a lot of the time it's the comfort. So actually the main reason that people drop out of contact lenses is because of comfort. So asking the right question. So screening, here I wrote fast, but fast doesn't mean inefficient. Fast means, find some questions, triggers, and get to the point. But again, screening, super important, right? And then slit lamp evaluation. Don't overlook that. Use both dyes. I always do my biography. If you don't have it, I highly recommend it. Or again, you can try that transilluminator test I was showing you, but definitely slit lamp evaluation. So fluorescein, lissamine green, I love, and I use it every day. So I highly recommend that. And then you can, again, you're looking for one homeostasis marker. So it just has to be one. So whether it's your tear breakup time, whether it's the staining or another, or the osmolarity, one of these tests is going to tell you that the patient has dry eye in addition to their symptoms. So putting in lissamine green is super fast. It's one of my favorite tests, as I mentioned, and it's probably the one I do the most, but you can pick your favorite one. If you have a non-invasive tear breakup time, even better, and do the test and then show the patients the results and use that along with the symptoms in order to confirm the dry eye. Now, once it's confirmed, you have to figure out what the cause is. So is it MGD? Is it aqueous? Is it mixed? you do have to figure this out again because the treatment is going to change. Now, this talk is really not about treatment. There's so many amazing talks on Woo You on treatment itself. And so if you haven't seen them, go check them out. But really what I want to focus on is the fact that we need to identify the underlying cause. And again, it can be mixed, right? So just because they have rapid tear evaporation doesn't mean they're producing enough tears, and vice versa. So really important to figure this out, because once you figure this out, you can treat it, right? And then show your patients. Some of our star colleague on the left here showing the myopography and comparing it to the standard. Explain that this is chronic, very important. Patients often ask me, oh, am I going to have to do this forever when we're talking about treatment, or am I going to have this forever? And my answer is always, my goal right now is to get you to a baseline. And so let's get you there, and then we'll figure out after we get there what we're going to do. And patients really like that, because it doesn't mean they are going to be condemned to whatever treatment you're putting them on forever. It just means that you're getting them back to normal. And then once you get to a normal for them, where do you go from there? And yes, they might have to continue treatment. They might really like some of the treatments that they're doing. So again, revisit. And that's the important, right, of follow-up. And this is kind of my guideline. Again, you come up with your own. This is not based on the TFOS DUES 3. So just disclosure there. This is my clinic, what I do. I keep track of all the patients. If they're mild, I like to see them every 8 to 12. If they're moderate, 4 to 6 months, severe, 1 to 3 months. And if they are having flare-ups, I will see them weekly, sometimes even more. So again, that's my guideline. Feel free to follow them, but the goal is really to follow them, right? And to keep monitoring their dry eye. And again, you can use some of those softwares I was talking about. You can use some of those tests I was talking about to monitor the progress of a lot of the treatment that you're doing. So diagnosis will evolve over time. So you can see, they can have improved lissamine green staining. They can have some improvement in the meibomian glands after doing some treatments. Their eyes might look and feel better, but they still may be predisposed to having certain issues, or they may still have, meibomian gland loss, and therefore you need to maintain. So diagnosis will evolve over time. Yes, they could have severe dry eye when you first see them, and then it can become more moderate to mild. So again, just reevaluating and kind of diagnosing them as you follow them. So key takeaways. I hope I made this simple for you guys. I know that there's a lot in dry eye, but again, it's really not that complicated. You really just need symptoms and one of those core homeostasis markers in order to diagnose this. I think finding the underlying cause, a lot of these tests are repeatable. And again, this was completely evidence-based. If you're curious, check out the TFOS DUES 3 report. It was released recently, and a lot of amazing information there. Hey everyone, thank you so much. I hope you enjoyed that talk. I'm super passionate about dry eye, and so we're happy to be here with you. I did get a question here about, could I share the OSDI 6 document? I do have it here. I'm not sure how to share files on this platform, so please send me an email. I will put my email in the chat right now so that whoever wants the OSDI 6 can just contact me. Let me see if this works. I'm typing it in, but please write some more questions here in Q&A if you have any. Okay, here's a question. So about contact lenses, do I wait to treat dry eye before fitting contact lenses? So that's a great question. I think, it depends on the severity of the dry eye. So if patient is mild, I might treat it simultaneously while starting a contact lens fit. And if it is more of a severe dry eye, I may want to treat it first and then down the line, fit some contact lenses. Same thing for refraction. I mean, you're going to have a lot of fluctuations in vision when you have more severe, moderate to severe dry eye. So I think just, depending on the severity again. Another question, how many dry eye patients do I see in a day? Honestly, all my patients have dry eye until proven otherwise. It's so true. I mean, I think that everyone has a certain degree of dry eye. I think a lot of people are asymptomatic or will only complain with triggers, like for example, screen use, etc. Doesn't mean that they don't have underlying dry eye. So I think always look for it. I try to do a mybography on everyone, including children. We're seeing a lot of screen time in kids now. And so, don't forget about that population. But I'll see anywhere between 15 to 20 patients a day. And I would say at least 90%, have dry eye or some level of it. Someone here live, hello, wants to know where do scleral lenses fit compared to topical drugs? So that is a great question. The thing about scleral lenses is a wonderful treatment for aqueous deficient dry eye, for dry eye due to Sjogren's syndrome, to, any real aqueous deficiency. It is a wonderful treatment. I think if they're mostly evaporative, yes, I do think that scleral lenses play a role in stabilizing the ocular surface, but you still have that pre-lens tear film. And if you don't treat the evaporative component, especially if that's the predominant, like the dominating component of the dry eye, I think that you will have trouble with the scleral lens regardless. So I don't think that scleral lenses are for every single dry eye patient, but they do play a huge role. And again, especially in the dry eye that is aqueous deficient, predominantly aqueous deficient. And where they fit in, it comes from two things. I think a lot of patients have tried a lot of drops and they'll come to me for a scleral lens because they've already tried a lot of things and have been unsuccessful. That is a great candidate for a scleral lens. Someone that I'm just diagnosing with aqueous deficient dry eye, especially if they're not a contact lens wearer, might be more reluctant to using a scleral lens. And so in those cases, I may start with a topical drug first, and of course, manage it as best as I can. For example, PRGF, autologous serum, acoltramon, or perfluorohexyloctane. Like, there's a lot of drops I can use. I do have patients who absolutely don't want to wear a scleral lens. Maybe they had LASIK, maybe they just had cataract surgery and we're hoping never to have, contacts and glasses ever again. So I do think it's case by case. I can't give you a formula that works for everyone, and that's just always my answer. I do think that it's important to have the conversation because it is a wonderful option for aqueous deficient dry eye. But we have a lot of other great tools as well. Just keep in mind that if they are not using a scleral lens, they will definitely need to use something to lubricate the surface a little bit more frequently. Whereas if they do have a scleral lens, they may not need as many artificial tears or as many drops throughout the day. So there's that huge advantage as well. All right, I'll take one more question here. Let's see. Do I have patients scheduled separate appointments, medical appointment, dry eye, vision appointment? So that's a really great question, and definitely important for flow. If a patient calls saying, I want to try a scleral lens, of course, they'll have a specific amount of time allocated to them. If they're coming for dry eye, usually it is called a dry eye consult, and that was all we're going to do. If we feel like they need a refraction, I may schedule them. I may schedule them for a refraction at a later time. If it's kind of a slower day and I feel like their ocular surface is stable enough to refract them, then I'll do it the same day. But my main focus would be the dry eye. Some patients will be scheduled erroneously just because of how they describe their chief complaint when they call. And it'll sound like they need a regular eye exam, but really it's like a dry eye consult. At that point, again, it depends on flow. If I feel like it's more of a slow day, then I'll definitely, take my time, do a full dry eye assessment as well as a comprehensive. And if I'm just kind of back to back, then I may reschedule them for a dry eye. So really it depends on how they're scheduled. But yes, ideally they would be scheduled differently. So the last question is, can sodium fluorescein give as much information as lissamine green for conjunctival staining? I don't think so. I much prefer lissamine green. I think it highlights the lid wiper much better. I think it highlights the conjunctival staining much better. And overall, it's my number one choice for conjunctival staining. I think it really does.
Only one of the best optometrists in the world, but one of my very best friends, Dr. 100 articles and books, delivered over 500 lectures, and she's a board member and founding member of the Intrepid Eye Society. She is the author and editor of Specialty Contact Lenses and Contemporary Scleral Lenses, Theory and Application, which I think we had those books out there, right? I think Jess had them at the Contimac station. So if you didn't get one, make sure to get one on your way out, because I know she doesn't want to take those back home with her because they're very heavy. And Dr. Barnett is energized by her passion for helping people improve their lives by optimizing their vision, health, and wellness with a customized approach. She is most proud of being awarded the EB Game Changers Award from the Eye Care Business, the Legends Award from AOA CLCS, and the Scleral Lens Practitioner of the Year Award from the Scleral Lens Society. Dr. Barnett obviously has a million awards, a million different articles she's written, books, podcasts. She is a woman that can do anything and everything. And it's my true honor to welcome here to Dry in the Desert.
Oh, well, thank you. Wow. How am I going to beat that introduction? That's amazing. It is such an honor to be here, and it is such a pleasure to see all of you here in person and all of you here virtually. And this is one of my favorite topics. So the first hour, we're talking about the eyelids and focusing on the lids for OSD success. So since all of you are here, I do want to thank you for your help in helping your patients, because we have this incredible opportunity to help our patients, help the ocular surface in order to improve their lives and their quality of life. So new, though it actually wasn't in my bio, in addition to being an optometrist practicing 25 years, I'm also a professional life coach. And so part of my time now is in eye care, and part of my time is in professional coaching as well. Some of you had asked, so here's a picture of my two boys. They're 17 and 19. Yes, they're very tall. They play water polo. And this was in Nicaragua. We had the great opportunity to do a Vosh trip just in January, and we're going to go back next year. It was so amazing. I do work with many companies to grow our wonderful profession. So in this lecture, we're talking about all sorts of things: meibomian gland dysfunction, Demodex, digital device use, ptosis, mask-associated dry eye, incomplete eyelid seal, and more. We're going to talk about different products that we can talk to our patients about. And this is not listing every single product and every single technology out there. I was going through this lecture thinking I could do this lecture for 8 hours because there's so much that we can talk about. But hopefully it'll give you some really practical guidance on how you can go back to clinic tomorrow and actually use some of these things with your patients. So one thing that is so important to highlight is this unmet need in dry eye disease. So about 38 million Americans suffer from dry eye. Now you're going to see all sorts of numbers, right? Here's just one of the numbers. If you look at different reports, there are other numbers too. But this is a huge, huge prevalence. So what I do encourage you to do in every single patient is to evaluate for dry eye disease. And 13% of people with dry eye felt like their dry eye was well managed. So we have this incredible opportunity to help so many people. And I hope that you'll take away with you that we should be ruling out dry eye in every single patient. We should be looking for dry eye because it is so incredibly prevalent. For those of you who don't know me, I'm also a huge eye nerd, so I love studies. And oh, I saw some smiles. We have some other eye nerds in here. And it's so great that we can have these studies, bring it back into clinical practice, and do better for our patients. So this is looking at the TFAS-DUES 3 report, and it's looking at dry eye, and we know it's a multifactorial condition. We know that ocular surface disease is really complicated, and when I have the opportunity to go and talk to groups like you, sometimes I have doctors who say, you know, this is so complicated. I don't know where to start. I don't know what to do. And so one take home is to evaluate for dry eye, diagnose for dry eye, and I'll use dry eye ocular surface disease interchangeably, treat it, and then see your patient back. Do some sort of follow-up as well. And it's okay if you start in one area, you use one thing or one treatment or medication, and then you see the patient back and you change it up. It's okay. It's absolutely fine. And so now that we have so many different opportunities, I find that a lot of people aren't sure where to start, what to do. And so all you do, you diagnose, you treat, you follow up with your patient. So this is looking at the differential diagnosis of dry eye. And there will be a quiz at the end. Yeah, it's a joke. It is a joke. There's no quiz because it's a reference. You can go back to TFAS-DUES 3. And here we're looking at the eyelids specifically. So we know that there are many, many contributing factors. Here today, it's very windy outside, right? It's dry, it's windy. Is everyone drinking enough water? I see like no one, no, one nod, excellent. But that's part of it too, right? We have the whole lifestyle aspect, and we have different products that people are using, different makeup products, for example, different skin products, different ingredients, in addition to all of us who are on digital devices all the time, many, many hours a day, and not taking a lot of breaks as well. So here, I really love this vicious cycle of dry eye where we have these initiating triggers. And this is adapted from the Ocean group, right? So we have meibomian gland dysfunction, we have dry eye disease, we have keratinization on the eyelid margin. We're going to talk about that today as well. We have increased tear evaporation, tear film lipid layer disruption, the meibum changes. It's like once you get in this circle, this cycle, it's hard to get out. So what we want to do is prevent this vicious cycle and really diagnose and treat our patients so that they don't have dry eye. And dry eye really significantly negatively affects quality of life. There's a huge economic impact too on dry eye disease, and we do need to take it seriously. The reason I sort of got into dry eye way back in the day is working with a ton of optometrists and ophthalmologists who were dismissing it, like, oh, it's nothing to really be concerned about. And fortunately, there's so many studies and so much research and so much advancement, and I'm so happy to see all of you here interested in this topic and really treating our patients quite well. So here's a non-comprehensive list because new products have come out and new devices have come out since this list was published, but here you can see some guidance, and this is helpful, and some of our colleagues find this quite helpful. Like, here's a patient, we know that typically dry eye is mixed mechanism, but here's one place you can start. You can start with the eyelids. You can start with the evaporative component. You can start with various areas. And when I talk to my patients, I like to get a whole idea of what's going on with their life, what are they doing on a day-to-day basis, what are they doing for work, what are they doing for fun, how are they using their eyes. And I do a lot of contact lens work too, and contact lenses play a big role as well. Not only contact lenses, but prior to surgery, any sort of surgery. So cataract surgery, refractive surgery, we always want to optimize that ocular surface. So my approach to dry eye has really changed and evolved over time. And I like to look at my patients holistically. So I look at my patient, thank you patient right there for being my model patient across the room. So I look at my patients from across the room, and why am I doing that? Because you can see so many different things. You can evaluate for rosacea on the skin. How many of you diagnosed rosacea of the skin? Like, yeah, oh wow, many hands going up there. It is so highly prevalent, ocular rosacea and facial rosacea. You can look at the hands. You can look for things like arthritis. You can see the lids, see if there's a little floppy eyelid syndrome going on. I do think you can diagnose keratoconus many times if you're really looking at your whole entire patient. And that's another thing we need to rule out in every single person. So that is looking at your patient across the room before you dive into that slit lamp exam, before you get behind the microscope, and evaluating for other aspects of their life too. So let's start with a few cases here. So this is Anne, a 21-year-old female who's interested in contact lenses. She's an engineering student, and medical history, anemia, but otherwise pretty negative. She comes in and says, my eyes burn and they feel dry. And she uses artificial tears, bottled artificial tears, unsure of the type and unsure of actually any information about it. Well, maybe it's white and it comes with a blue label. Do you ever hear that? Or maybe it's AccuView artificial tear. That was a joke, yay. Okay, so we know that many artificial tears have preservatives in them, right? Preservatives like BAK, which can be very drying to the ocular surface. So when my patient comes in and says, I use these artificial tears, I like to ask, what type? Are they preserved? Are they non-preserved? Is it a multi-dose preservative-free bottle? And how often do you want to use it? And then I've learned to ask the question, how often, even if you're not using it, if you're using it twice a day, how often do you want to use it? So do you want to use it 6 times a day, but you get it in your eye 2 times a day? When are you noticing the symptoms? And then asking the question, how long are you getting relief from the artificial tears? Is it 15 minutes? Is it 4 hours? Is it, what is it? And we know that the meibomian glands are very, very important. So when we blink on a day-to-day basis, the meibomian glands secrete meibum. And we know that meibomian gland dysfunction is very, very common. So here's another statistic for you. 30 million people in the US have dry eye. About 26 million have MGD. And there are currently no specific approved treatments for MGD. And we know that most of dry eye is mixed mechanism. So I've done a lot of research on Sjogren's and dry eye, and I will tell you, even in the Sjogren's population, that it's oftentimes a mixed mechanism component. So we're getting back to Anne, the 21-year-old comes in, visions 20/20 in each eye. You can see she's mildly nearsighted, she has some astigmatism. And upon slit lamp examination, she has meibomian gland dysfunction and also non-obvious MGD. And this is where people say, huh, what is that? Okay, so you take a clean finger and you gently press on the lower lid and you see the meibum and how it expresses. And it's amazing. Even to this day, even doing this in hundreds and thousands of patients, I cannot believe how many people have this non-obvious MGD. So it's something to incorporate into your exam. It's very quick. You can use a clean finger. You can use an applicator. There are different devices you can use as well. But please evaluate for this non-obvious MGD. She also has conjunctival injection, and this is not the huge injection that you see in someone with, say, iritis or an infection, but sort of mild areas of injection, an irregular tear film, rapid tear breakup time. So yes, there are many excellent instruments that do non-invasive technology. If you have one of those, fantastic. If you don't, that's absolutely fine. You can definitely diagnose and treat dry eye without the fancy technology. And I would encourage the use of questionnaires. Questionnaires are extremely helpful, and as we've learned from the TFOS DUES 3, the OSDI 6, it's very quick, 6 questions to ask our patients, and you can use the answers and to compare time after time. So these are really helpful, quick assessments to use. So for this patient, getting back to the patient, use daily eyelid hygiene. We do have a sheet recommending specific products so our patients know what to get. Prescribe MIBO 4 times a day, discontinue those unknown artificial tears. She reported improvement of the burning and dryness and fit into a daily replacement soft lens. So we know that dry eye often has an evaporative etiology, and MGD is so highly prevalent, so we do want to be looking for MGD and non-obvious MGD in all of our patients all the time. And this inflammation can lead to tissue damage, the desiccation stress, really the dryness, and then evaporation exceeds that total tear supply. So MIBO has been out, so many of you are probably familiar with it at this point. It's a semi-fluorinated alkane. It's a single ingredient, so there's no water, there's no pH. It is a 4 time a day per the package insert drop, although in contact lens wearers, I often prescribe it 2 times a day, so prior to contact lens application, after contact lens removal, and it has been quite helpful. It is a unique drop. It has a very teensy tiny drop size of 11 microliters. It stays on that ocular surface for many hours, and it spreads over the surface. Now, a question that often comes up is, say my patient is using another drop, like a glaucoma medication or a steroid. When do I use MIBO? You just use it last. So you can think of it like Rice Krispies or brownies and having that saran wrap over. You use the drop last. So there are many studies. These are large studies looking at patients over time using MIBO compared to saline, showing the benefits. So these are around 600 people. In each study, there is an improvement in the total corneal fluorescein staining, and that's using the NEI scale. So looking centrally, then superior, inferior, nasal, temporal. There's also an improvement in the eye dryness, so at day 57. Secondary outcomes and improvement in the eye dryness at day 15, improvement in corneal staining. Okay, for all of you in person, I want to show of hands here. And who wants to see an improvement in our patient symptoms as quickly as possible? Okay, thank you. I appreciate all of you participating. And then who of you want to see an improvement in signs? So signs of staining, corneal and conjunctival staining. And who wants to see both? Awesome. Okay, so all of you want to see both. Exactly, right? We do want our patients to feel better as soon as possible, and we want to see an improvement in corneal staining and conjunctival staining because the tear film is so important. The tear film has hundreds of components, and it is the first refractile surface of the eyes. So the tear film, we want it to be nice and pristine, have that beautiful ocular surface homeostasis or that natural balance of the ocular surface, and that's going to help vision as well. That could be vision with contact lenses, that could be vision without anything. So here you can see in MIBO, we have improvement in both the signs and symptoms of dry eye, day 57, primary endpoint, day 15, secondary endpoint. So when our patients say, how quickly is this going to work? We can say, it's going to work in about 2 weeks. And we have the day 15. It's well tolerated. There can be some blurring of vision, so we do want to tell our patients about that. Now, I could have easily also treated this same patient with Tripteer, right? That is another option. And Tripteer is also indicated for the signs and symptoms of dry eye. It stimulates TRPM8 receptors on the corneal nerve endings that regulate basal tear production. So it detects these teensy tiny temperature changes. And I still think it's amazing that we can detect tiny temperature changes when we blink and when we don't blink. And there were 2 phase 3 trials that show that there is an increase in tear production. So it's a rapid and sustained increase in tear production. Primary endpoint was met in both pivotal studies. Tear production was observed on day 14, which was primary, as well as day 1 and 90, both secondary. So your patient might say, how quickly is this going to work? This is going to work day 1 immediately when you put it in. It also demonstrates a reduction in symptoms. So the question that I asked all of you, do we want to see an improvement or signs and symptoms or both? Yes, we want both. In 2 studies, we do have a reduction in staining as early as day 7 and an improvement in symptoms. So there are no serious adverse events. Approximately 50% of people have mild and transient installation site burning or stinging. So it's very important for us to educate our patients that, yes, you're going to feel this. And some patients say, oh, it feels refreshing. Other patients say, oh, I can actually feel the drop. Yes, that is normal. And yes, it will improve over time the more that we improve the ocular surface. Isn't it fun? We have all these options. So fun. Oh my gosh. Okay. Moving on to Sam, a 27-year-old male. He's a veterinary student, comes in for a comprehensive exam, history of styes, has allergies. I practice and live in Northern California in Davis. It's like allergy time right now. Oh, it's been just awful. It's been windy, it's been hot and cold and everything in between. So many everything's blooming. So many allergies, as I'm sure there are here too. And Sam comes in saying, my eyes itch, and you can see here looking at the eyelids. So what I've learned over time about itch now is, do your eyeballs itch or do your eyelids itch, or both? And then patients say, oh yeah, it's actually my eyelid, it's actually right here. I always like when they show me it's right here when it itches. And okay, great. So we want to, and obviously this patient has Demodex blepharitis, as we can see, blepharitis, collarettes, MGD, telangiectasia, ocular rosacea as well. He also has diffuse conjunctival injection. There's no corneal staining, but we can see why there is itch around the eyelids due to the Demodex blepharitis. So treated him with Xdemvy twice a day, also preservative-free artificial tears, improvement of itch, and no additional styes. So we've seen this in clinical practice over time, that we have had patients who get improvement in styes, and I'll show you a study that just came out last week shortly. We know that Demodex is really underdiagnosed and undertreated. How many of you in-person folks are looking for Demodex on every single patient? Okay, great. So that is wonderful that there is more awareness of Demodex blepharitis. And whenever we see these collarettes on the eyelashes, we know that it's Demodex. So it's very, very easy to diagnose. We do want our patients to either close their eyes or look down. Now, there are different types of Demodex mites, and I will also encourage you, when you're counseling and talking to your patients, to really understand your patient and where they're coming from, because it can be completely scary and frightening to have mites and bring up this conversation. And I've had patients go online, Dr. Barnett, do you know that there are mites? And there, yes. So let's talk about what Demodex is. I say it's very common. Many of us have bacteria that live around our skin and body. Some of us have more that proliferate on the eyelids, but fortunately we do have many different treatment options that can help you. So we have different types of Demodex. Some reside at the base of the eyelashes, some in the sebaceous glands, and Demodex is present in every age group. So kids to those who are in their 90s, it's really, really highly prevalent. Now, this is really interesting looking at other conditions. So for example, blepharitis, 69% of blepharitis cases are due to Demodex. Everyone who has eyelash extensions knows about Demodex. I see the nods. Yeah, I mean, it's true, right? We have this, so whenever someone comes in who has eyelash extensions, I like to ask them, how do you clean them? Yeah, you're looking at me like, yeah, that's rough. Yeah, because I know that you have Demodex, and let's talk about ways that you can clean them. Demodex is also associated with conjunctivitis, keratitis, and other things like rosacea and dermatitis, hair loss, etc. So this is a really cool study that came out just recently, and this was presented at ASCRS last week. And this is looking at the prevalence of collarettes or Demodex blepharitis in Chalasia or Hordeola. And that is 71%, right? So what I'd like to ask my patients, practical, do you have a history of styes? Oh yeah, I got styes all the time as a kid. I get one or two a year. I have one now. It's resolving. You know, it's really, really highly prevalent. And so I would encourage you, if your patient has a history of styes, they have a hordeola, to really address that Demodex blepharitis. A question often comes up is, yeah, we know about Demodex and it's around and my patient's not really symptomatic. What do I do? Well, it depends, right? I think that you're always going to find a symptom if you ask enough questions. And one of my favorite symptoms of dry eye is blurry or fluctuating vision. So you can ask your patient, do you have any blurry vision or fluctuating vision, especially at the end of the day? You can ask a contact lens wearer, for example, do you need to take out your contact lenses before you want to? So there are all these questions that we can ask our patients, and yes, you're going to find a symptom that is associated with Demodex. So back to the study here, Demodex blepharitis can be present in patients who present with chalazium or hordeolum, and the prevalence is 71%. That's highly prevalent. So we do want to be looking for Demodex blepharitis. We do want to be treating it. We do want to be managing it, really to help our patients. So there can be many, many symptoms. Some of them are itching. We can have hyperemia. Other things like the inability to wear makeup, eyes always being red all the time. And there's a poor correlation between the signs and the symptoms of Demodex blepharitis. But we just need to look for collarettes. And it really is quite easy to look for collarettes. You don't even have to use a slit lamp if you don't want to. You can use a lens, like a 20 diopter lens, and you can actually shine a light, you can use a phone, you can use a camera, and you can easily pick up Demodex blepharitis. So it is really helpful. So in my normal slit lamp exam, I have all my patients close their eyes. I have them close their eyes because you can look for things, not only Demodex blepharitis, but other things as well. You can look for lag ophthalmos. You can look for incomplete eyelid seal. You can see other things like scars on their eyelids. It's amazing what you can see with having them close their eyes. Or you could have them look down. You can look down and look for these collarettes. So here are some really nice pictures, and also turning up that magnification. Look down, close your eyes, turn up the mag. So here you can see the difference. The one on the left with the low mag might be a little bit tricky, a little bit tough. The one on the right with the high mag, oh yeah, I can see the collarettes. It's really, really obvious. And those who have Demodex blepharitis often know they have, sleep in their eyes. You can say, oh, do you have sleep in your eyes in the morning? Yep, that's Demodex blepharitis. Also having our patients look down. So here you can see that straight ahead gaze. It's hard to see the collarettes, but if they look down, super easy to see the collarettes. Here are some other things that are associated with Demodex blepharitis. So contact lens wear, but I'm going to show you some other studies coming right up. Rosacea of the face, MGD, glaucoma. Those who are on some sort of dry eye prescription medication. Do you ever have patients who say, oh, I'm on this medication, but it's not really helping, it's not really working. They're kind of frustrated. I see some of you nodding yes, right? And so then we really want to be looking for that non-obvious MGD, pushing on the eyelid, and looking for Demodex blepharitis. So since I do have a special interest in contact lenses, I do want to share Demodex and contact lens wear. So the take-home message from this is that we should be evaluating every single patient who wears contact lenses for Demodex. So here are a few studies. One shows 90% of contact lens wearers have Demodex, and 65% of non-lens wearers. And it might be that the contact lens provides an environment for the Demodex mites to proliferate, and some microorganisms have been found in contact lens wearers. So we also, here's another study, 93% of contact lens wearers have Demodex. So really, Easy, every single patient who wears a contact lens, look for Demodex, diagnose it, treat it, see them back. And that is really going to help with our contact lens retention. And this can be any type of contact lens. It can be a soft contact lens, it could be a scleral lens, it could be a corneal GP or other types of lenses, but Demodex is really, really, really common. Now, this slide, I think it's really important to address Demodex because Demodex negatively impacts quality of life. So impacts driving at night. 47% have difficulty driving at night. The comfort of the eyes, the difficulty wearing makeup, worrying about the eyes, and these are really significant things. So not just for Demodex, I'll share some other things as well. So lotilaner or Xdemvy is an option to treat Demodex blepharitis. It does reduce the collarettes. There are many studies that have been done. There are also studies now looking at MGD, so how it affects MGD, meibomian gland dysfunction. And we know here that 57% of patients with MGD have Demodex blepharitis. And here's kind of a neat video. And this is thanks to Laura Perriman here. And you can see the Demodex mites moving along there. One more study to share about Demodex, and this is looking at cultured bacteria in Demodex blepharitis, again from Askers last week. And this is showing that those who have Demodex blepharitis exhibit a significantly higher prevalence of ocular bacteria or fungal co-infestation compared to control participants. So this is something that's really interesting. So when we are diagnosing and evaluating our patients for Demodex, there could be other comorbid conditions as well. So many learnings. There's so much great information out there and so many more studies that we can do too. So moving along, we're switching gears a little bit and highlighting the TFOS lifestyle report. So these are lifestyle reports. There are many reports. They're with excellent references. And what I take away from these reports, one is that so many different lifestyle factors can influence the ocular surface and contribute to ocular surface disease. But we do need to be aware that things like mental health, obesity, certain recreational drugs can impact the ocular surface in dry eye. We all have those patients who come in and they're taking, say, an oral antihistamine for their ocular symptoms, and they're saying, oh, my eyes are so dry, they're so irritated. Yes, so addressing all sorts of medications, looking at systemic conditions like diabetes, for example. There's so many things that we need to take into consideration, but also our patient's lifestyle. So I feel like I'm stating the obvious here because we all know about digital devices. We all talk to our patients every day about digital devices and taking breaks. But if you look around the world, right, so many people are on digital devices. I can't even believe now, like little tiny babies who have screens in front of them. And I'm sure all of you have seen this. Yeah, some of you are smiling. Is that your little tiny baby? I'm not giving you a hard time at all. I'm just saying that digital device use is really highly prevalent. Many of us have many devices that we use on a day-to-day basis, including our electronic medical records that we're using every single day. Digital device use and dry eye are highly correlated, and so we need to talk to our patients about the devices that they're using and ways to improve that ocular surface. This is kind of an interesting study looking at the cognitive demand and digital device use on the ocular surface. So those who have a really high cognitive task, for in the example, an accountant with little tiny numbers versus a low cognitive task, watching a movie, it's really the task difficulty does contribute to the digital device associated blink rate in those with dry eye disease. So we can remind our patients of the 20-20-20 rule every 20 minutes to look 20 feet away for 20 seconds, blink our eyes. We can also remind our patients and talk to them about appropriate viewing distances. So actually a down gaze of about 10 degrees, blinking exercises, including a humidifier is really helpful. So not just for daytime, but also for nighttime as well. There are different apps you can use to have your patients blink. You can set reminders. There are all sorts of tasks that they can use on their phones. But I think that the humidifiers are really fun, right? You can have a super cute cactus humidifier at work. You can have one at home. And humidifiers have made a huge difference for my patients. And now that I'm talking about this, thinking about no direct air, right? We don't want overhead fans, and there's like direct air blowing on me right now at this moment. We don't want air in the car to be blowing on us as well. That can really dry our eyes out. So talking to our patients about all of these things, it's really helpful. Mask-associated dry eye, I do bring this up because there are still many people who are wearing face masks, and mask-associated dry eye is still prevalent, maybe not as prevalent as it was a few years ago, but we know when the hot air blows into the eyes, it can very much dry that ocular surface. And it has a drying effect that, especially with a poorly fitting face mask. So mask-associated dry eye came up, and there are different strategies. So the strategies that we can inform our patients: taping the top of the mask. We don't want to pull down on the eyelid. We don't want to create anything abnormal. Topical lubrication. I think it's important to talk to our patients about topical lubrication in general, like putting lotion on our hands. We can lubricate our eyes twice a day. We can include daily eyelid hygiene every single day. Limiting time in air conditioning, drinking water, taking breaks on those digital devices, and all of these things can be really, really helpful. So now that I'm thinking about this, we have the air going, we have the wind outside. Any of you feeling dry? Are your eyes dry now? Yeah, I know. I'm like, oh my goodness. Okay, I'm blinking. Everyone blink. Moving on to the next one. So this is ptosis. How many of you actually look for ptosis and diagnose ptosis for your patients? I haven't asked this question for a bit. Okay, so some. This is a really cool video. This is a mother-daughter. And here you can see a change in the eyelid position. So just like presbyopia, we talk to our patients all the time about presbyopia. This is a normal process. It occurs over time. I never, ever like to use the word age or old or anything like that. But look at these two eyelids, right? You can definitely see the ptosis in the mother compared to the daughter. And this is a finding that occurs over time. It is a normal finding, and it's something that is highly, highly prevalent. So we know that ptosis is a lower lying or droopy upper eyelid. I also never ever say droopy with my patients. And it can be unilateral, it can be bilateral, it can be congenital as well. But ptosis can affect the visual field. So that's something we do need to be considerate of. And for some of my patients, I had a patient recently who came in and he had really significant ptosis and also dermatochalasis. And I was talking to him more about safety around driving, making sure that he was able to see everything he wants to see peripherally. He was not concerned about the cosmesis at all. And so we had a long conversation about just things in the periphery that are quite important. But many patients are concerned about the cosmesis, that asymmetric or the sleepy look with ptosis. And congenital ptosis can occur, and with time, right, over time as we age, we can have ptosis that can normally occur as well. We can also have other things, and those things all of you are well aware of. We can have neurological conditions that we need to evaluate and treat immediately. We can have trauma to the eyelid. There can be mechanical changes. But here I'm talking about the aging, normal aging changes. Now, we do want to differentiate between ptosis and dermatochalasis. So dermatochalasis, I always point. I use my hands a lot when I'm talking to my patients. So I always say ptosis is the upper eyelids, dermatochalasis is the skin also on the upper eyelids. And you can even just pull that up on your patients and see if that makes a difference. My patients will say, oh, wow, I can see more. Great. That is fantastic. Here's a patient who is in her 40s who has a ptosis, as you can see. Many different things contribute to ptosis, including contact lenses. So I think years ago, we always thought, oh, it was the corneal GP. It was pulling on that outer lid that caused ptosis. But no, it can be any type of contact lens. It could be a soft contact lens. It could be a scleral lens. It doesn't matter. We know that ocular surgery is something significant, especially cataract surgery with that lid speculum. So if we have a patient who's going to have cataract surgery where the eyelid is going to be open, I'm going to want to have them have cataract surgery first prior to, say, ptosis surgery, because that can affect the outcomes. Ptosis is highly prevalent, and if you look for it and evaluate it, you're going to find it in so many of your patients. Now, again, all of you are very educated. You know the differential diagnosis, and I bring this up because there are other professions that are looking at ptosis, but as eye doctors, you're well aware if someone has Horner's, they have a mild ptosis, they have pupil constriction, eye redness, anhidrosis, you need to evaluate and work that out. If they have myasthenia gravis, if they have CPO, if they have a cranial nerve palsy with ptosis, you are going to evaluate that from a neurological standpoint. You're not going to be concerned about the cosmesis of their eyelid at all. How do you evaluate for ptosis? Well, what we can do is we can check the MRD1. So that's the distance between the center of the pupillary light reflex and the upper eyelid margin with an eye in primary gaze. So a normal range is 4 to 5 millimeters. We can look for the levator function. We can have our patient look up and down. Normal range is 15 millimeters. We can look at that eyelid crease height, and we can do visual field testing. There's really helpful resources having our patients identify their own ptosis. I was with a colleague a few weeks ago, and he said he has so many patients that he sees every single year because of ptosis, like just because of ptosis, and they're coming in every single year to see how they're doing, to evaluate, to check up, to follow up. It's like, wow, that's incredible. But ptosis really does impact wellness and vision. So not just appearance, but the psychological effect. And this was completely heightened during the pandemic when so many things went online and virtual, and people are looking at themselves in the tiny Zoom box, right? And, oh my goodness, my eyelids are droopy. And so surgeries went through the roof at that time, and they're still actually quite high. Ptosis can also impact the quality of vision and physical discomfort, same as having a poorly fit progressive lens, right? We want to make sure it's not affecting our patient's neck or back or irritating them at all in any way. So fortunately, we also have a non-surgical approach for ptosis, and that is Upneek. So Upneek actually works on, it's a direct-acting alpha adrenergic receptor agonist, and it pulls up the upper eyelid. A question that comes up is, well, what if my patient had ptosis repair surgery before? Can I use this product? Yeah, sure. Yep, many of you are nodding. Yeah, sure, it's fine. And it targets receptors in Mueller's muscle. It does wear off over time, and it can be used either unilaterally or bilaterally. So here you can see some different examples, and this is after using Upneek. Now, Upneek currently is prescribed by others outside of the eye space. It has won all the awards. People are aware of it. They know about it. And people might be asking you, or your patients might be asking you in your practice about this option. So, okay, I'm going to pause there and see if we have any questions. I know that's a lot of stuff, but we have a lot more to go. Any questions? Yes.
Is there a correlation between dryness and keratoconus? Because keratoconus has the highest prevalence. Is there in Arizona,
Yeah, ooh, let's talk. So is there a correlation between eye dryness and keratoconus? Yes, so there are many studies that show that in people who have keratoconus, that dry eye is highly prevalent. And we know the prevalence of keratoconus, it's 1 in 223, so it's much more prevalent, 233, than it has been. And we also want to look at the whole allergic component as well, because allergies and inflammation and dryness for everyone can affect that ocular surface. So let's look at meibomian glands now. Who has a meibographer in this room? Okay, yeah. You can have all the fancy toys. You don't have to have all the fancy toys. But we know that the meibomian glands are on the upper and lower lids. If you have a meibographer, it's a super helpful tool to inform and educate our patients. If you don't have a meibographer, that's okay. You can actually use a pen light and evaluate the meibomian glands. So again, looking for non-obvious meibomian gland dysfunction, pushing on that lower lid. And here we're looking for the expression of the meibomian glands. Let's see. Do any of you do expression techniques in your practices? Yeah, it's so satisfying, right? Oh yeah, you see like the toothpaste coming out. Yeah, I love it. Okay, I'm glad I got like 2 smiles. So using a transilluminator is also something that you can use to evaluate meibomian glands. I've also been told you can use your phone to evaluate meibomian glands. I'm not as skilled at that, I'll tell you that. But you can use your transilluminator to look for incomplete eyelid seal, which is a very easy technique. So putting your transilluminator on the upper lid. So this is the core Blackie lid light evaluation, having your patient close their eyes, putting the transilluminator on there and looking for light emitting. And this is actually far more prevalent than we knew about. So this is looking at a study, and 39% of patients said that their eyes felt dry when they woke up, and 53.7% have incomplete eyelid seal. So that's another really important reason to have our patients close their eyes and look for things like incomplete eyelid seal, lagophthalmitis, in addition to Demodex blepharitis, ocular rosacea, etc. So we want to ask our patients, do your eyes feel dry in the morning? Do they feel dry at the end of the day? When do they feel dry? Is it all the time? Is it some of the time? And we have other options. So yes, we have great drops, we have gels, we have ointment, and we also have a newer option called Sleep Tight, Sleep Right, which is a film that goes on the eyes. It's not too sticky, so it doesn't paste the eyelids or lashes shut at all, and the patient can remove it in the morning. They can get it on Amazon or the website, very easy to obtain, and it works very effectively. So what about warm compresses? Warm compresses are a great option. We have a variety of warm compresses now. We have those that are single use. We have those that we can heat up in the microwave. I often have patients who do not have a microwave, and so we have options for that too. And there are so many different wonderful commercial warm compresses that are very effective. So here's just one study. This is looking at contact lens related dry eye. This is using a warm compress once a day or twice a day, showing that most patients have relief of their contact lens associated dry eye using a warm compress 10 minutes, 1 time a day. So talking to our patients about warm compresses, being careful for our patients who have ocular rosacea. We don't want to increase that inflammation there. So what about all these other technologies? We have so many great devices now and different technologies. And what we do need to address is the inflammatory component of dry eye and the obstruction as well. So we know that many play a role. And one thought process is, if we can remove the obstruction, and there are different ways of doing that, if we can improve the MGD, if we can improve the Demodex blepharitis, that's going to be a great starting point to add in another treatment. So for example, we can use a device that can clean up the eyelids and lashes. I always go back to the dental model. It's like the in-office cleaning, and then we can prescribe a medication, say Xdemvy, that's going to help over time. So we do need to really address both. Now, this is looking at, there is a disconnect. It is getting better, which is wonderful. Some believe that obstruction, yes, it's very important, but we we have this opportunity to help our patients with all these different techniques. So one of them that we have in our practice is called new lids, and I believe they're here for our in-office friends out in the exhibit hall. But this is like, again, I call it like a toothbrush for the eyelids, but it is very comfortable, it's very soothing. And here you can see an example, so 1 minute each eye. You can see the example before and after, the improvement that we see here. Now, we also have all sorts of medication options, and I put these studies in here because years ago, we used to use these options over time. Many of your patients might have been on doxycycline or other oral antibiotics for a long time. And here's some studies to share with you, some more recent studies. This is one in looking at 2 studies with 220 participants showing that there's insufficient evidence to draw any meaningful conclusion on the use of oral antibiotics for chronic blepharitis. Here's another study looking at MGD, and this was in the ocular surface. The evidence for lasting improvement after completed treatment is lacking. Now, there are studies showing improvement in a short course of something. So, say azithromycin, using it quickly, yes, that is very helpful. But having a patient on, say, an oral doxycycline for years and years and years, there are also side effects associated with that. Now, what about oral supplements? We all know about the DREAM study that came out showing that there's not any beneficial treatment, but we do want to look at other studies that do show a lot of beneficial treatments for people who have ocular surface disease in general. So we have different options. One option, it includes GLA, and there are many studies looking at this that improves inflammation and inflammatory mediators in dry eye. It does help those who have Sjogren's. It helps those who wear contact lenses, and it is a different formulation. There's also Blink NutriTears, which is not an omega-based product that can be taken orally once a day that can improve the signs and symptoms of dry eye as well. Now, I love all the products and everything that our patients are using. And I will say that I'm bringing this up because many of our patients, and these are not just female patients, I have many male patients who are wearing makeup, who use different products like sunscreen. We do want to be aware of the products that our patients are using. And I always like to ask, how are you taking that off? Right? It is absolutely fine to be using whatever you might be, and how are you removing it? When I brought this up in previous lectures, some people are saying, I don't want to talk to my patients about this. That's okay. You don't have to. You can have a sheet in your practice asking these questions. You can have a staff member asking these questions. But here in the US, we have 12 ingredients that are banned compared to thousands and thousands of ingredients that are banned outside of the US. So there are many, many different products that can really affect the ocular surface. We also want to ask our patients, how often are you disposing of these products? And products could be mascara, they could be eyeliner, they could be all sorts of different products. Now, we have many people who are doing different cosmetic procedures as well. And this is from the TFOS Lifestyle Cosmetic Report. So people who are using eyelash curling or eye dyeing, I always like to ask my patient when they had the procedure as well. Like, was it 20 years ago? Was it last year? Say, tattooing of the eyelids. You kind of get a feel, but then my patients say, oh, wow, you can see that? It's like, yeah, we have a slit lamp. We can see a lot, right? And people are now doing lots of other procedures as well. So really just having these conversations with our patients. And if you don't feel comfortable having the conversation, having a sheet, having a staff member, but it is really, really important because there are many toxins in different cosmetics. And here's a nice list, thanks to Selena McGee, of different things that we can use very safely versus other things that we kind of want to avoid. So the key point, talk to your patient, have some written information if you don't want to have the conversation, and know that yes, there are many good products out there now this year we have even more products, many developed by optometrists and ophthalmologists, not only that can be used for makeup and different cosmetic products, but also different other products that are out there that are so advanced, which is wonderful. Now we're going to talk a little bit about what's new and exciting in the pipeline. Then we're going to talk about some of the options you can share with your patients, and then I'll open it up for any questions. So we've talked about the meibomian glands. We've talked about the importance of them, the hundreds of different lipids in the meibomian glands, and we haven't talked a lot yet about keratin. So have any of you ever looked at your patient, you've looked at their eyelid, and you kind of see the keratin on their lower eyelid? Have any of you removed that? Yeah. Does that help? Oh yeah, it helps tremendously. So currently we could take a spud or any other device and really remove that. And that is a great, easy way to remove obstruction. So you could do that in addition to some of your other tools in the practice. But this is a medication that is not yet FDA approved, and it is coming out in the future, hopefully near future, to really work on the keratin. So we can think of it like dandruff in the hair, keratin on the eyelid margin, and the importance here of restoring, improving the meibomian glands, preventing any loss, especially severe loss that we see in many of our patients. So we know that meibomian gland dysfunction can lead to all of these things, including decreases in meibum, inflammation, corneal scarring, and here we can see the importance of the quality. So this is a medication from the company Azura, and this is focusing on the keratin. Of interest, it's a twice weekly treatment that is done. The studies have already been done and completed. It is a keratolytic to loosen the meibomian gland blockage, and it reduces the keratinization and increasing secretion of the meibomian glands. So again, you don't have to memorize any of these studies, but sharing the latest studies with you, showing that there is an improvement in the meibomian glands yielding liquid secretion. There's an improvement in contact lens comfortable wearing time. There's an improvement in total OSDI, and I'm very excited for this. Again, not FDA approved, it's coming in the future, but as a great option that our patients can use over time. So our contact lens wearers can use, it's a twice a week option. And it is also very safe. So less than 5% of patients are observed with any adverse ocular findings. The trials, again, have been done. It will be going through that FDA approval process, and it'll be another great option that we can use with our patients. So here are some of the, again, not a complete list, but some of the products that are eye safe that we can share with our patients. And what I like to do is just give my patients a whole variety of options. I don't recommend one specific mascara or another because different people like different things. I just give a list, like here are a bunch of good options. You can look into them and see what you think. The Eye Derm is a new product, and that is from Josh Davidson. He's an optometrist that created this. They're patches that help reduce swelling under the eyelids, and it's a really nice new product. Some of you might be familiar with some of the other products. So the We Love Eyes by Dr. Tanya Gill, all of those products, 2020 Beauty, Diane Hillel Campo, Eyes Are the Story, Amy Sullivan. So these are all like great products that you can share with your patients. And again, there are many more. There are even new products that have come out. We also like to inform our patients about different eyewear options. So both daytime options and nighttime options that can help. I can't stress enough talking to our patients about lifestyle when we're talking about the ocular surface. And I know this sounds really basic, but I am going to bring it up. It's hydration. Do you drink enough water? Simple changes in hydration, reducing things like caffeine, although some caffeine is helpful for dry eye, which I'm very happy about, but not too much caffeine, right? So increasing hydration, reducing caffeine, other lifestyle factors. Are you wearing sunglasses outside, a hat outside, breaks on digital devices? I always like to ask my patients how many hours they're on a digital device. Are they taking breaks? And many will say, well, I can take breaks, but I never ever take a break, and sharing those options with our patients. And sometimes also just simply changing oral medications. I can't believe I didn't bring this up until right now. Very Accutane. Accutane will definitely affect that ocular surface, so we want to have comprehensive eye exams prior to starting Accutane and monitoring our patients very closely who are on Accutane, because that can definitely affect the meibomian glands and lead to ocular surface disease. Of course, we have other things as well. So we have intense pulse light. Any of you have IPL in your practices? Any of you refer to a colleague who has IPL? Oh, no. So I want those numbers to increase. So all of you who have IPL, that's great, wonderful. All of you here in this room, you have these great doctors here. Refer to them. I've never had IPL in my practice. I love IPL. It is so incredibly helpful for our patients. And that's something I feel like we don't do enough of in optometry. We don't refer to each other. If you don't fit scleral lenses, it's fine. Please note the indications, refer to a colleague who does. But same for IPL. We have great colleagues in this room, so little encouragement in our break to talk to each other. Find out who's doing these procedures, and you can send your patients for that procedure and see them back for their general eye care. It is a wonderful procedure that we can use. And not only IPL, right? We have many other things, but talk to each other. We have this wonderful opportunity to help our patients, but especially those who have ocular rosacea. We want to be looking for ocular rosacea in every single patient. We want to be looking for rosacea of the face. Oftentimes we're diagnosing that, as we established earlier in this lecture, really helpful for things like Demodex and chalazion as well. So I am going to pause here to answer any questions. Yes. The answers to all the questions. Awesome. So I didn't, the next slide, the question was about what about different skin types and IPL? Oh, okay. Yeah. Oh, yeah, great, wonderful. So patients who have more pigmentation, what is the best way to evaluate for ocular rosacea? Oh, I love it, right? So we can still evaluate for the telangiectasia, and I would say looking at the lower eyelid margin and doing the same thing, so evaluating and looking for the non-obvious MGD, and yes, but excellent point is that we need to look for ocular rosacea in everyone, right? Yes, sure. The next question was about, I love this one too, was about averting the upper lid for meibography. Yes, super important. There's a device that can be used, it's called MyVerter, if you don't feel comfortable using your hands, that can be used to do that as well. And that's helpful in some different populations where it might be tricky. Another option is, of course, using the end of like a Q-tip or a cotton swab. But looking at the upper lids at the meibomian glands is very important. And then there was a third question too. What was the third question? Oh, correlation of fish oil. I don't know the answer. The questions about fish oil and prostate issues, and I don't have a good answer of that. But again, I always learn from these things too, so I will look that one up. Thank you.
Sorry, we have to stay on time. I know you guys have so many questions, but Dr. Burnett
I'll stick around.
Yeah, she'll hang out afterwards. But we're going to roll right into the exciting CE lecture of the day, Dry Eye Jeopardy. I know nothing about it, so Dr. Burnett is going to tell us what the rules are. And Katie and Hannah are going to pass out the buzzers for the in-person people to participate. And we're going to have an interactive, fun CE event and test your knowledge. So take it away, Dr. Barnett.
Okay, awesome. And folks in the back, we're going to help with some sound if possible. If not, it will roll without it. Okay, so we're passing out buzzers. So for our in-person friends, I would like you to kind of, I think we have 4 buzzers going on. So, well, you can put them on a table. So yeah, just pick 4 tables, like 2 on the side, 2 on the side. Who wants a buzzer? Okay, we're having fun. And I'm a very nice Jeopardy host, just to let you know. So I'm same person, same disclosures, all that fun stuff. And here's our rule. So we're going to be placed into teams. So we're going to have kind of 2 sides of the room. Those who want to buzz in, you can also, if you don't have a buzzer, you can just raise your hand. That's absolutely fine. And then the first team selects a category and a dollar amount. Then the judges will read the question out loud, and teams may not buzz in until the question is shown on the screen. The first team to buzz in has 30 seconds to answer the question. Answers will be given in the form of a question, right? Just like Real Jeopardy. And a correct response earns the dollar value, and an incorrect response has 0 points. If no team gets the question right, the last team to answer correctly gets to select the next question. And for final Jeopardy, each team must wager as many points as they would like to risk before hearing the question. Any questions about the questions? We're going to see how this works. Okay, so here we have Jeopardy. We have 5 different categories. There are dry eye diagnosis, and maybe if you can write these down. We have dry eye diagnosis. We have pharmaceuticals, topical medications. We have at-home treatments, in-office treatments, therapeutic contact lens, and innovations. So who would like to choose the first? Well, that is what theoretically should be up there. So again, we have dry eye diagnosis. We have pharmaceuticals, topical medications, at-home treatments, in-office treatments, therapeutic contact lens, and innovations. You're gonna have to shout it out. Okay, so in-office treatments for 200, 400, 600, 800, or 1,000? Okay. So this is I think we're kind of going with the flow here because it's not working as expected. Oh, hold on. Oh, here we go. Okay, here, we're getting there. Okay, the temperature, I love the sound too, thank you so much. The temperature that needs to be achieved in order to melt meibum during thermal pulsation. Go for it. Okay, so it's 42 degrees Celsius, so you get it, totally. Awesome, okay, team back there, what is your next question? From what category? Diagnosis for how much? Ooh, getting risky here. Okay, welcome to the Daily Double. The 3 changes in the structure of the meibomian glands for dry eye disease patients seen on meibography, and then the names of the grading systems used to describe these changes. Some of you, I know you know the answers. Anyone have an answer? Yeah, you can raise your hand, you can shout out, you can do anything you want. Okay, I see you all talking about it back there. Okay, go for it, part of it. Right, great. So you actually got it. So that's wonderful. So you have atrophy, tortuosity, segmentation. Awesome. And then the names of the grading systems used to describe these questions. So let's just help out here as a team. Anyone? Meiboscale, yep. I think I heard tortuosity out there. The Leo segmentation scale. Great job, team. Okay, so again, really friendly game here. Okay, so going on to, we're gonna, maybe one of you pick another group to ask a question, that'd be great. Okay, you guys up front, you get to choose a category and a dollar amount. Yeah, all of you. For 400, new innovations for 400. So I love how actually the prior lecture, I was giving you all the answers to all the questions in this one. Rapoxalab's mechanism of action. Okay, Jeopardy music, please.
And just for the online people, you can participate by putting in your answer in the chat box.
Awesome, yeah. You're all welcome to play our game. Okay, well, I'll answer this. I'll answer this one. It's what is a RASP inhibitor? Yeah. Okay, going back. And yes, online friends, answer in the chat. It'll be fun. You all win prizes, all of you. So, okay, so let's go to this group up here. You get to pick a category and a dollar amount. Okay, we have at-home treatments for 400. The new dry eye supplement that does not contain omega-3 fatty acids. I heard it. Awesome, you're right. Blink NutriTears, good job. So, oh, you guys are awesome. You are so awesome. This is great. Okay, so this group in the back gets to choose the next category and dollar amount. Oh my gosh, you're going right to 1,000 with therapeutic contact lens? Wow. Okay, these 3 properties that make the HyperSeal unique. This is a tough one. We can go back to 200 on the contact lens, you know? Be a lot easier. I think this is one of the most difficult ones in the whole game. Okay, I think I'll answer this one. So this is a tough one because this is maybe something none of us have seen. But what are the shape of the lens captures and holds the therapeutic eye drop against the cornea. The lens protects the eye, acting as a buffer from the eyelid and allowing for better healing. And the lens can be on the eye for 7 nights and extended wear for up to another 7 days prior to removal. Okay, that group is risky there in the back. How about we give you another chance? Oh. Wow. Okay, diagnosis for 1,000. Let's go for it. So the name of the tier-based test that helps differentiate dry eyes versus ocular allergy. Okay, I heard the buzzer. Wait, was that a buzzer just for fun? This is also another really tough one. Okay, so this is what is TPOC from Versailles. And so this looks at what is the cause of dry eye, is it aqueous deficient or evaporative dry eye, and is there an allergic component? And then the second part of the question is what are IgE and lactoferrin? I don't know, guys, do we want to give this team a little break here in the back and we can go for some easier questions and answers maybe? Okay, team 2. Oh, good, you have numbers. Team 2. I don't know what front table, front center.
At-home treatments for 200.
Okay, at-home treatments for 200. This preservative found in artificial tears can worsen dry eye. Ooh. Oh, that was fantastic. Right. What is BAK? Yes, BAK can be very drying to the ocular surface. Wonderful. Okay, team. I don't know what your number you are, but that team, you get to choose. Okay, here we go. Okay, topical medications for 200. The newest topical cyclosporine drop to treat dry eye, the way it is different from other drops. Okay, team, go for it. Exactly, form of a question. What is Vivi? Wonderful. And the way that it is different? It stays on the ocular surface longer, spreads easier, has better tolerability, and is water-free, all in the form of a question. Okay. Okay, so now we're going way back here. And how about a different team? Why don't you guys choose a different team? Yep. Okay, so we have at-home treatments for, oh, I believe we've done this. You get to choose another one. Okay, let's do that. At-home treatments for 600. So according to the 2023 TFOS Lifestyle Report, this type of diet is best for dry eye. Yes. You got it. Awesome. What is the Mediterranean diet? Good job. So if you look up, this is something fun and interesting. So if you look up diet and dry eye, I encourage you to do that. You'll find thousands and thousands and thousands of studies on this. But you're exactly right that according to the lifestyle report, it's the Mediterranean diet. But if you look at different studies, there are every diet that you've seen out there, there is some study in how it relates to dry eye. But I think guidance from a lot of these studies are to increase hydration, fruits and vegetables, reduce fatty food, but the Mediterranean diet. Good job. I am impressed. Okay, team in the front, you get to choose the next one. I know it's tough. There's so many good ones, right? Okay, contact lens 400. Bandage contact lenses can prevent this type of ocular surgery, and these are types of FDA-approved bandage contact lenses. You can name 2 of them that are FDA-approved. Jeopardy music, please. You can even answer half of the question. Oh, yes, go for it. Yeah, okay, great. So the first one, yes, so any sort of penetrating keratoplasty or tarsorrhaphy, really anything, that's fantastic. And yes, so the FDA approved ones, we have AccuView Oasis, Pure Vision, Air Optics Night and Day, and the Unilens lens. So good job, team. I will give that to you, and you get to ask the next question. You want to stay in the contact lens theme, or you want to go for something else? Okay, might you want to choose another one like 200, 600, or 800? 600. Okay, let's go for it. 3 goals of therapeutic scleral lenses for dry eye patients. Oh, I see your buzzer. Go for it. Yep. Okay, so we have improving dry eye, improving refractive outcomes. I would love to give the same question to another group as well. So think of a scleral lens, right? It's going to bathe the ocular surface. Anything under the lens, it will protect, right? Giving you hints. So mechanical protection of that ocular surface. What else happens when yeah, go for it. Yeah, so a scleral lens can improve corneal health. It can prevent a persistent epithelial defect. That's, yeah. And continuous hydration. What you said is also correct. So awesome job, team. Very, very good. And we can use scleral lenses as drug delivery devices as well. So we can put different medications in the bowl of the lens. There are multiple studies showing the benefits there. And then we can also use other types of lenses for drug delivery that there have been so many different studies. And currently, the one that was FDA approved is not being distributed at this time. Here in the US and other countries like Canada, it is. Okay, team, do we want to stay on the contact lens? Do we want to move to something else? Kind of anyone gets to choose the next category. New innovations for 600. Let's do it. ST100, currently in phase 3 clinical trials, helps to heal the corneal surface using this mechanism. Jeopardy music, please. Again, this is just such a tough one. I appreciate that answer. This is just a hard one, right? So it uses the polycol technology, which mimics amino acid sequences that are found in collagen to help remodel damaged collagen in the cornea. So kind of the remodeling part was part of it. So good job there. Yeah, that's a tough one, but good. Okay, so now, but why don't you ask your table? You can choose the next category. Do you want to stay in innovations? Do you want to move to something else? Diagnosis for 200, 400, or 600? Okay, dry eye diagnosis for 200. Here we go. The approximate number of people in the US that have Demodex blepharitis. You're kind of close, a little lower than 38 million. Oh, a little higher than 24, but I'm going to give that to you. 25 million, whoever said that. Good job. Good job. Okay, so you definitely get to ask, and it's somewhere over there. I don't know exactly who said it, but you get to ask the next question. Good job there. Yep. Okay. I think, yeah. So no, I actually think that, here, we're gonna do, oh, goodness. Okay, but do you know what 200 is? I have it here. The condition, dry eye diagnosis 200, the condition that commonly presents with eyelid telangiectasia. Oh, yeah, what is ocular rosacea? Good job, team. Yep, you all got it. That was super quick, too. Okay, what about the middle table over here? Why don't you get to choose or all of you want to? Perfect, you all get to choose the next one. Okay, let's just double check that. Topical medications for 800. Okay. According to the URSA phase 2A study, besides Demodex blepharitis, TP03 may also be helpful for this ocular condition. Yes. Exactly right. Good. What is my meibomian gland dysfunction? Okay, team, you get to choose the next one. Correct. We actually have all but 200. So you should not perform IPL treatment on this Fitzpatrick skin type number. Yep. Yeah, so good job. So what is type 6? Excellent job. So you get to choose the next one. That would be debated. Yep. Oh, sorry. So sorry for the virtual folks. So what about 5? What about 6? Yeah. So 6 for sure, possibly 5. Yep. Okay, team, you get to choose back there. Do you want to stay with the in-office treatments? Do you want to go to something else? The diagnosis, we have the 600. Let's do it. Okay. And then we're actually done with the diagnosis. So dry eye diagnosis for 600. 2 examples of non-invasive dry eye imaging tests. Great. So what are non-invasive tear breakup time and meibography? Extra credit for the whole team, everyone. What are some extra things that can be done? Tear meniscus, sure. Yes. What about non-invasive tear breakup time? What about blink patterns? What about ocular injection? Do any of you have these technologies, the non-invasive technologies? Yeah, super helpful, right? And I find that I really like the ocular injection, the redness. You can use these, and they're just wonderful educational tools for our patients. Okay, everyone, so dry eye diagnosis is completed as an entire category. So now we still have topical medications, we have at-home treatments, in-office treatments, therapeutic contact lens, and new innovations. How about picking a group that has not been able to participate? Way in the back, okay. Okay, team, you're up. So it's kind of anything besides dry eye diagnosis.
And Dr. Burnett, can you just repeat what they're selecting, and then if someone answers, can you repeat what they answered so the virtual people can
Yes.
hear?
Oh, yes, yes. Thank you. Thank you. So okay. So topical for 1,000. So the newest topical, we've actually done this. So the newest topical cyclosporin drop to treat dry eye. So that one is taken. So we have topical medications for 200, 400, or 600 left. Okay, so topical medications for 600. And this is Synergimin, is the only FDA-approved eye drop used to treat this condition and the way the above condition is diagnosed. Yes, up here. Great. So the answer to this is what is oxervate, and the other is corneal sensitivity testing. So excellent job, team. And neurotrophic keratitis. So let's talk a little bit about corneal sensitivity testing and NK. So NK, neurotrophic keratitis, highly, highly prevalent, especially in those who have any sort of condition like diabetes, those who have any past history of ocular surgery, and that can be any surgery. So that could be cataract surgery, it could be refractive surgery, it could be a corneal transplant, retina surgery, glaucoma surgery. And so we do want to be evaluating for NK really in all of our patients. And the way to do that is to check corneal sensitivity. So we can check corneal sensitivity in a variety of ways. One is using a cotton wisp. Very important not to introduce any bacteria. So we want to either wear gloves, have a clean instrument to actually pull that cotton wisp when checking for corneal sensitivity. We can also use dental floss, which is very helpful because dental floss, just regular dental floss, non-minty, non-cinnamon dental floss, it can be a very prescribed length, and we can check corneal sensitivity in that way. We can also use an instrument like a crochet bonnet. We can also blow air onto the cornea, but always having on your differential NK, always having on your differential to check corneal sensitivity and prior to any anesthetic going in the eye. So yes, it's fine to have fluorescein, and we can look for diffuse keratitis versus inferior keratitis. But I think once you start checking for NK, you're really going to see it. So that is my ask to you tomorrow when you go back to clinic. Check corneal sensitivity in your first 10 patients and really get familiar with it. The next question that always comes up is which eye to do first, the affected eye or the non-infected eye. Really, it's up to you. I like to do the eye that I think is non-affected, so the more normal eye first, and then check the eye that I think has NK. But it doesn't matter. Checking both eyes. And then the other question is, where do I check this? Do I check all over the cornea or in one specific area? Definitely checking each eye, but you can check in the area that is the most affected. So for example, that has the most corneal staining in that certain area of the eye. So good job, team. You get to ask the next question. Okay, contact lenses. So we're back to contact lenses. We're not doing 1,000. We have 2 or 800. Oh, contact lenses for 800. So name 3 FDA-approved scleral lens application and disinfection solutions. Jeopardy music, please. Some of you in this room fit scleral lenses. This is an easy one. Okay, yes. Okay, so yes, so this is both application and disinfection solutions. So some application solutions, Sclerofill, Lacropure, Vibrant View, Tangible Fill. Some disinfection solutions, Clear Care, Tangible Clean, Unique pH, Boston Simplus. Awesome. I think we're gonna just finish up this contact lens category because then we have that all set and we have contact lenses for 200. These types of soft contact lenses are used for ocular disease. This is an easy one. Okay, go for it. Excellent. What are bandage contact lenses? Yay. We don't use bandage contact lenses enough, in my opinion. And then we also always need a prophylactic antibiotic when we're using soft bandage contact lenses. Okay, so now we have pharmaceutical, topical medications, at-home treatments, and in-office treatments. Topical for 400? Okay, let's do it. The first-in-class medication, FDA approved to treat evaporative dry eye, and the amount of time it stays on the ocular surface in an animal model that we just talked about. Yeah, go for it. Yep. So yeah, you're close. You're close. So what is MIBO is the first, and what is 4 to 6 hours? So I'm definitely going to give that one to you. Okay, you get to ask the next one. So we're on, I know exactly, what are we on? Pharmaceutical, topical medication. We have 200 and 600 left if you want to stay in that category. Okay, so 200. Oh, no, yes. So I'm going to read it to you. The first-in-class drug that is FDA approved to treat Demodex blepharitis and the drug's mechanism of action. You can even answer half of it. Awesome. I heard what is XDEMVY shouted all over the room. And I heard the mechanism of action, that it paralyzes the mites, right? And through GABA-gated chlorine channels. Good job, everyone. I think that we're going to just move on to the 600 and the pharmaceutical. Topical. Okay. We're done. We're done with the pharmaceutical category. Okay, we're moving on to the at-home treatments and in-office treatments. So we do have at-home treatments 600, 800, and 1,000, and in-office 600, 800, and 1,000. You get to pick the team to ask the question. Dr. Wu gets to ask the question. You're selected. So at-home treatments or in-office treatments for 600, 800, or 1,000. We also have some innovations too. In-office treatments for 600. Okay, the skin temperature that should be achieved when doing RF, and the skin temperature where you run the risk of fat volume loss around the eyelids when doing RF. Go for it.
What is 41 degrees to achieve? And 45 degrees is when you start losing fat.
Okay, so we're extremely close, so I'm going to give it to you. So what is 40 to 42 degrees Celsius? So yeah, so 41 counts. And then what is 43 degrees Celsius and above? So you definitely get that and get to, good job, good job. And so you get to ask the next question. So we have in-office treatments, 800, 1,000 are some options. In-office for 800. You can do low-level light therapy treatments on these Fitzpatrick skin types. Awesome, you're right. What is all of them is correct. Yay! Okay, so moving on to, how about 1,000? We'll just finish up that category. What is Tixel? Jeopardy music, please. Yep, go for it. Oh my goodness. So this is the solution. So the device that uses tiny pyramid-shaped tips at a very high heat to create little tiny microscopic thermal injuries to the lid to stimulate collagen and elastin and improve meibomian gland function. Okay, yeah, it's kind of a neat tool. There are studies also that support its effectiveness. Okay, so we have at-home treatments, just a few left, and we do have a few left of innovations as well. Okay, I like at home for 600. And that is, oh, I'm sorry, we've already done that. And how about 800? Perfect. At home for 800. 3 recommendations for healthy ocular cosmetic eye makeup wear. Oh, no, go for it. Yeah, you can add 1. That's fine. Okay. Okay, this is great. Yes, so applying makeup not on the waterline. Perfect. Removing makeup before bedtime. What about not sharing makeup? And what about replacing makeup, right? Anything liquid about every 3 months. Awesome. Okay, so we have at home, and we're going to just finish up the category of at home with 1,000. This is the newest treatment option for lag ophthalmos incomplete eyelid seal. Yes. Awesome. What is sleep tight, sleep right? That was a very quick answer. Wonderful. Very, very good. Okay, so now we have a few, yeah, you're exactly right. Thanks for keeping me on track. We have a few innovations. So we have 200, 800, and 1,000. We have 200. Okay. New innovations for 200. This new device uses, oh, no. The rules are you have to wait. The new device uses 10 cc of saline to remove dirt, debris, and inflammatory agents from underneath the upper lid. Buzz again. Very good. What is Rinsada? I love the enthusiasm for that one. So